also need to know, at least take a decision on whether to refer or keep and manage the exams. So Prakash is obviously one of the best visual surgeons in Kerala, if not in India, and he is extensively trained in retina, and these are his credentials. So he'll be the lead discussion Prakash. As a panelist, we have Dr. Anand Rajendran. Again, see, whenever you see him discuss, he is one person who gives real practical solutions to any of the problems. That is one reason why I thought he would be one of the best persons to be a panelist and discussant in this session. Next, please. And Piyush Bansal. I mean, he's like my younger brother, and he's a very dynamic veterinary surgeon, extensively trained in LV Prasad, and he's presently a member of the scientific committee of all the Ophthalmological Society. He'll also be joining online. Next. And we have Nikhil, veterinary surgeon from our own member from Jyoti Sai. Nikhil, please. And Saurav is a second veterinary surgeon from Jyoti Sai, and these two boys are doing an extremely high volume work in Jyoti Sai. Thank you for being here. So this is, and we have our own, my colleague, Dr. Simi Manoj Kumar. She's a dynamic retina person from Thalassery, PKI Care. So I request Prakash to take over and start the session.
Good morning all. So we are having a panel discussion based on the theme set by Dr. Srini, what next in ophthalmology. So we are starting from the back of the eye and the diseases. As more and more practicing ophthalmologists are doing thorough indirect ophthalmoscopy, 1978 examination, you are seeing more and more lesions, and many times you are confused whether you have to refer this patient or whether you can manage those patients yourself. So we are trying to do this discussion. The aim is like we are trying to answer those doubts or queries where you have to refer, where you need an urgent treatment for the patient so that the patient doesn't lose the vision. So it can be very interactive. We are going to be very interactive. We have a fantastic panel. We have Dr. Piyush and Dr. Anand joining us online. Welcome Dr. Piyush and Dr. Anand. Can you hear us? Is it on a screen? Yeah, Anand. Hi. So we can go back to the presentation. Yeah, Anand, are you muted?
No, I'm muted. Can you hear me?
Yeah. Thank you, Anand, for being with us.
Screen.
Yeah,
okay. Somebody's screen sharing.
Okay.
Yeah, fine. Perfect.
And Piyush, Dr. Piyush, are you there? Yes, okay. So we have Anand with us and we have a fantastic panel here. So we'll start the session. As I told, the aim is to just briefly go through confusing situations. So everybody from the audience also can join us in this discussion, and if you have any queries, you can always ask me to stop and then you can ask also. Or at the end also we can have discussion. It's not moving. Yeah, full screen is not okay. You can have it. Only thing I need the control of. I will ask you. Okay, this is okay. Next slide.
Next slide. Next slide. Aaki vechittu ningal connect cheyyum. Appo at least adinte pole discussion nadukkanam. Even next slide aaki.
Meanwhile, I'll ask the audience, what is the most like challenging situation you face in your daily practice as far as retina is concerned?
Photos.
Yeah. So we have a that is coming up. Next slide, please. Okay, so next slide. Again, so diabetic retinopathy, as we all know, we are all aware of diabetic retinopathy, the challenges involved in it. And we know whenever we have a center-involved macular edema, you have to treat it with intravitreal injections, and when it is a center-threatening macular edema, probably if there are leaking macular nephron, you might consider doing a focal laser to those lesions. And if it is no macular edema, you continue to follow up with these patients regularly. So the biggest challenge comes when you have a cataract and a patient is having, you are not able to assess the macula with a 78, you don't know whether it is thickened or not, and you see some hard exudates, you see some reddish lesions. So this is a very common situation which we all face. So whether we directly take up this case for cataract surgery or not. So I will start with Dr. Simi. So, Simi, how will you go about such a case when you have such a issue?
As we all know, doing cataract surgery in a diabetic patient can always be some diabetic retinopathy if it is not properly controlled. So, if the patient has got diabetic retinal edema, initially you treat the diabetic retinal edema and then proceed for cataract surgery. And if the vision is too poor with the dense cataract, and if you can't make out it with nosity, it is better to combine the intravitreal injection along with the cataract surgery.
Okay, that's a very clear answer. And so, Dr. Saurav, like, what is your choice of webinar? Do you combine your cataract surgery with intravitreal drugs? And if you combine, what is your choice of drug? You have any specific?
Basically, it depends on the edema. For all diabetics, I would like to do an OCT before planning cataract. That has been my practice for last one and a half years.
Do you do an FFA?
FFA,
because
not
view is
necessarily.
hazy, so you want to roll out.
No, whatever details I can get from an OCT, that's fine for me. And if there is some center involving edema, I will probably consider a injection with the cataract. Otherwise, I will just explain the GVP to the patient and need for retinal treatment post cataract surgery.
You are not able to assess with OCT. OCT is also not good enough. Then in that situation, you are seeing some clinically, you are seeing some lesions. Will you go ahead with an intravitreal injection?
I will reassess after cataract.
Yeah, so you can actually treat those patients. Any difference of opinion, Dr. Nikhil, or?
No, I was usually combining with the cataract surgery injection, but nowadays the insurances have making practice that you have to separate these practices. Like all insurances are like you have to
It can't be billed as a single procedure.
It can be billed as a separate one procedure. So nowadays
for a paying patient, for a non-insurance patient, will you prefer
combine.
So what is your drug of choice at that time? Do you give anti-VEGF or steroid? Which is your preference?
Depending upon the edema, if it is chronic, I can shift to steroids. Otherwise, it's acute recent edema. I use always prefer antibiotics.
Okay, so it is only the edema, chronic or acute, that decides which drug you are using. And we'll have one final word from Dr. Anand.
Unshare it.
Yeah. So
This is a simple.
can you hear me?
Yeah.
Unshare.
Yeah. Another practice here is to treat the macular edema first with anti-VEGF, preferably. And if there is if the OCT shows a lot of subretinal fluid, Even then, the evidence shows that you could go with anti-VEGF first because you don't want, IOP to shoot up because of that. 1 month later, just, maybe a few weeks after you've done your cataract surgery. Also, if God forbid, the patient develops some infection, you don't want a steroid hanging inside for a long time. So our preference is go with anti-VEGF, get the edema down, and then go in for cataract surgery. That said, if there is a minimal amount of edema and the patient understands that, and you talk to your patient and your patient would like to keep both together, then you can definitely combine cataract surgery with an anti-VEGF agent. So that's my first go. Yeah.
Okay, so we can take home that we usually, if it is accessible, we will go ahead cataract as not an emergency. We will go ahead with treating the macular edema till we get maximum suppression of the edema. Then you tackle the cataract and explain the patient if there is a worsening, then we may have to give injections again. So clearly explain the prognosis to the patient, the possibility of worsening, so that you don't have a disappointed patient. And Anand, do you have any criteria? Do you feel glycemic control in the perioperative period helps in controlling prevents worsening of macular edema? Is there any evidence on that?
Yes, absolutely. I think that is critical, not just for controlling, macular edema issue, but also importantly infection. So that's our primary concern. We want our patients to be in a safe situation. So the glycemic control, of course, it's an ongoing thing for life for anti-macular edema. But more importantly, since we're doing a major invasive procedure like cataract surgery, we want to get it down. Our usual target is fasting 150 and random 200 about. But by and large, I like to see fastings down to 120. That's my target. I can stretch it to 120 with no issues. So that's what I want. And of course, there's no doubt that we need to keep the patient good, strong glycemic control.
Okay, and do you have any prophylactic NSAIDs, any role for prophylactic NSAIDs? Does it differ from your routine? Of course, we all use NSAIDs to prevent CME. So in DME, do you feel you have to have a different protocol for using NSAIDs, something like starting early or something like that?
So if the macula is flat, then the patient is going in for cataract surgery. I do not recommend starting every patient on prophylactic NSAIDs. So I will see the patient again 2 weeks later. I'm just saying case patient A where you have flat macula to begin with. But if you don't have these little interretinal fluid cysts, the patient is diabetic, then maybe you can start the patient on topical NSAIDs and explain to them that there may be an upswing of the macular edema. In that case, Difenac is what I usually prefer. Romfenac also is equally fine.
Excellent. So post-operatively, there is a recurrence of diabetic macular edema. There is macular edema which was not there before cataract surgery, and this patient is having diabetic retinopathy change. So we are all confused whether this is pseudophakic CME that is happening, or whether it is a diabetic macular edema worsening. So Dr. Nikhil, what is how do you differentiate? What is your plan of evaluation of such a patient?
We look for self-flare and anti-histamine. After this, usually after the course of steroids tapering down, if the CME and self-flare happens, this can be post-operative CME. And otherwise, we look for the control of the blood sugars, and the control is well, then edema is increasing, and we can do an FFA and differentiation between DME and also CME post-operative.
Dr. Saurabh, sir, just add on to differentiate.
Post-operative CME, when we see an OCT, those cysts will be more towards the vitreous side, because those prostaglandin and the inflammatory mediators come from anterior to posterior, and those cysts are generally towards the vitreous. Whereas in diabetic edema, they will be uniformly dispersed in the mid-retinal areas. You can have all these, hard exudates and all these things which are absent in post-op CME. Also in OCT, we may appreciate cells in the vitreous, which again goes towards diagnosis of post-op CME, and they respond very well to topical steroid and NSAID combination.
So what is your protocol of treating a pseudophakic CME?
I will go conservatively, 4 weeks of topical steroid and NSAID combination. If it's still persisting, I will give a PST or an IV.
So any tips on, like, do you do an angiography regularly for diagnosing pseudophakic CME, and if told you do, what are the like points you will look for in angiography?
Angiography generally no. Directly you will see in OCT only. It's better and non-invasive. You can go to diagnosis.
So, in the pseudophakic CME, the treatment protocol is different from diabetic macular edema, so it is essential we identify what is the cause and treat accordingly. So, if at all you do an angiography, you will see a hot disk associated with the angiographic CME, which tells you this is Levin gas syndrome, and that is a pseudophakic CME, whereas you will be seeing more of leaking microaneurysms in a case of diabetic maculopathy.
What should be the protocol for NSAID use perioperatively in cataracts?
What I use is one diabetic patients I prefer to start at least 1 week before NSAID and continue for 1 month post-operative period.
1 month is good enough, or you extend it further? Because
no, it depends. I feel if in your center you are seeing more of pseudophakic series, you can continue it in 2 or 3 months. But otherwise, we usually continue for 1 month is good. Because I think
classically probably the CME appears 3 months.
Correct.
So is there even routinely is it okay if you continue? It's rather stinging this thing and all. It is comfortable. Is it Dr. Anand?
Yeah, so I agree that's the issue with the stinging sensation is not as all a pleasant experience to have long-term NSAIDs on. So if you think that edema is not coming down with 1 month of topical NSAIDs, that's the issue with stinging sensation is not at all cystoid macular edema and there's an upshoot. Then my go-to is first given an intravitreal injection. Because I think nothing controls or gets it down as well as an injection, intravitreal injection. I'm saying this, there is an increase. You can see that the central macular edema is increasing and there is a drop of vision. Then I would speak to the patient and it is shown to work. The other option is to go for PST. But there is always, for me, PST and steroids, there is always also the issue of intraocular pressure rise. So that's one negative there. But if there is a lot of subretinal, and we are talking about diabetic patients who developing pseudophakic CME. I think we're talking about that. That is so then that is an option. But for me, first was intravitreal anti-VEGF rather than a long course of topical NSAIDs.
What if a patient is on NSAIDs, develops CME, is on NSAIDs, and the patient develops like the first thing is topical NSAIDs. The patient is on NSAIDs and develops, and you give intravitreal steroids.
Intravitreal steroids?
Yeah. No. The patient is on topical NSAIDs. Okay. On topical NSAIDs, he develops pseudophakic cystoid macular edema.
Okay, so in that case, let's say surgery is happening and one month down the line, there is an upshoot of pseudophakic CME, and let's say patient is 6'9", patient is good, but the patient is not happy, then I will also add on topical steroids if they were not there initially. So I'll put the patient on intensive topical steroids, and very importantly, as well as the panel has mentioned, look clearly to see if there is any even cells 1+, because that will strengthen my decision to go in for topical steroids as an additional act with the NSAIDs. So I'll first put the patient, let's say, from month 1 to month 2 on a course of taking topical steroids with NSAIDs. Invariably, this helps. Invariably, it comes down. But in the instance that suppose glycemic control is not good or it's worsening and the macular edema is increasing, that is a situation where I will go for intravitreal. And let's say 6'9" goes down to 6'12", then for me, that's my limited tolerance. At the end of the second month, or somewhere in the second month, I will go for an active injection.
Yeah, well taken. Two things like pseudophakic CME can happen anytime. Like I have seen a patient who developed after 6 years of cataract surgery, so it can happen anytime. second, so always keep that point because it's a very it does not, and one more thing is it does not cause vision loss very most of the time. Vision recovers even if you treat it after 3 months, 4 months also. So it's one of the best, has the best prognosis. And third thing is intensive topic. Most of the cases respond to intensive topical steroids and NSAIDs. 95% of the cases respond, and 1 month at least use non-tapering dose of topical steroids 4 times a day, and then only next second month only taper steroids. So that helps in most of these cases.
And then one more thing, like you doing hand caps can also cause like pseudophilips we have seen 2 or 3 cases like developing CSC after 5 or 10 years, and then a history of hand caps like they then put on
Yeah. So next slide, please. For want of time, we'll go ahead. Go back. Yeah, now from coming from macular edema to proliferative diabetic retinopathy, I'll ask Dr. Srini, like what are the risks involved in you feel there is a proliferative diabetic retinopathy, or not able to use satisfactory laser because of the dense cataract. So what is your protocol in managing such a case?
Initially if it is possible to do laser, then better to do a full laser. If it is not possible, you can you should always do a DE scan. It's a dense cataract, you can do a DE scan to handle which is and if it's not if there is any hemorrhage or signs in India, better to get an intravitreal anti-VEGF before doing the cataract surgery. Especially if the patient has got some NVA or something, you should leave the intravitreal anti-VEGF and do the cataract surgery as a second procedure, or you can combine it because the chances as well as the period can increase with cataract surgery.
Dr. Saurabh, do you have any change in protocol, or you will follow the same?
I will get a cataract surgery done, re-evaluate,
and try to do it laser as well. Okay, so the main risk is like you can have a vitreous hemorrhage. Sometimes you can have a NVI, especially if you have a complicated cataract surgery. So you have to be watchful for kind of ambiosis post-operative in these cases. Sudden worsening of diabetic retinopathy can happen after cataract surgery. And this is again one more common problem. We see a patient with minimal changes in the fundus. So, and you advise cataract surgery for this patient because there is a cataract. But what are the clues, like the featureless retina? Many times, some about 10-20% of the cases don't have, especially at the posterior pole, you don't see many diabetic changes. And when you look at after the cataract surgery, the patient develops ambiosis and other issues. So, how do you prevent this, and what are the clues that you will use, Dr. Nikhil, identifying a featureless retina, suspecting a featureless retina, and doing an angiography in such a case?
We can see sclerosed vessels. If you scan the retina with 90 or 20 with the indirect ophthalmoscopy or with the slit lamp examination, we see new vessels or sclerosed vessels, we should suspect for PDR and do angiography evaluation before going to cataract surgery.
Dr. Anand, you have anything to add on this?
Yeah, couple of things. First, because for the patient with the cataract and vitreous hemorrhage, then I think it's important, as Dr. Shiva said, to do a scan. Also assess whether there are focal traction points. So vitreous hemorrhage can be mild, haze out there, or it can be fairly dense and can have focal traction. If there is focal traction, then I will not give an anti-VEGF, because that can worsen. You can have a PRD going down the line. Okay, so that is one thing. And I will, then of course, for the patient, there are 2 causes of loss of vision. The cataract and the vitreous hemorrhage. Get the cataract done, and then see the minimal moderate hemorrhage. See if I post-op I can positioning do some LILs. That's the first go-to. Otherwise, of course, as you mentioned, there is an EI, then you have to do anti-VEGF, and then a week later cataract surgery. Otherwise, it is moderate to severe vitreous hemorrhage, then I will even do combined procedure of cataract plus vitrectomy straight away to get the thing done. So that's one. Second thing is about featureless retina. By definition, featureless retina is proliferative diabetic retinopathy, not not showing the features because think that the hemorrhage is gone. So the one clue for me would be a lot of unusual amount of multiple spots, which will tell me that this is a very ischemic retinal AD, and then that is an indication for doing fluorescein angiogram. And even when you do fluorescein angiogram, take care to get the peripheries also imaged. Yeah, and that's an urgent indication for PR.
Yeah, so it's Anand is very clear. If you have a PDR, mild hemorrhage, you do a cataract surgery and try to complete the laser. If it's severe hemorrhage, we take up for vitrectomy. Otherwise, if you have a rubeosis, you can probably combine with an anti-VEGF injection. But anti-VEGF injection always carries a risk of crunch syndrome because we cannot assess what is in the postal segment. So suddenly, the fibrovascular switch that can happen can lead to sudden traction detachment development. So you have to be careful. So if at all you can, if there is no NVM, it's always better to do a cataract surgery, reassess the fundus and complete the PR. And featureless retina also we have to go to the next. And pseudophakic CME we have already covered. I think we'll go next. So we have been many times these are cataract surgery surprises we all have. So after the surgery, patient is very unhappy. There is no improvement in vision or there is some drop in vision, VMP, macula, all these things are the major. So do you have anything to suggest like how before in the pre-op evaluation for a cataract surgery? How do you avoid these surprises, Dr. Sabra?
Try to see the macula properly before advising cataract. And if there is any doubt, we can consider an OCT. That would be my advice.
A double foveal reflex could be a clue that we are having something at the fovea in this case, or a white dot that is seen at the fovea might suggest there is some problem. So in those cases, it's always better to do an OCT in those cases if it is possible. And you want to add something?
This is the visual effect. If the cataract is not corresponding to the fundus findings, you have to do an OCT and find out if there is macula or some other lesions causing those lesions.
We used to use potential accelerometer and all, but I think nowadays nobody is using those. So this is again one very common scenario Dr. Saurav has pointed out. Like we see many patients after cataract surgery having lateral ectasia, and so this is something many times missed by general practitioner because of the lack of awareness about lateral ectasia. So Dr. Simi, what are the clues like ventricular fundus picture that will tell you there is a hiding lateral ectasia in this patient, and what stage you expect? How will you explain the prognosis of this before cataract surgery in the patient?
Before cataract surgery, if you can see a hyperpigmented spot or RP vision goes to the hard exudates like without an undivided patient, you see hard exudates at the fovea or small microaneurysms at the fovea. You have to do the OCT and decide. And if you see an OCT picture with the features such as macula disease, you should explain to the patient the prognosis and follow the patient after cataract surgery with frequent OCTs and see if any edema is developed, and only you treat the vision issues.
Dr. Anand, do you want to add something on this?
I think the most important thing, as you mentioned, is the biometric examination, key index, all diabetics. Macula usually develops in diabetics, so since we're talking about diabetics, this can happen. The right angle dipping of the vessels, those hyperpigmented plaques, that little pallor, especially temporally, these are giveaways. On the OCT, that ILM drape sign, those irregular gaps, cystoid light spaces, all these are clues. And certainly since a lot of cataracts going in from premium IOS nowadays, any discrepancy in the vision, that should signal that you should do an OCT and look for all these signs. Once you see it, then of course, like as Dr. Sumi mentioned, you need to follow them up. First of all, talk to them. This is the reason you have that disease in ophthalmology there, which is degenerative. It's not inflammatory. So we need to see there's only that much that can be done. And of course, later down the line, if this is there, then you have to watch out for secondary CNVs or hemorrhages.
Yeah, so the point is well taken. If you have that white dots like or a graying of the temporal retina or small pigments or telangiectatic vessels, you suspect a macula. And if you do an OCT, if you see an outer layer defect right under the fovea or there is pigmentation, usually it affects that stage when it affects the vision. So in those patients, usually 612 to 618 or 624 vision is what we expect. So this you can explain to the patient before doing surgery, and it doesn't end after surgery. You have to make the patient aware that they can develop CNVM later, and the follow-up with ampsillary is very important in these patients. So coming to dry AMD, so we see many times drusen here and there, which we call as dry AMD. So what is the criteria? Like, I think the antioxidants are the most misused drugs I feel, and many times patients are because almost there is no antioxidant drug which is less than 50 rupees. So it is actually a financial burden to the patient when you start the patient on antioxidant. So what are the criteria, Dr. Saurav, that you will use for starting a dry AMD patient on? The main aim of starting an prophylactic antioxidant is to prevent them getting converted to wet AMD. So what is the criteria that you use in your practice?
Basically, it depends on the affordability, as you have mentioned. I mean, if they are affording, I would like to give an antioxidant. But again, its frequency I change according to the patient's economic status. Maybe not daily, alternate days, alternate months, like that. I change it, and frequent follow-up to see the fundus, how it's changing through time.
Dr. Anand is a worldwide expert on AMD, so we'll also hear from him.
So like you mentioned, there's just too many antioxidants out there in the market, and as you know. So what I would rather suggest is just a good healthy diet, drinking rich carotenoids for the most. If you see based on the kind that you showed in the slide there, follow the other two formulations and prescribe the patient. But you have to believe that this is not a magic drug going to go away, and you are just a lot of times things don't just take dietary supplementations. So that is, of course, schedule your visits accordingly. Show the patient, show the several deposits, and then let them know when the patient is compromised with this. And then, of course, follow.
So as per the criteria, if you have an intermediate AMD or above in both eyes, or if the patient has lost one eye due to CNVM and he has dry AMD, these are clear-cut indications where you need a lifelong prophylaxis and according to the right dosage. So most of the commercially available drugs will have to use 2 per day, lifelong, at least 2 tablets a day. So that will be around 36 rupees, I think, for the cheapest drug. So that's very important. So next slide. So coming to when do you suspect conversion to wet AMD, how do you suspect, and how do you ask these patients to monitor themselves? So many times dry AMD does not require referral to a retina specialist. How do you follow up these patients, Dr. Nikhil?
Teach them an home access chart, ask to look from individual close eyes, and which in a month or twice weekly you have to monitor his visual activity, and there is cataract, you have to advise about cataract surgery to get a visual fundus removal also. Also I monitor.
If the patient has that reasonable vision and suddenly the patient complains of dimness of vision or sudden onset of retinopathy or macropsia, you have to think of the possibility of try getting converted to wet AMD.
So you can complete one OCT and identify if there is presence of fluid. So metamorphopsia is the most biggest warning symptom, and it's important you teach the patient how to use a home ampsillary and regularly use it. That's very important so that you can prevent this, early detect this complication. You cannot prevent it, but you can detect it early so that it doesn't cause severe vision loss. And question to Dr. Semi, do you do always in your AMD with AMD, once you see a hemorrhage of the macula, exudate or SRF subretinal fluid, you know there is a conversion to wet AMD. So do you always, is OCT good enough? Because many practitioners have only OCT at their disposal. So is it good enough to treat most cases, or do you have any indications where we always do an anti-bias surgery?
Usually the OCT is clearly suggested for CNVM. I don't usually go for if it is if you have a doubt regarding if it is a CNVM or a night CNVM, I think if you doubt of polyps and better to go for surgery.
Dr. Anand, your opinion also on this?
Yeah, so I almost never do an FFA nowadays. The OCT, the current generation is giving the moderate Occasionally, most of them come in with OCT angiography, and you can get reasonable clue. But largely, it's physical examination, then the structural OCT, which is enough in almost 90% of the cases. The only place where I might, consider dye-based angiography is if I want to differentiate it from PCB. And again, there are good enough clues on structural OCT itself. But so if I see a fatty choroid and I think it is, it could be PCB, and I may consider. That is one thing. Other thing is, I think it's coming up in your discussions, just to distinguish it from myopic CA. I think if there's a lacquer crack there and some occlusals also, it's clearly myopic. Then in that case, I might use a fluorescein angiogram. Almost never. The real indication for FFA was maybe 10, 15 years ago when you wanted to consider doing PDT for ABC and DMs, whether it's minimally classic or not. So that was really the time when you really needed a lot of angiography. And that was the time when OCTs were not of very high quality. But today, I think almost 90% of the time you can manage just structural OCT with and without OCT.
Thank you. So only we need a structural OCT, even PCB can be diagnosed based on that with accuracy. You can have the slide. And maybe when you have a mimicker or a non-transponder, then you might consider so that you want to make sure you haven't missed any other mimicking lesion. That is the only time probably you will do a angiography. And what are the other causes of macula? So whenever you see a hemorrhage at the macula, usually practitioner is worried. So what are the causes? What are the serious or what are the intervention requiring conditions that you can have a macular hemorrhage? Dr. Yeah, so these are some of the common causes. So many of them are treatable. So for Simi, how will you manage a vulvar retinopathy?
Can wait and can spontaneously can if it is you can even try laser highlighter, or if it is not successful, anti-VEGF and pneumatic displacement.
And for the retinal artery macroaneurysm, RAM with bleed, subretinal submacular bleed, what is your choice of treatment?
Submacular usually anti-VEGF.
With pneumatic displacement, so we may have anti-VEGF may not have much effect on RAM, but it is always important. If there is a dense submacular hemorrhage which vision significantly affected, then it is better to do a pneumatic displacement. And usually the hemorrhagic version of hemorrhage in a RAM is the end of its life, so it usually gets thrombosed after that. So usually don't get need for a laser, but in an X-ray tube type of RAM, where you see hard X-rays, maybe you can get focal laser to the RAM. And this is one common, this is becoming more and more common nowadays, and this is like an elderly patient who comes to you, then you examine the patient in direct ophthalmology. You see these kind of small hemorrhages in the periphery, sometimes associated with exudation, then there is a lot of peripheral fluids. And so, what is your, how do you assess and what are the risks involved in these cases, Dr. Nikhil?
This EHCR when I was practicing Coimbatore and other centers, the incidence of PHCR was not that much. When now I go for a vitrectomy for vitreous hemorrhage, I should take it as a daily. Otherwise, I'll end up. Some cases are so extensive that the patient may lose even if you treat that. So some kind of very alarming situation. Sometimes I cannot treat the patient. If I inject also, there is extensive bleed and it causes vision loss of the patient. And you have to suspect this kind of there is erosions in the periphery and this kind of small hemorrhages.
Yeah, so small hemorrhages are the warning sign in the periphery. In an elderly patient, if you see small hemorrhages, if they are looking subretinal, then of course it is most of the time in a non-diabetic senile patient, especially ladies. If you see this, then it's a very big alarming sign because they can suddenly lose their vision by massive subretinal hemorrhage. So it is always better to treat. Many times it is possible to treat these cases after doing an IC. You have Anand, how will you manage these cases? What is your protocol in managing the peripheral exudative hemorrhagic coagulopathy?
So, I mean, if two situations, one during a vitrectomy, the patient is coming in the vitreous hemorrhage, and the patient is non-diabetic, like you mentioned, and that's when when you're doing ultrasonograph, we scan look in the peripheries also to see if there are these bumps showing up. So that's then you need to be careful, because sometimes these patients, as manage your infusion, sometimes they can develop CDs during your vitrectomy. So that is just an outlier, but that needs to be done. And if they are flat, then you can even just add a gentle laser to those areas. Also, sometimes the other eye gives you a clue. Sometimes you can have PCD in the other eye, or even extramacular PEDs. So that should raise a warning flag that this vitreous hemorrhage may be associated with a PCD or a peripheral PCD or a PENCR lesion. So that is one thing. But on the other hand, if you're seeing a patient in OPD and the patient has come and has these lesions shown in his eye, then I think you have to tell the patient that stress good anti-hypertensive control. Very often are hypertensive, so that needs to be kept under control. And if there is any exudation fluid, then one may even consider anti-VEGF, but not if the macula is clean. So it's just that systemic control of triggering factors needs to be contained.
Do you ask to them to stop antiplatelets?
No, because these are they've been there for a reason, life-threatening issues, cardiac issues. So I don't strongly suggest that, because it can be any trigger, any rise of hypertension or BP upshoot, which can trigger this. It's probably not right for us to stop cardiac equation.
Thank you. So you have to be aware of this condition, and many times a laser or a cryo to lesions will help prevent that such a drastic complication. And the PVD will come directly to the floater. So what are the pros? Like we have, if you have to, every patient, most of the patients that come to your OPD will have a floater. So when do you decide, like, what are the warning signs that tell you this floater could be associated with a retinal tear or can be disposed to a retinal detachment? So what are the warning signs in a floater that you have to, or you refer, or you have to do a thorough indirect examination? Dr. Sauravan, what is your view?
A recent onset floater associated with flashes.
Yeah, that is one very important. It has to be a recent onset floater.
Then see for the anterior vitreous, that is on slit just behind the lens. If you can appreciate some RBCs or pigments, then you should be doing a thorough indirect. And recently this PHCR VH has also come into my mind as a DD.
So if you have a PVD associated with a vitreous hemorrhage, a line, if you see a line of hemorrhage along the lower limit of the PVD when you do an indirect ophthalmoscopy, and or you see these signs, then always you have to double check the fundus, because you might have missed a retinal tear, or if you still you are not good at endoscopy, better to refer to a retinal surgeon, because a tear which is barrage can make a lot of difference to the patient, because once RDW vision is never going to be the same, and patient does not require major surgery. So, but otherwise, if floaters which have been the patient have been moving around for 6 months, 1 year, floaters usually doesn't require, and most of the without vitreous hemorrhage also chance of having a tear is little less. So this is again coming continuation to that. If you have a vitreous hemorrhage in a patient who is not diabetic and other eye is perfectly normal, sudden onset vitreous hemorrhage, how will you evaluate and what are your take on it, Dr. Nikhil?
First we will look clinically, we can see any lesions in the tears in the periphery, and do an FB scan. We cannot usually appreciate this tear if it is not that large. We cannot appreciate in FB scan also, and we can read if assess the patient clinically, diabetic, hypertensive, or other comorbidities, and look for other causes of vitreous hemorrhage. Then if you have sure for is a PVD-induced vitreous hemorrhage, do a B scan, and there is no blood detachment, call the patient, give a headache procedure, and call the patient after weeks. explain the patient, you might be going for a cataract surgery at that point of time. Then ask the patient and assess for integration after that. Then do a laser.
Dr. Anand?
I agree with what you mentioned. I think if you have a sudden onset TB, then sudden onset is important, and if the patient is bit of a watcher, if he has distorted flashes of multicolored flashes of light or a sudden spark of black spots or photos, then I think a very careful, meticulous, indirect ophthalmoscopic examination with scleral indentation may be required, and it should be referred to somebody who will do that. Also to look at while doing this for lattice also, because if that is there, then we would like to shorten the review. As a rule of thumb, generally for anybody who comes with a decent onset photoid lens, we will say passing photography will come in a month later. But if you see a lot of lattices or the other eye has had an detachment, then you want to follow a little more closely. If the other eye has had an detachment in an extreme case, so then you might even consider a barrage of the lattices that are there, because you know this patient is predisposed to that situation. So that's an extreme situation. But otherwise, by and large, depending on the condition of the periphery, you would like to see them either 2 weeks or 4 weeks down the line for a sudden onset PBD. That's
Timmy, you want to add?
Usually, in case of the patients in quarters, you will only have the PBD advising, and usually you tell the patient if there is an increase in the size of the number of photos, or there is increase in flashes of light, or if there is dimness of vision or any shadows coming in front of the eye, you should come immediately. Otherwise, just PBD alone will ask the patient also.
So if you have a vitreous hemorrhage, a careful bead scan is one of the most important things, because it will tell you, like, if you see multiple attachments of PVD, then it could be a PRPO or something which has bled. If you see a tear like this, sometimes if you do a careful examination, many times you will be able to see a flap tear in bead scan. So if it is a PVD induced bead scan, always look for this sign. If it is present, you don't wait for long with these patients, because they might develop retinal detachment. And you also look at the macula, whether there is a mount defect there, then it can break through, be it from a CNVM or a TCC. So all these, please be careful. This scan is very useful in all cases of vitreous hemorrhage where you don't see the fundus. Always a scan is a must. And coming to CSR is one of the most irritating things for a ophthalmologist. So the patient also is irritated, you are also irritated. So how do you, like, what are your tips, like, for example, ophthalmologist, if you see a subretinal fluid at the macula, so what are your differential diagnosis other than CSR or other conditions? Are you worried about if you see a subretinal fluid? Patient comes with central scotoma, there is a subretinal fluid like this.
Actually, as you mentioned, it's a little bit headache kind of thing. Basically, first time presenting CSR, I will just ask him to observe for 1 month. I will definitely try to rule out the precipitating factors like work-related stress, poor sleep hygiene, or night activities or night club, something like that. I will ask him to switch. And if it's persisting vision drop after 1 month, if it's not resolved, I will go for an FFA for a definitive treatment.
Yeah, Dr. Anand, like, do you do routinely a fundus autofluorescence in this case and look for chronicity, so that you may have to, if there is a sign of chronicity, you want to refer something like that?
Yeah, so almost good clinical microscopic examination should in most cases be enough. But of course, when you see this in the baseline, you should do an OCT. Alongside that, I always like to get an oral pulse, because it tells us quite a bit about the disease. You pick up a mild teardrop tract also, suggesting that this is not chronic, but at least it's a recurrent disease. We know it's recurrent, so it's acute on-tic situation. So that also will help follow up this patient. One important history is some history of steroid use or any other homeopathic medication which as we know very often has some form of steroids alongside, or any kind of facial cleansing or dermatological cleansing. So that is very important, because a lot of them, or if they are on steroids for any other reason like meningitis or whatever. So that history is very important. Apart from all the others, sleep disturbance and stress. So So we know this is associated type of surgery. So the history is fairly important. Three, four things you need to ask for. You need to tell them that they need to maintain better biorhythms, avoid any steroid injuries, and then of course see them after a month and follow up with structural CT and fluorescence. I also like to use multiple imaging into an optometer. So sometimes you may have a creeping hypervascularity seen out there. But by and large, this is enough for acute CSCS.
And once you decide to treat, you require a treatment, what is your choice? Like we don't have a treatment for season, so like what is your plan of action in such a case?
Yeah, so of course, if you're treating it, you need to identify the needs and then you need to obviously fluorescein 2 months down the line. The classic expectation used to be 3 months, but I think in this day and age, people don't want to sit around with CSRs, and especially if it's not resolving, showing any signs of resolution. Then I'd of course like to do a fluorescein angiogram. I usually like to do FFA with ICG because we know the disease has roots in the thyroid. It's a serous correlation of as it's now called. So I like to do both. Just to get that baseline. If you don't have an ICG, it's okay. It's something maybe enough. Identify the lean spots, and if it is if it's just extrafoveal, I won't think twice. Because extrafoveal will just do the focal laser. If it's subfoveal, that's an issue. We have micropulse laser, and I like using it and seeing very good results for CSCS with micropulse pressure.
What's your take on Ocular? That is the only option we have as far as chronic CSR is concerned. So what is your take on it and how safe is it?
Sure. So the focal laser I was talking about acute CSCS. For chronic CSCS, two options. We don't have PTT now. If it's extramacular leaks, then transpupillary chemotherapy is an option, the red laser. But if not, then it's a very sick RP, you see this very mortal, massive hyperflow cells, and I know it's chronic CSR, just looking at it, you know it's chronic CSR. Very often it's very diffuse. Then in such situations, I apply it on as helped. And I need to put the patient, we need to monitor regularly the serum pressure in this patient. I have not had a great experience in all cases, but some cases I know it has.
Okay, so Simi, what are like mimickers, what are subretinal fluid, what are other causes that you should be aware of, and how do you rule out these conditions? So that you can safely observe the patient. So as far as in CSR it is not going to cause a sudden open vision or non-open vision, but there are conditions which can.
Subretinal fluid, ventilating, PCC, then take this with SR PEDs, then PCC diabetes, then chronic inflammations like uveitis can cause subretinal fluid, leakage.
Simi has got a very important differential diagnosis, that's optic disc maculopathy. So, Dr. Anand, what is your protocol for treating optics? Because it's a condition which has a good treatment. So, what do you do, Dr. Anand?
So, again, depends on the vision. So, if it's, you can have this, importantly, like to start from clinical examination, look for the disc, for that grayish depression on the optic disc, and very often even the OCT will give you there will be a skytic edema taking off towards between the fovea and the disc to give you that clue that this is an optic disc that you're dealing with. Earlier we used to do laser around the disc, but I don't like that specifically because that's a degenerative and kind of damaging to papilla, and it's one-time treatment, it's an irreversible treatment. So if it is increasing, and for me the top line is 618. If it's 618 and lower, optic disc with significant serous macular detachment, and I will advise surgery and gas. Secondly, if it's very chronic and very large, it fits with other coronary anomalies, sometimes I will look for a scleral blood draft onto the characteristics.
Yeah, so this is the same thing we also do vitrectomy with plugging the which has got very good anatomic resolution. Size improves by 1 year or 6 months in most of the cases. But vision depends on how long it has been there, vision recovery depends on that. But at least we can prevent further drop in vision in that patient. So that is one thing which has always been all case of SR look for a pituitary present, and as Dr. Anand showed, very close on OCT, that will help you. So slide please. And retinal vein occlusion, this is again one more thing I have seen many times. So yesterday also actually a cardiologist called me. I have been referred by a ophthalmologist with a retinal vein occlusion. My friend called me and asked what am I supposed to do in this case. So that's a big thing. I think we are not very clear about how we evaluate a case of retinal vein occlusion. Can you, Dr. Simi, can you throw some light on how do you go about working on the case of retinal vein occlusion, whether branches and retinal vein occlusion?
Especially if it is examination and facility, you have to definitely do cardiac causes, hypertension, diabetes, dyslipidemia, then vasculitis, other systemic conditions like that can cause venous occlusion, SLE, other trial symptoms like SLE, proteins, protein deficiency, like that you have to note down.
So in young patients below 50 with non-systemic risk factors, you do a thrombophilia workup. That is because it's a thrombotic disorder, embolic disorder. The thrombotic disorder, so there is no much role for a cardiac echo or a cardiac doctor, but it's actually a thrombophilia workup. And if you suspect a vasculitis, in rare cases there are clinical clues to this vasculitis, you have to do a vasculitic workup.
There's a car number KL13AQ8956. അത് വീടിൻ്റെ ഗേറ്റിന് മുമ്പിൽ പാർക്ക് ചെയ്തിരിക്കുന്നു. ആ കീ തരുവാണെങ്കിൽ മാറ്റാം. KL13AQ8956.
Okay, so for a patient who is older patient with risk factors or even without risk factors, there is no role for a workup because you are not going to find any risk factor in those patients because age is the biggest risk factor for CRP. The age gives damage to the at the disc, at the prelaminar, at the lamellar close, the vessel damage happens, venous damage, endothelial damage happens due to repeated flow of the optic disc itself is a predisposing cause in most of the cases. So there is no workup required in all cases. That is one thing I want to. And coming to CRAO again, many times when you come, it comes as an emergency. So what is your protocol of managing a CRAO that is adequately referred in time within say 12 hours it has come to Dr.
I'll do a bone massage first, then look for any this on plaques and try to dislodge with thing. I do probably even time, so I can do AC paralysis to reduce the intraocular pressure. All just do, and I give a reference to cardiologist to look for other options in heart this thing, and do a carotid Doppler or internal carotid options.
Simi, Dr. Simi.
Usually after doing all that, I will refer to the cardiologist and suggest to give a local time. Few patients have shown good results. Even one patient came in 6 hours, got his basic vision to give normal weight.
Yeah. So Dr. Anand, do you have any opinion on that? Because I have heard from Dr. Simi many times that when long molecular weight heparin actually helps in many of these cases of CRO. Do you have any similar experience?
Yeah, I've had patients who have improved with heparin. Also, another drug for cardiologist was pentoxifillin. This is thinner, and it basically comes from treatment of strokes, where again this is used IV or oral. So some cardiologists like using that too. But by and large, various studies have shown that if a CRA is going to, it's usually a spontaneous thing. That the non-patient usually is largely spontaneous, largely down to patient in that sense. But these emergency missions have to be instituted during massage, AC paralysis, or kind of all these surgery. It's an emergency.
So in any case of CRO, it is like if it presents right in time, it is important that we attempt to dislodge the emboli to the peripheral artery so that some amount of vision can be spared. We don't know whether it is scientifically correct or not because anyway, we have all of us, I'm sure, will have at least one case experience where it has improved the vision. We don't know whether it was spontaneous or manual. And one more thing is I've seen a lot of cases nowadays, giant cell arteritis causing CRAO. So are there any clues, Anand, because that is one thing, we have had a patient who presented with CRAO in one eye, and then another within a month she presented with CRAO in the other eye. Actually the cause was giant cell arteritis, and that was very much preventable if we had detected it in time and started the patient on high dose steroids. So can do you have any clues which will tell you clinically or otherwise, or do you have to evaluate every patient of CRAO with the SR and CRP? What is your take on that? Dr. Anand? Dr. Sundeep?
Sorry.
So do you have to see, we feel a few cases, it is not maybe 10% or less cases with the giant cell arteritis causing CRAO. So are there any clinical clues or something that tell you this could be a GCA causing, because we are going to prevent the other eye from developing similar episodes if we start, if we detect GCA?
Yeah, so I mean, again, this is a very rare situation. I think sometimes we will report sheathing of vessels can be seen. That is there, then maybe you can pick that up. But by and large, just I mean, it's a very sudden thing, it's very severe thing. In such cases, yes, you can consider adding any CRPT test. But the primary management will not talk.
Usually it occurs over the age of 50 again, and patient presents in pain and tenderness, the temporal arteritis, and high suspicion if the CSR is high, and temporal biopsy confirms this.
And another sign is most of the time GCAs affect the ciliary circulation, so you cannot have a typical picture of CRAO without a cherry spot. The absence of cherry spot, again, in a patient above 70 or 80 years of age developing with no known cardiac or anything developing a CRAO, always this should be at the back of your mind, and if the patient especially complains of headache and if you have a temporal tenderness, because that can prevent the other eye. I have at least two patients who have had the same issue. So that is to be back of your mind when you see a case of CRAO. And coming to epiretinal membrane, so many times we see when a patient is coming for cataract surgery has a rippling of the retina instead of a macropathy. So do you have to, what is your take, Dr. Nikhil, do you have to always combine your surgery with an epiretinal membrane, or are there any criteria where you will do only the cataract surgery and think of doing epiretinal membrane later?
I usually used to combine the surgeries, but nowadays I do the cataract surgery first and assess the patient after 1 month. And if he or she still complains metamorphosis or problems, and if it is vision is less than 6 or 6, 8, 9, I usually take for surgery.
Dr. Anand, your take on this?
Yeah, so I think it all depends on the visual acuity. If you see with the cataract, there is a significant glare, and of course your OCT also shows a fairly significant glare. And again, from this, the cutoff is 680 and lower. In that case, I would suggest to combine procedure for patients, and they will be really happy with just this. Also importantly is along the vision, also the patient's mobility. Really sick patient, vision is 6 I will definitely just look at cataract surgery and then observe. But if it is significant, then I think going ahead and combine procedure when the patient.
Okay, thank you. So metamorphosis could be a symptom that will tell you that the ERM is causing affecting the visual acuity, not just the cataract. So that may be a case where you can do a cataract surgery along with it. Or else the OCT shows significant changes like field changes and significant inner retinal changes, real changes. If they are seen on the OCT, then you may have to think of doing a ERM along with ERM surgery along with the cataract surgery. And what are the mimickers? We can have sometimes mimickers for which if you take up for surgery you can have very bad results. So these are some of the mimickers like a combined hamartoma, especially in a children child. If you see an epiretinal membrane, always think of a possibility of hamartoma lesion, because it's very unlikely for children to have an epiretinal membrane. And coming to myopia again, myopic CNVM, Dr. Saurav, how do you suspect and how do you confirm and how different is your management compared to normal AMD?
patients with the high myopia, they specifically have the symptoms of seeing a black spot in front of the eye. When, even though they may be having a best visual acuity of around 636, 660, still they will appreciate that drop in vision. That is how they present. Then OCT
How
and
does the presentation differ from routine AMD?
you can't appreciate those basically that SRF or large amount of hemorrhages may not be appreciable, but still a small tinge of bleed which was not there previously, that will suggest towards development of a new CNV. Then an OCT will throw light into the diagnosis, even Opta will add in the coming to the diagnosis, and they respond very well to antibiotic. That is one good thing about myopic CNV.
Anand, do you have to add something on this? Because
Yeah, as I mentioned, like first of all, the background image of myopia would be very clear. Very often you will see that clearly there is lesion in the myopic disc. All that will tell you lack of fluorescence. Again, there is no something which is non-EME kind of vision. It happens suddenly. It happens in young patients also. So that's an important differential for the CNV and the young patient, especially myopic. And then I think very often, quite often, the Opta will also show you that network, and then it's fairly easy. But like I mentioned earlier, this is one place where if you wish to, it's a young epilepsy patient with unblocked vision, you're telling them putting an anti-VEGF injection, which as mentioned, is very good response in myopic CNVs. Doing an FFA can show them that this is why you have this. Also, we know that lateral tract bleeds can lead to this, and for them you don't need to intervene. Very often spontaneously they will go. So for yourself also to make the diagnosis, this is because of CNVM, and not a reason treated to breakout response to CNVM lateral tract. Fluorescein antibody can contribute here.
thank you. Right. So this is one thing which you have to always, any myope comes with a even a certain vision drop or certain vision complaint, careful examination, because it is not very prominent like an AMD CNV. You don't see large stars or exudation, so you have to carefully look at small gray tissue on the retina, or a small hemorrhage could be the only clue that there is a CNV, and if treated in time, because it is not, treatment is very easy because with the 1 or 2 injection it goes away, patient saves vision. But if you don't treat it, it causes a permanent drop in vision for the patient, and develops a pigmented spot. So again, one more condition, like when a high myopia with isolated fundus macular evaluation is always difficult. So if you have a decreased vision, so what is your protocol, Dr. Nikhil? What is your protocol like in a patient? When do you suspect a myopic traction maculopathy, and you do anything about? Can you do anything about it?
There is a vision, acute vision loss. I do if the macula is not accessible, but the fundus 90-day examination, usually do take an OCT, and for the management part it is very challenging. We have to combine the macrobiology PPD, so we should see the visual acuity associated with cataract, and macula buccal cells are available nowadays, so it's very difficult to take management.
Yeah, so any patient with this kind of fundus, very isolated fundus, it's always better to do an OCT, because clinically it may be very difficult to pick up, and especially if the patient down eye has already been lost due to advanced atrophy. So these cases, it is very important you do an OCT and revisit and follow up these patients closely. Dr. Anand, what is your surgical plan for such a case?
So I think this is one of the most challenging situations in macular surgeries, because it's difficult sometimes. Myopic tract activity sitting inside the scapula, it's a tough thing, and the actual pathology, apart from the traction of the vitreous, is also the outgoing of the sclera. This is a scleral depression, which ideally speaking, macular buccal should help. We know the macular buccals are not available. There's a lot of paucity. Yeah.
And nowadays actually macular has again come back to market. Divine Eye Care in Delhi is giving macular. If anybody interested, I can give the number. We have ordered also.
Okay, that's a great thing. So otherwise, Vijayaraghavan eye cleaning and long-term and gas is usual.
So you do a 4 years sparing eye cleaning?
Yes, very good. Thank you for highlighting that. We are sparing getting. That's very important because otherwise you can one can always argue that even if you create a macro hole, you're doing the treatment for the macro hole by the eye anyway. But still, the other you are sparing.
Do we have time, Srini? Yeah. No, I am coming to that. I think the PCO. Next slide. So we have that. Okay. So this is to not only PCO, just doing cataract surgery in myopic, high myopic eye. What are the precautions do you take, Dr. Saurabh? What are doing a capsulectomy as well as
Specifically in a myopic eye, I will see for indirect and peripheral lesions. I would do laser mode before doing even cataract or even YAC. Even if the laser is not complete, I will call them after cataract surgery and complete the laser. These people tend to have that TVD much more earlier than the routine population. So having a tear or developing an IDs is a little bit more common than this.
Why I wanted to discuss it, you have a PCO there. You have, I mean, obviously PCO, would you consider going in and polishing the PC
surgically?
For a path panel? No. Well, you can go through even the hydrophobic IOLs you can actually, easily do it. And polish the PC. Would that be safer from the retina standpoint, or just going inside and doing it again? Would it be? I mean, I'm just thinking about the retina part. Would it be riskier? Which one? You have an option of going in and polishing, or do a yak capsule. Because when every time you see patient with high myopia, everything is laser. You have whatever as Saurav said, everything is laser. But would it be better if you go in and polish the PC?
I think this is a Yorker. I will take Anand to face this ball. Anand.
Yeah, so the thing is, what we usually do is well, laser control. Yes, I agree. Yes, you said it's a very high that's already, let's say, partially barrage tears are there. Not trying to complete that. And then the first thing is to get a single consultant to do that yak capsule of me. But we very clearly mentioned few shots, minimal power. Few shots, minimal power, because sometimes it just blasts indiscriminately. So just few shots, sometimes you get lucky, you're able to just create that whole kind of opening, and that very often helps. So that is also for just that much. The main issue is not to disturb the anterior space. So if a person can do that yak capsule skillfully enough with just the most minimal power, that is what I would do ideally. I'm not sure how much.
I would ask JK sir.
I'm not sure how going again under the IOL and polishing. If that helps, I'm not sure how much we should.
Polishing is not a good idea. We used to do it, but most of the cases, almost 100% is coming back within 2-3 years. So the polishing, the basic pathology we are not addressing. So why it happened, that it will repeat. It will come back. I did at least 4-5 cases polishing, but within 2-3 years, almost same PCO. Another thing is what we observed in myopia cases. They clear everything retinas as indirect. Then we do then they come after 6 weeks or 2 months after. Then you see a giant gap somewhere. So it's very important after doing the at least for 1 year, we have to follow them every 3 months.
Yeah, that is a very, very important point.
Before fine. But after
yeah, even without a predisposing lesion, even without a lattice, in any case of myopia can end up with general tear or multiple retinal tears of reactive as well as cataract. So it's very important that we follow up this patient, make them aware of the symptoms of retinal tear so that they seek immediate attention for treatment. So that is very, very important. So thank you sir for that. Very, very important. Slide. And sir, Anand, do you suggest still doing laser barrage or lattices before LASIK surgery? Because now
In
we
the
are not
earlier
using.
days, yeah, that's what I was coming to. In the earlier days, when they had the first generation LASIK, they used to have the vacuum lifting up and then the pressures, huge amount of vacuum up to 60, 90 millimeters. I think we used to export. In such cases, our protocol used to be to do laser barrage for the lattices. But in the current generation, I think the way the light and stuff, no, we don't definitely do until if the real strong indications for doing it would be if there's a definite detachment or a tear significant in the fellow eye, then we would. Or of course, we see a hot shot therapy would. If there are multiple holes in lattices, then we won't. So these are indications for doing it. Otherwise, we don't. Every lattice we certainly don't advise barrage 360 or localized for every lesion. But we do definitely ask them for follow-up at least a month after the LASIK. That we do, yes.
Yeah, so with current thing, do other panelists agree, or do you do any of you do still all lattices?
We ask for symptoms, if it is symptomatic, for the treatment, asking for the IO protocol of the lattices is good. If there is lattices with symptoms, if the patient has symptoms, we will go for a barrage and do LASIK, and you can always follow the patient and make aware the patient of the symptoms of RV and do a frequent follow-up.
So we can, if we assume that if there are indications due to retinal reasons like symptomatic BVD or a family history of RD or other IRD, then we do lattices. Otherwise, it's not essential to do even those LASIK. So the risks involved are very less. So slide. We have more slides. Are there any subgroups who are the subgroups like the higher risk of developing RD in especially in myopia? Okay, so I think we will come to that. So the subgroups are like patients who have a retroretinal degeneration like Vijayaraghavan and Marfan's. These are patients who are higher risk than even just having a myopia. So these patients have to be very careful again on the preoperative follow-up, and this should be very important. I think with that we will come to the end of this panel discussion. If we have any audience have any other questions, we can feel free to ask. We can discuss. Yeah. Can you pass a mic?
My question is regarding prior to giving posterior subtenon steroid injection or intravitreal IUD, don't we have to look if the patient is a steroid responder with giving a topical trial prednisolone drops? Because once we have put in the steroids, it's going to stay there.
Probably the patient would have had steroids in the post-operative period.
Okay.
So if at all their response was weak, it would have been developed by that time.
Okay.
So we directly don't go for a PSK. It's after a substantial amount of topical steroids only we will make a plan to give a PSK.
Okay, so do you routinely do a steroid check for any steroid response if you are planning to give PST or IUD?
If basically patient is steroid responder and he needs a IVD, I mean a steroid, deposteroid, I will prefer to give him an IVD because at any time, if at all it has to be removed, we can easily remove it. Otherwise, the PSK may not be that comfortable.
Thank you.
So PSK, sir. Jain Thomas, sir.
I had a patient with chronic neck pain for the last 4 years, and the vision was not quite well, and she was on chronic blindness, straight pain. Then yesterday she got central serous choroidopathy. Is there any relationship between the papilledema and this?
Anand, are you there?
Yeah.
Is there a
So I don't think there's a relationship between diamox therapy and CSCR. Obviously, I don't think the patient should have been steroids, right? Patient is not on steroids.
No, it's not. I'm not therapy and CSCR. It's chronic
benign intracranial hypertension and CSR, is there, do they have a relation?
No, only thing is one needs to see if the serous detachment was tailing off and there was some connection between the macula and the test. So sometimes aggravated, this we see with malignant hypertension, papilledema secondary to hypertensive causes. So if that is there, then we have seen situations where the disc edema, the serous detachment, peripapillary SRF tails into the macula. So sometimes that is, mistaken. Again, that's another differential for CSCR. So that could be a reason, an aggravation of the basic pathology, which is tailing over to the macula. But and sometimes that is associated with mental star or fan. But usually you do not see that. Usually there is if it is that, it's secondary. But an isolated CSCR as a complication of benign intracranial hypertension takes it. Also, one would actually have to look for if there is pachychoroid. So sometimes that may be a confounding coincidental.
Yeah, both could be separate entities, or probably it could be a spillover from the disc, that edema. So probably a BH scan to look for a optic nerve sheath widening or a positive 30-degree tested out on effect. So probably whether it is from the disc that it's coming.
Thank you.
Any of the panel say focal VMT, there is a very minimal VMT, there is no fovea is in the normal contour. On inner retina is already affected, the fovea is lifted up and outer retina is intact, there is no detachment and you have a dull scan. What is your take, Dr. Nikhil or
We'll wind up.
Yeah. I think with this last question we'll wind up. Thank you all. Thank you Dr. Anand for being with us, spending your precious time on a Sunday. Thank you.
Dr. Anand, big thanks from us. As I said in the introduction, you are the best. Thank you.
Thank you.
Thank you so much. Thanks.
We'll do an OCT before cataract surgery and show the patient that there is some macular pathology and ask him to get a cataract surgery done and explain him he might need a vitrectomy surgery later. If the VMT is spontaneously relieved, it is well good and okay. If the still visual level is less and patient is not satisfied with the cataract surgery, we have to go for vitrectomy.
Okay, we'll end the section.
I would like to invite Dr. Ramakrishnan sir to give the momentum for the speech. Dr. Saudar, Dr. Nikhil, Dr. Sundeep.
We'll just start the next session. Minister is getting late, so we'll start this session. When Minister comes, we'll just take a break for that. And this session is the lead discussant is our Dr. Indu and Dr. Anju. They're doing a real wonderful job developing and they're doing world-class surgeries at Comtrust Hospital, Calicut. And we have Dr. Sundeep Vijayaraghavan, my dear friend. He heads that plastic surgery department at Amrita Institute of Medical Sciences, and if you're seeing a lot of film stars to be beautiful and maybe getting younger these days, it is basically thanks to Sundeep. So thank you, Sundeep, for being here. So he'll be delivering the keynote address, and one of the best oculoplasty surgeons in India, my friend, my brother, Dr. Raman Mittal, and he will be joining us on Zoom, and no better person than Sir to be discussing on the various aspects that we are discussing today. And see, I basically wanted a non-ophthalmologist who deals with the periocular issues. Dr. Anjali Rose, she's a dynamic dermatologist from Pterygium, so that's basically the team that'll be carrying through this next session. And I request Dr. Anju and Dr. Indu to take it.
Good morning, everyone. Welcome you all to the oculoplasty session. Today we will be dealing with periocular aesthetics. I think it's a very relevant topic these days because people are being very more cosmetically aware all these days. So myself and Dr. Indu, working as oculoplasty consultant in Contrast Talsheri and Periocular. With me, I have my colleague, Dr. Anju. She is working in Contrast Hospital, Calicut.
Good morning, everybody. So we would like to invite our panelists for today.
So we have, as we said, Dr. Raman Mittal with us.
Good morning.
Good morning, Doctor.
Good morning, sir. So I'm very privileged to introduce Dr. Raman Mittal. He is currently the medical director of Eye Class Eye Center in Amritsar. And he has done his fellowship, oculoplasty fellowship from the prestigious L.V. Prasad Institute, and he has established oculoplasty centers in various parts of North India. He has served and 2 terms at the as a joint secretary in Oculoplasty Association of India, and also he has taken up very leading roles in Punjab Ophthalmic Society.
Very warm welcome to you, sir.
We also have Dr. Anjali with us, Dr. Anjali Rose. She's a consultant dermatologist who is working in dermatologist in Nova Cosmetology Clinic, Talasheri, and in Astamins, Kannur.
A very warm welcome. Without further delay, I would like to invite our keynote speaker, Dr. Sundeep Vijayaraghavan, who is a professor and HOD of the Department of Plastic and Reconstructive Surgery at Amrita Institute of Medical Sciences, Kochi. He did his NCH in plastic surgery from Kottayam Medical College and then became a DNP in plastic surgery from New Delhi. Since then, he has been a very integral part of plastic surgery department at AIIMS Kochi. He has over 35 publications in national and as well as international journals. He is the one who pioneered gender affirmation surgery at Amrita and also started a fellowship in aesthetic surgery at the same place. He is a trainer for various organizations and he has immense experience in administering botox, fillers, and threads, and so many things which he is going to talk about today. So I warmly invite you, sir, to deliver today's talk.
Thank you very much for this warm welcome. Thank you, Srini, for that questionable kind of introduction that was offered. we'll actually come to the topic right away. Right? This is something which is not done too often, but it is one thing that is required for everyone. So like if all the ophthalmologists actually get into the act, there's a huge potential for this particular subdivision of ophthalmology. Yeah. So beauty is in the eyes of the beholder. That is what all of us have been hearing all our lives. But actually, you see, what is attraction is the thing that is actually each person is concerned with each person. Attraction is actually is in the eyes of the beholder. Beauty is actually universal. Beauty is for everyone to appreciate, everyone to like it, right? And you will actually see that there are so many terminologies for beauty. And that is mainly because different people have got different concepts of beauty, and there is no standardization for that. But there are some ways of actually understanding how to actually go about it. The important thing we should know is that if you want to make somebody look beautiful, you should know what actually makes them look beautiful. Why does someone appear to look beautiful and others do not appear to look beautiful? So actually studies were done and they found that in the order of importance, the most important thing is the eyes, then the brow, and then the cheeks. So these are the three things that we are actually going to discuss today, and these are the most important parts of the body, and my dear ophthalmologists all deal with these areas. So let us see how it is. So we know that in the old age, I mean 2000 years back, the most beautiful woman in the world was considered to be Nefertiti. And this is a bust of Nefertiti that was actually excavated. She was the queen of Egypt, and this bust was actually excavated in Egypt, and it has been taken to Berlin, and it is now currently in the Berlin Museum over there. So why we selected this particular picture is because she is considered to be the epitome of beauty, and her beauty has been going on for centuries. So it has not changed. Okay. So the most important thing is that it is harmonious. The face is shapely. The normal face should be balanced, it should be symmetrical, and the most important thing is it has to be elevated. If it is elevated, there will be highlights. The highlights is actually what the eyes perceive. So that is the next important thing. And the proportion should be good, and that is what will make a face look beautiful. But what is it? Basically it's a normal face, right? But the normal face, what makes it look beautiful is actually the is the augmented angles. You can actually see the angle of the mandible, so that you can see also the cervicomental angle. So these beautiful angles make it look attractive. Also the elevated features. Actually the cheek is very elevated, and because of the elevated features you can actually see the highlights, the lighter areas over there, and right over the eyebrows also. And also if you see on the lips also, you will see that's called the white roll of the lips. That is what makes a lip look very beautiful. So together, on the whole, this lady looks very beautiful. But how do we measure beauty? If somebody is actually coming to the hospital, we have a very limited time to actually interact with that particular person. So normally what we do is we take a lateral picture, and then there are small tips and tricks to actually decide whether the proportions are good. Or in case where the proportions are really bad, then we have to go for cephalometry. And with the cephalometry, we'll actually get these angles and decide whether any bony work has to be done from them. In general, most of the time, 99% of the time, we will be just taking the lateral and the APV of the patient. So here basically what happens is that we show the picture to the patient, and then we speak to them. We ask them what is their interest, what are you looking for? And then they will tell, okay, I am interested in these areas. So then we have to actually talk to them about the proportions and all other things that I had actually discussed with you. Then the most important thing is when we are actually going to start a procedure, the most important thing is we have to tell them the downtime. So if you are doing this, the downtime will be this. If you are doing this, it will be it might take much longer for you to actually get back to business, things like that. And again, the thing is, along with downtime, the important thing is the quick fix things last less long. So you do something which is very fast, it might last only for a couple of years. Whereas you do some surgical work, it might last for much longer time. Then the procedures we have to tell in detail, and the cost factors, which is also very important. And then what most of the time we go for a structured way of actually dealing with it. We do not go and do all the procedures in one go. We do it in a structured, stepwise manner. Main thing is that again the financials also there, so they are also comfortable. They'll do something now, and then after 3 months they'll do the next thing, things like that. So in this particular patient, what happened is that we discussed with her, then she has actually selected to go for fat injection. So we told her that it is a simple procedure, it's a day case procedure. We can have a downtime of 2 to 3 days, and then she can actually be fit to do her regular activities. It is a very cost-effective way of actually doing the primary setup and primary procedure, and it improves the quality of the skin significantly. That is the added advantage for them. But the disadvantage is it's a general anesthesia procedure, and it takes around 30% of the fat is lost in around 3 months. And 70% of the fat is a living tissue. So the living tissue, living fat is all the problems of living structure. That is, it also sags with time. So we told all these things, and this is the immediate post-operative picture of this particular patient. And the idea is that once you get this particular look, then you actually go, maybe after 3 months, we'll have to call this patient back again, and once we see, okay, some additional areas we'll have to do some corrections. So it goes step by step, and then we went ahead. So we all know about eggs, coming to eggs. No? We all buy eggs every day in the market. Now eggs are, I think, around, for the regular ones, it must be 5 rupees. And the brown ones, Nadan Mutta, that is, I think, maybe 10 rupees or so, at least in Kochi. And these are some eggs which are around 250 crore rupees each egg. This is actually made by the SARS from Baj Group. So these eggs, the most important things are, they are very rare. For every Easter he used to make one for his wife. So wife had 54 eggs with her. Okay. But some classes are some useful use for this particular egg. So he decided that eggs are very important for giving beauty aspect. So he actually, for giving a good highlight for the face, you have to have 7 areas where these Babaj eggs can be actually fitted over there. So these are the areas. So the most important thing, like I said, the most important parts we will see. We are going to see 3 different parts: the eye, the cheek, and the brow. So the eye, the most important thing is when we are dealing with the eyes, the size of the eyes are very important. The positions, the lid margins, the angles, the proportions, the eyelashes, the supratarsal fold, and the tear tubes. So these are the areas that we will try to cover today. So in our society, there are so many ways to identify a beautiful eyes. We tell Kamalanetram or Meenakshi, like Srini's daughter, like that. So there are so many ways. The Western people used to talk about almonds, less sexy things, okay, and rosebuds, things like that. So, but certain things are really beautiful. When you see something, it looks amazing. So similarly, in this particular case, the lashes are actually very important. These are the smaller things that are very important. We might not be able to increase the overall length of the eyes and things like that, but these are certain things that can be done. So the eyelashes normally should look arched and full. That will add beauty. And the other thing is the supratarsal folds. So supratarsal folds are also extremely important, because this is something which many of us sometimes miss out on. That it should be subtle, and the important thing is in this particular things you will usually notice that this lady has got actually some eyelash extensions. Also, it's not a very beautiful eyes. You can actually see the lower lid positions also not that. Again, we are not leaving the eggs behind, so that there should be actually a space between your eyebrow and your eyelid. So we'll come again to that. So that is the thing that highlights the beauty to the face. And the proportions should be very important. You all know the proportions. It is 1/5. Each eye is around 1/5 the width of the face, and there's a distance between the eyes, which should be again the eye line. So that again proportions should be corrected in case it is not that. There are other numbers which are not really important. The other important thing is like the upper lid is usually slightly in front of the lower lid. Also, there should be smooth transition between the lower lid and the cheeks. Again, if you actually see the angles, the eye actually is at a 5 to 7 degree angle, and the medial canthus is always in a stable position. Usually the treatments that we offer to the patients, one is eyelash. Some people come with loss of eyelash due to different reasons. Maybe it's a tumor surgery, we have done a flap, the eyelash is not there, or could be burns. So there are techniques where you can actually put eyelashes now. You can actually do hair transplants for eyelashes. Then supratarsal fold creation, that's usually the upper lid blepharoplasty, we do that. Then we have the teardrops, and we can do fillers, we can do lower lid blepharoplasty, radio frequency, lipolysis, etc. And crow's feet is usually treated with toxins and dark circles. We actually have lightening agents, but much better things are actually the hyaluronic acid. Those are the things that actually really gives a lot of character to your the tired looking eyes. And SPF, that is the nano fat, is actually made into stromal vascular factors, and these also improve the quality of the eyes. Now, in this is a typical case that would actually come, and then these are simple cases. So then here what we do is we just go for a filler. We advise the patient according to whatever she's not having. A newer thing is like we try to combine threads for these patients. The idea of combining threads or doing threads alone is because the threads are relatively cheaper and you are able to treat a larger area. So in this particular area, this lady, she's actually had 5 threads put for her face on each side, and here we have done for the entire face, but I'm just concentrating on the eyes, but you can actually see that there's a significant difference in the teardrop in this particular lady. Again, coming to crow's feet, one important aspect that people come to us is telling that they have a crow's feet. I want treatment for that. I want Botox for that. So now the thing is, when if you are going to do isolated crow's feet treatment, it doesn't look nice. The way the eyes interacts with the surrounding area is also very important. So normally we treat 3 areas. That's the upper face expression lines, that's the forehead lines, the glabellar lines, and the crow's feet together are treated. Usually around 64 units of Botox is used for that, and you can see how the immediate results would look like. It takes around a week for the results to come. If done properly, you would actually be able to open up the eyes. So that's you can actually position the eyebrows. However you want your eyebrows, you can actually position. There's a difference in males and females, and similarly the lateral portion of the eyes can actually open up so that the person would look very interesting. And for politicians, I always tell them that for them Botox is very important, because most of them will be always angry and having a bad look, and they'll be having these glabellar lines. So it's very easy for getting rid of the glabellar lines with Botox. Coming to the eyebrow, so that's the second most important aspect that we will be dealing. So here the ideal eyebrow, you can see on the other side, on the left hand side of the patients, you can see how this is a normal what she was having, and that is how the ideal eyebrow should look like. So normally the eyebrows should be having a certain amount of thickness. It shouldn't be too thick and it should be too thick. Okay? And the most important thing is it should have a follow-on arch. So the arch starts from the medial aspect and it climbs up in around 15 to 20 degrees angle. It climbs up for 2/3 of the distance, and then at the peak it dips down. So that is how it is. And the most important thing is the entire eyebrow should be above the upper supratarsal, the superior orbital plane, right? And usually the medial portion of the eyebrow should be thick and the lateral portion should be thin. In males, it is more horizontal than in females. But nowadays, actually, there are many males coming to us asking for a lateral lift, like a spock eye. So they want that lateral lift. It depends. There are so many things that are happening over here. There are so many people coming to us asking for a sharp chick, because they are seeing all Korean movies, Korean pop stars and Korean movies. They want chin like this, they want eye like that. So it's their face, they are, so we can do it for them. So again, the important thing is we have not left out the most important area, the egg is over there. Okay, the degree of the climb is around 10 to 20 degree climb. So now we should know where the eyebrow should start, where should be the peak, and where it should end. So normally a beautiful eye would look, it would start at the medial canthal area, just above that, and then it would climb, and then you draw a line from the alar base through the lateral limbus, you would reach the peak, and from the alar base through the lateral canthal area, you would reach the end. So this is how an ideal eyebrow should actually look like. The most important thing is you should have a smooth line actually from the eyebrow. It would come, extend onto the nose and onto the dorsum of the nose and come to the supratip point over there. So that is how, if you have a good light, that would actually, it should look like that. That is what gives beauty to the eyebrow and to the nose together. But you can see that many of these models will not have eyes like this. Some people's eyebrows are, it will be going this way, that way. Some it is too medial. Some is not really bothered about that. But then ultimately all of them also look beautiful, right? So some people come to us actually for hair transplant for the eyebrows. So this is an Iraqi lady who was actually having a tattoo. She was not having, so the problem was that her eyebrows were not in the correct position. So instead of getting the eyebrows correct position corrected, she went and removed all the eyebrows. Then she did a tattoo for that. Then now she wants hair on the tattoo. So but there are techniques of doing hair transplant for the eyebrows. The important thing is that you usually take the hair from the edge of the back of your scalp, the occipital region, at the edge, so that the hairs would be extremely thin. And you have to actually, the angle, the direction, both are very important. You can actually see the direction, how it is done, and it should be as flat as possible to the skin. So we have a special technique of doing that, and that is how we get things like this. Now coming to brow lift. She's a trans woman. So if you can actually see, even for her, no, you can actually see that she has got a look as though that she's always an angry kind of a person. You can actually see that the medial portion of her eyebrow is actually coming down, and then she wanted the whole thing to actually go up from a male pattern to a female pattern. So what we have actually done is, nowadays we actually do a endoscopic brow lift through small incisions in the hairline. We can actually go inside and dissect off the entire subperiosteal, entire forehead can be dissected off. The important thing is that you have to separate off the orbital retaining ligament around the orbit, the superior part and the lateral part. So once you are doing that, you can actually take a bite onto the scalp. See, normally you can have bone tacking sutures are there, and that's pretty expensive, or you can make 2 holes in the bone and into the skull outer table, and then you can actually stitch it over there. This lady also had wanted some elevation of the cheeks, so we are actually showing you how we have actually made a small plane over there, and instead of doing big things, simple silicone implants are more than enough. And then from here you can actually see that the elevated the eyebrows is completely elevated, and the cheek has also got a good elevation with a good highlight for the cheek. Coming to cheek, the other techniques are, coming to the important things are that it's one of the most important facial feature actually. So we should know where it has to be there. So where the peak should be there, it is actually, if you draw a line from the ala to the tragus and from the lateral commissure to the lateral canthal area, that angle should be where that maximum prominence is. Or you take your finger, keep it like this and move it around, you'll find the position. For males, a different look is required, and females, a different look is required. Females should have a projection laterally, male should have a projection anteriorly. The width of the egg ideally is the distance from the lateral canthus to the same distance from the lateral canthus to the brow peak should be the width over there. You can actually see this is the width over there. And usually the distance is around 2.5 centimeters from the lateral canthal region. So what happens is, with aging, this is what happens, that good malar eminence, it slowly descends downwards, and that would actually first increase the nasolabial folds, and later actually would cause the jowl to actually form. So here we can actually we have to do 2 things. We have to consider elevation, and the second thing is that we have to consider fullness. Elevation, we usually use fillers, thread lifts and face lifts. And for getting fullness nowadays, fillers, fat injections, silicone implants are what is normally done. So the one thing about fillers is, whenever we talk about fillers, people immediately, oh, if you put fillers, I will become very plump. This is not what I want. I want a chiseled look. That is what people always look for. You can actually see this particular lady, young lady. She's actually having a plump look, and then after putting fillers, you can see that she has become more thinner than broader. So that is, you should know where to put, how much to put, how to get that elevation. And then on that other picture you can see that her highlights are also there. The lateral cheek area, you can see the good highlights that can be seen over there. And this is a slightly later post-op picture. She looks much more thinner than what she was initially. This is a peculiar person. He is actually a fisherman from Maldives. He had come with one problem. He said that, see doc, I am a very happy person, but everyone in my village tells that I am looking very sad. Can you do something for that? So here actually we assess this particular person. The main thing is that what we found is that he is not having a cheek fullness. So we just injected 1 ml of fillers for him in the cheek area, and then see from this same position, it's 10 minutes difference. Same thing, he has not seen his face. I've just taken 2 pictures and then you can see what the highlights have actually done. So this is what I wanted to highlight. Highlights are very important, right? Now comes to the threads. So there are so many threads available, so many types. That's a whole session by itself. We will not go through all those things. So now there are simple ways of actually doing, instead of going for facelift. People don't want downtime. You want to get things done and the result also to be seen with immediately on table, and within two days they'll want to go for party, marriage, engagement, etc. She is one of our staff over there, and after the fillers you can see how she has improved. So certain fillers like the ones which we use, it has got hyaluronic acid also in the fillers, so the quality of the skin also keeps improving. This is a picture that was taken exactly 2 weeks after this one. You can actually see that some of the nasolabial, the nasojugal folds, everything has actually disappeared with that, and that elevated look is there. Now the last part, this is the conclusion slides. This is actually my classmate. She's an entrepreneur. So she came with a peculiar problem. She said that she had a son's engagement happened in Mumbai, and she said that I was actually in that Mumbai thing event. So daughter-in-law was only actually doing all the party and things like that. But when she was just going on, people were asking her, why are you looking very tensed? Why should you be so tense? They are only looking after everything. Why are you so tense? And she was telling me that I am not tense, but the thing is that people are telling I am tense. What is the problem? Can you do something for that? So this was how she was looking when she came. Will you be able to tell something? Okay, we'll come to it. Okay. So immediately we assess the problems. I will not tell you what all we spoke to her. We assessed the problems and then we started the journey. I told you, we will go in a stepwise pattern. No? So first what we did is that we actually put some fillers. Basically we had a filler workshop. So I called her as a patient and we did 2 ml fillers. One we have put on the temple areas. Actually you can see in this particular picture, you can see that the lateralmost portion of the eyebrow is almost disappearing. It shouldn't be like that. It should be visible better. So for that, we have put that fillers in the temples. It would add, temple fillers would actually give a small lift also. And the second thing is you can actually see in the jaw, lower portion of the jaw, that some jowls have actually started forming. So we wanted to get rid of the jowls. So what we do is we fill up the anterior portion over there, and then you can see the difference that has happened. We have not addressed any other portion at this point of time. Then we wanted to improve the quality of skin because she has got melasma over there, and this is what we have done. We did a vampire facelift with some fat and a PRP. That's a current thing that we are doing. We use nano fat plus PRP, combine it, and we do this vampire facelift. And then what the most important thing was the initial picture, that is why the problem that she was facing, the tensed look. The main problem for the tense look is because of her blepharochalasis. The excess amount of skin that is there in the upper lid was actually causing her to lift up her eyebrows. And that lifting of the eyebrows, people perceive it as tension, because normally when you're tensed, you lift up your eyebrows. So that was what is done. So we explained to her, and then we went and did an upper lid blepharoplasty. And after that, she had the marriage. Somebody saw her in the marriage and then invited her to be a model for Tanishq. And then she was there all over the world now. This was 2 years back. Now you have Nayanthara, I think, as the current model. So this is what can be done with small things around the eyes, the treatment around the eyes. Thank you very much.
Thank you, Dr. Sundeep, for such an excellent topic being covered in such a short period of time, and it was beautifully described as well.
Dr. Raman, the minister has come. We'll just break for 20 minutes inauguration, and then we'll continue.
Okay.
It's okay with you,
No
right?
issues.
Okay. So, minister has already arrived, so we'll break here for the inauguration, and then we'll continue with the oculoplasty session. Any comments you can?
Actually, sir has covered most topics. Nothing left much for us to do in the discussion part of it. And a very interesting thing was how, instead of just looking at the eyes per se, we need to address the face as a whole. So that's exactly what was described very well and in a very simple manner. And these days, like we said at the beginning, patients are very concerned about their appearance thanks to social media like Instagram, where people make use of filters, but they do want to have the no filter look as well.
Kind of actually, Doctor, I appreciate Dr. Sundeep's talk. He, as you said, very vastly covered all the important topics in ocular as well as facial aesthetics. And if we have a minute, I can make a couple of comments.
Yeah, please.
So, as he said that we have to correct the whole face rather than looking at eyes because we are ophthalmologists, but it's like ocular and facial aesthetics which we need to take care of. And we should always, it's a two-way discussion we should ask. We should always ask what the patient wants and then what all we can deliver. So there has to be a match between what he or she wants and what we can deliver. So if we can deliver something else and the person wants something else, that doesn't suit. And whether they want something and we can't deliver, they has to match, number one. Secondly, we all age definitely, and the aging process has two important things. One is deflation, and one that we all know the necessary evil is gravity. So whenever our face deflates, due to gravity, everything sags down. And he has very nicely given us the ways how to lift various areas of the face in various forms by using threads, by using surgeries and whatnot. Second thing, apart from the mathematical calculation which he has nicely shown, every face is unique and everybody has its own facial features. But what important thing which I would like to re-mention is that there should be a symmetry in the face. The face has to be symmetrical. A symmetrical face is a beautiful face. And South Indians are anyway having the most beautiful eyes in the country, we all know. So the basic thing which we need to do is to fill the depressors wherever there are depressive areas like in tear troughs and in the malar areas, and to reduce the elevation. If there is something which is much more fuller than what you need, like lower lid bags of fat or whatnot, then you need to reduce. You have to symmetrize everything, so reduce the elevation and fill the depressors. That's all what I wanted to say. Thank you.
Thank you, Dr. Raman. We'll join back.
I request all dignitaries and chief guests to please take their seats on the dais for the inaugural function. Dr. Remya Vivek. Dr. Remya Vivek, Dr. Srini Edaklon, Mr. Ramji Gopinath, Dr. Nadima Beauty, Dr. Sujitra. On to the dais, please.
ബഹുമാനപ്പെട്ട രജിസ്ട്രേഷൻ പുരാവസ്തു വകുപ്പ് മന്ത്രി ശ്രീ രാമചന്ദ്രൻ കടന്നപ്പള്ളി അവർകൾ, ഈ യോഗത്തിലെ അധ്യക്ഷൻ ഡോക്ടർ ശ്രീനി എടക്ലോൺ സർ, മറ്റ് വേദിയിലിരിക്കുന്ന വിശിഷ്ട വ്യക്തിത്വങ്ങളുടെ സഹപ്രവർത്തകരെ, കോംട്രസ്റ്റ് ചാരിറ്റബിൾ ഐ ഹോസ്പിറ്റലിൽ എല്ലാ വർഷവും നടത്തി വരാറുള്ള തുടർ വിദ്യാഭ്യാസ പദ്ധതിയുടെ ഭാഗമായിട്ടാണ് നാം ഇന്ന് ഇവിടെ കൂടിയിരിക്കുന്നത്. നേത്രപരിപാലന രംഗത്ത് നാം കാണിക്കുന്ന ജാഗ്രതയാണ് ഇത്തരം CMEകൾ എല്ലാ വർഷവും നടത്തി വരുന്നതിൻ്റെ ഉദ്ദേശം. ഇന്ന് ഈ പരിപാടി ഔപചാരികമായി ഉദ്ഘാടനം ചെയ്യുന്നത് നമ്മുടെ പുരാവസ്തു വകുപ്പ് മന്ത്രിയും ഏവർക്കും പ്രിയങ്കരനും ആദരണീയനുമായ ശ്രീ രാമചന്ദ്രൻ കടന്നപ്പള്ളി അവർകളാണ്. സാറിനെ ചടങ്ങിലേക്ക് ഹാർദവമായി സ്വാഗതം ചെയ്യുന്നു. ഈ ചടങ്ങിന് അധ്യക്ഷത വഹിക്കുന്നത് കോംട്രസ്റ്റ് ഐ ഹോസ്പിറ്റൽ തലശ്ശേരി മാനേജിംഗ് ഡയറക്ടറും ഓൾ ഇന്ത്യ ഓഫ്താൽമോളജിക്കൽ സൊസൈറ്റി മാനേജിംഗ് കമ്മിറ്റി ചെയർമാനുമായ മാനേജിംഗ് കമ്മിറ്റി മെമ്പറുമായ ഡോക്ടർ ശ്രീനി എടക്ലോൺ സാറാണ്. സാറിനും ഈ ചടങ്ങിലേക്ക് സ്വാഗതം. ഈ ചടങ്ങിന് ആശംസകൾ നേർന്നുകൊണ്ട് സംസാരിക്കുന്നത് കോംട്രസ്റ്റ് ഹോസ്പിറ്റൽ മാനേജിംഗ് ട്രസ്റ്റി മിസ്റ്റർ ഗോപിനാഥൻ MG അവർകളാണ്. സാറിന് സ്വാഗതം ചെയ്യുന്നു. കൂടാതെ തലശ്ശേരി IMA പ്രസിഡന്റ് ഡോക്ടർ നബീദ് അബൂട്ടി സർ ഇന്ന് ഈ ആശംസാ പ്രസംഗത്തിന് ഇവിടെ എത്തിയിട്ടുണ്ട്. സാറിനും സ്വാഗതം. ഇതിലെ ഔപചാരികമായി നന്ദി പ്രകാശനം നടത്തുന്നത് നമ്മുടെ ഓഫ്താൽമിക് സൊസൈറ്റി ഓഫ് കണ്ണൂരിൻ്റെ സെക്രട്ടറിയായ ശ്രീമതി സുചിത്ര മാഡമാണ്. മാഡത്തിനും സ്വാഗതം. ഏവർക്കും ഒന്നുകൂടി ഈ ചടങ്ങിലേക്ക് സ്വാഗതം പറഞ്ഞുകൊണ്ട് അധ്യക്ഷ സ്ഥാനത്തേക്ക് ശ്രീനി സാറിനെ ക്ഷണിക്കുന്നു.
നമസ്കാരം. ഡോക്ടർ MA പറഞ്ഞ മാതിരി ഓരോ വർഷവും നമ്മൾ ഇതുമാതിരിയുള്ള സെമിനാറുകൾ നടത്താറുണ്ട്. ഈ വർഷം നമുക്ക് ഈ സെമിനാറിന് അഭൂതപൂർവമായ ഒരു റെസ്പോൺസാണ് കിട്ടിയിരിക്കുന്നത്. 100-ലധികം ഒഫ്തമോളജിസ്റ്റ് ഇതിന് രജിസ്റ്റർ ചെയ്തിട്ടുണ്ട്. നമ്മുടെ നമ്മൾ ഈ പരിപാടി നടത്തുന്നത് കേരള സൊസൈറ്റി ഓഫ് ഒഫ്തമിക് സർജൻസിൻ്റെ ഏജസിലാണ്. കേരള സൊസൈറ്റി ഓഫ് ഒഫ്തമിക് സർജൻസിൻ്റെ ഒരു കാര്യവും കോംട്രസ്റ്റിൻ്റെ ഒരു കാര്യം ജസ്റ്റ് ഒരു എക്സാമ്പിൾ പറഞ്ഞുകൊണ്ട് നമ്മുടെ ഈ ഒഫ്താൽമിക് കമ്മ്യൂണിറ്റി എങ്ങനെ നമ്മൾ സമൂഹത്തിൽ ഇടപെടുന്നു എന്നുള്ളത് ഒന്ന് മനസ്സിലാക്കി. ഇപ്പം ഈ ഇടയ്ക്ക് ഉണ്ടായിരുന്ന ആ ഫ്ലഡും ലാൻഡ് സ്ലൈഡിലും വ്യാപകമായ നാശം വന്നിരുന്നു എന്നുള്ളത് നമുക്ക് കൃത്യമായിട്ട് അറിയാം. അപ്പം ഇതിനു മുമ്പുണ്ടായിരുന്ന ആ ഫ്ലഡിൽ ഞാൻ KSO ജനറൽ സെക്രട്ടറി ആയിരുന്ന സമയത്ത് നമ്മളൊരു 55 ലക്ഷം രൂപ കളക്ട് ചെയ്തിട്ട് CMDRF കൊടുത്തു. ഇപ്രാവശ്യം നമ്മൾ വിചാരിച്ചു അങ്ങനെയല്ല, നമ്മളുടെ ഒഫ്തമോളജിസ്റ്റ് എന്നുള്ള രീതിയിൽ എന്താണ് നമ്മുടെ സ്ട്രെങ്ത്? ഐ കെയർ. അപ്പം നമ്മൾ നേരിട്ട് എന്ത് ചെയ്യാൻ പറ്റും എന്നുള്ളത് ആലോചിച്ച് കഴിഞ്ഞപ്പോഴേക്കും ഒന്ന് മനസ്സിലാക്കാൻ ഇപ്പം ഈ ഫ്ലഡ് വരുമ്പം കുറേ ഡെത്ത് നടന്നു. പക്ഷെ അവർ പോയി. പക്ഷെ പലർക്കും ഉള്ളത് മുഴുവൻ നഷ്ടപ്പെട്ടു പോയിരിക്കുന്നു. വീട് നഷ്ടപ്പെട്ടു, എല്ലാം നഷ്ടപ്പെട്ടു. ഇതിൻ്റെ കൂട്ടത്തിൽ ട്രീറ്റ്മെൻറ്റിൻ്റെ പേപ്പേഴ്സ് നഷ്ടപ്പെട്ടു, ഗ്ലാസ് നഷ്ടപ്പെട്ടു. പലർക്കും സർജറി പ്ലാൻ ചെയ്തവർക്ക് പിന്നെ ഫണ്ടില്ല അടുത്ത എന്താ ചെയ്യണം എന്നുള്ളത്. അപ്പം നമ്മൾ തീരുമാനിച്ചു. എനിക്ക് ഇതിൽ അപ്പോൾ ആ ഒരു ചിന്ത എനിക്ക് വന്നപ്പോൾ ഞാൻ നമ്മുടെ KSOS പ്രസിഡന്റിൻ്റെ അടുത്തും എക്സിക്യൂട്ടീവ് കമ്മിറ്റിയിലും നമ്മൾ ചെയ്യാം, ഞാൻ ഏറ്റെടുക്കാമെന്ന് പറഞ്ഞു. അപ്പം KSOS readily agreed, and what I did was I understood that Bishop Pamplani Bishop, Archbishop, അവിടെ എനിക്ക് സൗകര്യങ്ങൾ ചെയ്തു തരാൻ, അവരുടെ പള്ളികളിലെ കൂടി എല്ലാം ഒരു ക്യാമ്പ് നടത്താനുള്ള സൗകര്യം ചെയ്തു തരാം എന്നുള്ളത് മനസ്സിലാക്കിക്കൊണ്ട് തന്നെ ഞാൻ ബിഷപ്പിനെ പോയി മീറ്റ് ചെയ്തു. അതേമാതിരി തന്നെ MP-യും അവിടുന്ന് തന്നെ ഷാഫി പറമ്പിൽ MP-യും അവിടെ തന്നെ കോണ്ടാക്ട് ചെയ്തു. ഇതിനെല്ലാം എനിക്ക് സഹായിച്ച എൻ്റെ സുഹൃത്തായ നവാസാണ്, ഒരു പത്രപ്രവർത്തകനാണ്. അപ്പം നമ്മൾ അവിടുന്ന് ഇതെല്ലാം പ്ലാൻ ചെയ്തിട്ട് what we did was we did camps in Wayanad and Velangan. സോ ഇത് ആയി വന്നപ്പോഴേക്കും ഞാൻ ഇതിപ്പം KSOസിനായിട്ട് നേരിട്ട് നടത്താൻ പറ്റില്ല. സോ വി ക്യാൻ ഓൺലി ഡൂ ഇറ്റ് ത്രൂ എ ഹോസ്പിറ്റൽ. ഇങ്ങനെ ഒരു പ്ലാൻ വന്നപ്പോൾ ഞാൻ ഫസ്റ്റ് ഞങ്ങളുടെ മാനേജിങ് ട്രസ്റ്റിയായ ശ്രീ MG ഗോവിന്ദാഥനെ വിളിച്ച്, സർ നമുക്കിതിനുള്ള സപ്പോർട്ട് തരുമോ എന്ന് പറഞ്ഞു. He readily agreed and he said for 1 year, so we'll do the camp there, give classes, give treatment. It doesn't end with that. We are going to give 1 year full treatment, including surgeries for all those affected. This is I don't think it has been done anywhere else where disaster has struck. സോ അത് മാതിരി അവിടെ പോയി നമ്മൾ ക്യാമ്പ് നടത്തി. ഇപ്പോഴും എന്തുകൊണ്ട് 1 year എന്ന് പറഞ്ഞു കഴിഞ്ഞിട്ടുണ്ടെങ്കിൽ ഇപ്പം അവർക്ക് വേറെയും പല കാര്യങ്ങളും, ഇപ്പോൾ കാറ്ററാക്ട് സർജറി വേണ്ട പേഷ്യൻ്റ് ഇപ്പം വന്നിട്ട് ചെയ്യാൻ പറ്റില്ല. സോ വി ഡിസൈഡഡ് വി ആർ ഗോയിങ് ടു ഗിവ് 1 year. സോ ജസ്റ്റ് ടു സേ വി ആർ ഡൂയിങ് എ ലോട്ട് ഓഫ് ആക്ടിവിറ്റീസ് ഇൻ അക്കാഡമിക് ആക്ടിവിറ്റീസ്. ദാറ്റ് ഈസ് ഡെഫിനറ്റ്ലി ദെയർ, ബട്ട് വി ആർ ഇൻവോൾവ്ഡ് ഇൻ സോഷ്യൽ ഇൻ്റർവെൻഷൻ ഓൾസോ. സോ ഇത്രയും പറഞ്ഞുകൊണ്ട് ഞാൻ ബഹുമാന്യനായി രാമചന്ദ്രൻ കടന്നപ്പള്ളി സാറിനെ കുറിച്ച് നമുക്കിപ്പം പുറത്തുനിന്നുള്ള മലപ്പുറം, കോഴിക്കോട്, വടകര എന്നുള്ള ഒഫ്തമോളജിസ്റ്റ് ഇതിൽ ഉണ്ട്. അപ്പം അത്ര പരിചരണം അല്ലാന്നുണ്ടെങ്കിൽ ഇത്ര ഫ്രണ്ട്ലി ആയിട്ടുള്ള, ഇത്ര ജനകീയനായിട്ടുള്ള ഒരു മന്ത്രിയെ ഇതുവരെ ഉണ്ടായിട്ടില്ല, ഇപ്പോഴും ഇല്ല, ഇനിയും ഉണ്ടാവില്ല. അപ്പം ഇതിന് ഒന്ന് ഭയങ്കര ബിസിയാണ്. ഇപ്പം തന്നെ പല പ്രോഗ്രാംസ് കഴിച്ചിട്ടാണ് വന്നിരിക്കുന്നത്. ഇതൊന്ന് ഇനോഗ്രേറ്റ് ചെയ്യാൻ വരുമോ ചോദിച്ചപ്പോൾ അദ്ദേഹം റെഡിലി എഗ്രി ചെയ്തു. വളരെയധികം നന്ദിയുണ്ട് സർ. ഒന്ന് ഇനിയിപ്പോൾ ഒന്ന് സാറിൻ്റെ ഇനോഗ്രൽ അഡ്രസ്സും നമുക്ക് ആദ്യം വിളക്ക് കൊളുത്തിയിട്ട് സ്റ്റാർട്ട് ചെയ്യാം.
ബഹുമാന്യരായ സഹോദരി സഹോദരന്മാരെ, സുഹൃത്തുക്കളെ, നമ്മുടെ നേത്രരോഗ നിവാരണ മുന്നേറ്റത്തിൽ വളരെ വിലപ്പെട്ട സംഭാവന നൽകിയിട്ടുള്ള ബഹുമാന്യരായ വ്യക്തിത്വങ്ങളെല്ലാം ഉൾക്കൊള്ളുന്ന ഈ സംഗമീയതയ്ക്ക് എൻ്റെ സ്നേഹനിരഭരമായ അഭിവാദനങ്ങളും ആശംസയും നേരുകയാണ്. ഇവിടെ ബഹുമാനപ്പെട്ട അധ്യക്ഷപദം അലങ്കരിക്കുന്ന ഡോക്ടർ ശ്രീനി രഘുവരൻ, സ്വാഗതം ആശംസിച്ച ഡോക്ടർ രമ്യ വിവേക, രജിസ്ട്രേഷൻ നടത്തുന്ന MG ഗോപിനാഥ്, നദീന ബുട്ടി, നന്ദി പറയുന്ന സുചിത്ര ഉൾപ്പെടെയുള്ള വ്യക്തിത്വങ്ങൾ. അതോടൊപ്പം നമ്മുടെ ഇന്നത്തെ ഈ സംഗമത്തിൽ ബഹുമാനപ്പെട്ട പത്മശ്രീ ജേതാവായ ഡോക്ടർ TP ലഹനെ, വേൾഡ് റെക്കോർഡ് സൃഷ്ടിച്ച വ്യക്തിയാണ്. കാറ്ററാക്ട് സർജറി, മഹാരാഷ്ട്രയിൽ നിന്നാണ്. അദ്ദേഹത്തിൻ്റെ വിലപ്പെട്ട സാന്നിധ്യമുണ്ട് ഇവിടെ ചടങ്ങിൽ. I extend my hearty welcome on behalf of Kerala. Thank you. Thank you. ഇവിടെ സ്വാഗത പ്രസംഗത്തിലും അതുപോലെ ചിരപ്രസംഗത്തിലെല്ലാം ഈ ചടങ്ങിൻ്റെ ഏറ്റവും ബഹുമുഖമായ കർമ്മനിർവഹണത്തിന് ആമുഖം നൽകുകയുണ്ടായി. ഇവിടെ മുന്നിരിക്കുന്ന നിങ്ങളെല്ലാം തന്നെ ഇത്തരം കാര്യങ്ങളെക്കുറിച്ച് എന്നേക്കാൾ കൂടുതൽ അവബോധമുള്ളവരാണ്, പരിശീലനവും പരിജ്ഞാനം ലഭിച്ചവരാണ്. അതുകൊണ്ട് ഇതിൻ്റെ ഔപചാരികമായ ചടങ്ങ് നിർവഹിക്കുക എന്ന് മാത്രമാണ് ഞാൻ ആഗ്രഹിക്കുന്നത്. മാത്രമല്ല, വിവിധ പരിപാടിയിൽ പങ്കെടുത്ത് വൈകുന്നേരം മാവേലിക്ക് പോകണം. ബഹുമാനപ്പെട്ട മുഖ്യമന്ത്രി മണ്ഡലത്തിലും ഒരു സ്കൂൾ പരിപാടിയിൽ പങ്കെടുക്കണം. ഇത് കഴിഞ്ഞൊരു സെമിനാറിനടുത്ത് പങ്കെടുക്കാനുണ്ട്. ഇവിടെ തന്നെ പറഞ്ഞ സമയം വൈകി നിങ്ങൾക്കുണ്ടായ ബുദ്ധിമുട്ടുകൾക്ക് ഞാൻ ആദ്യമായും ക്ഷമ ചോദിക്കുകയാണ്. ഇതേ ഹാളിലോ അതുപോലെ മറ്റ് ഈ പരിപാടികളിലോ ഇതുപോലെ നിങ്ങളുടെ പരിപാടിക്ക് മുമ്പ് പങ്കെടുത്തിട്ടുണ്ട് എന്നാണ് എനിക്ക് തോന്നുന്നത്. അതെല്ലാം ഓരോ നിലയിലും അനുഭൂതികളും അനുഭവങ്ങളും നൽകുന്ന ഒരു കൂട്ടായ്മയുടെ ഹൃദയധ്വനിയായിരുന്നു. നിങ്ങൾ കാണിക്കുന്ന നിങ്ങളുടെ ജോലി നിർവഹണത്തിലും ആ ക്രമത്തോടും കാണിക്കുന്ന നിങ്ങളുടെ പ്രതിബദ്ധത, സ്നേഹപൂർണമായ നിങ്ങളുടെ ഇടപെടലുകൾ, ഇതെല്ലാം സാമൂഹ്യ രംഗത്ത് ശ്രദ്ധേയമായ ഓരോ പദവിന്യാസങ്ങളുടെയും ഭാഗമാണ്. അതാണ് കുറഞ്ഞുകൊണ്ടിരിക്കുന്നതാണ് ഈ വർത്തമാനകാലത്തിൻ്റെ രൗദ്രഭാവങ്ങൾ പ്രകടിപ്പിക്കുന്നത്. അതിന് വ്യത്യസ്തമായി നിങ്ങളുടെ സഹോദര നിർവിശേഷമായ ഒരു ഇടപെടലുകളും ബന്ധവും എല്ലാം തീർച്ചയായും അത് രോഗികൾക്ക് ഒരു അനുഗ്രഹമായി തീരും എന്ന് പ്രതീക്ഷിക്കാം. ഇവിടെ നമ്മുടെ ചാരിറ്റബിൾ ട്രസ്റ്റ്, ഹോം ട്രസ്റ്റ്, അത് ഈ രംഗത്ത് പ്രവർത്തിക്കുന്ന ഒരു പ്രത്യേകമായ ആശുപത്രിയാണ് എന്ന് നമുക്കെല്ലാം അറിയാം. എല്ലാ വർഷവും നടത്തി വരാറുള്ളതാണ് ഈ മെഡിക്കൽ പരിശീലന ക്യാമ്പ്. തുറ വിദ്യാഭ്യാസ പദ്ധതി അതുപോലെ ഈ പ്രസ്ഥാനവുമായും ലക്ഷ്യവുമായും കൂടുതൽ താതാത്മ്യം പ്രാപിച്ചുകൊണ്ട് മുന്നോട്ട് പോകാൻ കഴിയുന്ന നിരവധി പരിപാടികൾ നിങ്ങൾ ആസൂത്രണം ചെയ്തിട്ടുണ്ട്. നേത്ര ആരോഗ്യ പരിപാലനത്തിൽ നിങ്ങൾ കാണിക്കുന്ന ജാഗ്രതയുടെ ഭാഗമായിട്ടാണ് ഇത്തരം സംഗമവേദികൾ സംഘടിപ്പിക്കാൻ കഴിഞ്ഞത്. അതുകൊണ്ട് ഇത്തരത്തിലുള്ള കൂട്ടായ്മകളിലൂടെ ഒരു ജനങ്ങൾക്ക് ഒരു ബോധവൽക്കരണത്തിൻ്റെ ഒരു ദൗത്യം കൂടി നിർവഹിക്കാൻ കഴിയണമെന്ന് ഞാൻ ആഗ്രഹിക്കുകയാണ്. കേരളം വിദ്യാഭ്യാസ പ്രബുദ്ധമാണ്, സാംസ്കാരിക പ്രബുദ്ധമാണ്, സാമൂഹ്യ ബോധമുള്ളവരാണ്, രാഷ്ട്രീയ പ്രബുദ്ധം, എല്ലാ പ്രബുദ്ധതകളും നിറഞ്ഞു നിൽക്കുന്നതാണ്. പക്ഷേ നമ്മുടെ രോഗങ്ങളോടും രോഗങ്ങൾ വരാതിരിക്കാനുള്ള പ്രവർത്തനങ്ങൾ എല്ലാം നമ്മൾ കാണിക്കുന്ന ഒരു ജാഗ്രതയുണ്ട്. ആ ജാഗ്രത ഇത്രയും പ്രബുദ്ധത കൊണ്ട് നിറഞ്ഞു നിൽക്കുന്ന സംസ്ഥാനത്തിനകത്ത് പോലും കൃതകൃത്യമായി നിർവഹിക്കാൻ കഴിയാത്തൊരു സാഹചര്യമുണ്ട് എന്നത് വാസ്തവത്തിൽ നമ്മളെല്ലാം ചിന്തിപ്പിക്കേണ്ടതാണ്. ചെറിയൊരു സൂക്ഷ്മക്കുറവുകൊണ്ട് വലിയ പ്രത്യാഘാതങ്ങളാണ്. കണ്ണിനെ സംബന്ധിച്ചിടത്തോളം കണ്ണ് പോയാലേ കണ്ണിന് കാഴ്ച അറിയുമെന്ന് ഒരു പഴഞ്ചൊല്ലുണ്ട് നമ്മുടെ നാട്ടിൽ. പുതിയ തലമുറയൊന്നും കേട്ട് കാണില്ല. എന്ന് പറഞ്ഞാൽ കണ്ണിൻ്റെ പ്രാധാന്യമാണ്. കണ്ണില്ലേ പിന്നെ ജീവിച്ചിരുന്ന കാര്യം? എന്താണ് ലോകം, എന്താണ് നിങ്ങൾ, എന്താണ് ഞാൻ എന്നറിയുന്നതിനുള്ള ഉത്കൃഷ്ടമായ ഒന്നാണ് കണ്ണ്. കണ്ണ് കാണാത്തവനെന്ന് പറഞ്ഞാലോ കണ്ണില്ലാത്തവനെന്ന് പറഞ്ഞാലോ അവരുടെയൊക്കെ ബുദ്ധിമുട്ടുകൾ എന്താണ്? നമ്മൾ കണ്ണിൽ നമുക്ക് പ്രത്യേകിച്ച് തോന്നുകയില്ല. നമ്മൾ ഒരുപാട് പരിപാടികൾ പങ്കെടുക്കേണ്ടവരാണ്. അവർ സംസാരിക്കും, അവർ ചിത്രം വരയ്ക്കും, അവർ പാട്ടുപാടും, അവർ നൃത്തം, എല്ലാം കാണുകയാണ്. എൻ്റെ വീടിനടുത്തുണ്ട് സഹായിക്കുന്ന ഒരു വിദ്യാലയം, തോട്ടടയിൽ ചെയ്യാൻ കഴിയുന്ന സഹായങ്ങളൊക്കെ ചെയ്യുകയും പരിപാടി പങ്കെടുക്കുക. അവിടെ പങ്കെടുക്കുന്നവരുടെ പ്രയാസങ്ങൾ കാണുമ്പോഴാണ് വാസ്തവത്തിൽ അന്ധതയുടെ അക്രൗര്യം, അന്ധത സൃഷ്ടിക്കുന്ന ഇരുട്ട്, കൂരിരുട്ട് നമുക്ക് മനസ്സിലാകുന്നത്. അവിടെയും സേവനമനുഷ്ഠിക്കുന്നവരുണ്ട്, ഡോക്ടർമാരായിരുന്നാലും ഉപചാരകന്മാരായാലും. അവരൊക്കെ കാണിക്കുന്ന സ്നേഹസ്പർശം അതാണ് അവർക്ക് വെളിച്ചം നൽകുന്നത്. അതുകൊണ്ട് നേത്രരോഗ പരിപാലനം, നേത്ര ചികിത്സ എന്ന് പറഞ്ഞാൽ ഏത് വൈദ്യമേഖലയേക്കാളേറെ ഉത്കൃഷ്ടമായൊരു മാനുഷിക ധർമ്മത്തിൻ്റെ ഏറ്റവും കരുത്തും ശക്തിയുമാണ് എന്ന് ഞാനിവിടെ ഹ്രസ്വമായി സൂചിപ്പിക്കുകയാണ്. ഞാൻ കൂടുതൽ സംസാരിക്കുകയല്ല. അപ്പം ഞാൻ പറഞ്ഞതുപോലെ കേരളത്തിൻ്റെ ഈ അടുത്ത ദിവസം നിങ്ങൾ കഴിച്ചു സ്പോർട്സ് സ്കൂൾ ഹോസ്റ്റലിലെ മറ്റ് വിഷബാധ എന്ന് പറഞ്ഞിട്ടാണ്. ഒരു ചെറിയ അശ്രദ്ധ കൊണ്ട് ഒരു വ്യക്തിയിലോ അല്ലാതെ നടന്നതാണ്. ഞാൻ തിരുവനന്തപുരത്ത് ഇന്നലെ വന്ന് എല്ലാ ആശുപത്രിയിലും ചെന്ന് അതുപോലെ മറ്റു കാര്യങ്ങളൊക്കെ ചെയ്യാൻ. അപ്പോൾ അത് എന്തൊരു വാർത്താ പ്രതികരണം സൃഷ്ടിച്ചത് എന്ന് പറഞ്ഞാൽ ഭക്ഷണത്തിൽ നിന്ന് പകർന്നതാണ് എന്നാണ് പറയുന്നത്. അപ്പോൾ ചെയ്തുകൊണ്ടിരിക്കുന്നവർ കാണിച്ചിട്ടുള്ള എവിടെയോ ചെറിയൊരു അശ്രദ്ധ. ആ അശ്രദ്ധയിലെ പ്രത്യാഘാതങ്ങളാണ് നിങ്ങളും ഞാനൊക്കെ വായിച്ചത്. നിങ്ങൾ വായിച്ച് പറഞ്ഞു എന്തെന്നായത്, ഇതെന്തായി കാണിക്കുന്നു. സ്പോർട്സ് സ്കൂളിൽ രക്ഷാകർത്താക്കൾ മാത്രമല്ല, കുട്ടികളെ അവിടെ തന്നെ പഠിപ്പിക്കുന്ന രക്ഷാകർത്താക്കൾ മാത്രമല്ല, എല്ലാവരും എന്ന് പറഞ്ഞാൽ ഒരു വ്യക്തിയിൽ നിന്നോ 2-3 വ്യക്തിയിൽ നിന്നോ ഒരു കൂട്ടായ്മയിൽ നിന്നോ ഉണ്ടാകുന്ന ചെറിയൊരു അശ്രദ്ധയും ഉത്തരവാദിത്വ ബോധമില്ലായ്മയും സൃഷ്ടിക്കുന്ന വിഷയം. ഞാൻ തന്നെ ഒരു യോഗം വിളിച്ചു. ആരോഗ്യവകുപ്പിൻ്റെ ഉദ്യോഗസ്ഥന്മാരുണ്ടായിരുന്നു, ജീവനക്കാരുണ്ടായിരുന്നു, ഇതേ ബന്ധപ്പെടുന്നവരുടെ. ഞാൻ പറഞ്ഞു, ദൈവം ശ്രദ്ധിക്കുക. പിന്നെ ഭക്ഷണ കാര്യത്തിൽ നമ്മളൊക്കെ ഞാൻ പറഞ്ഞതുപോലെ അശ്രദ്ധരാണ്. ഈ അടുത്ത കാലത്ത് നമ്മുടെ മെഡിക്കൽ ഡിപ്പാർട്ട്മെൻറ്റും മറ്റു ഡിപ്പാർട്ട്മെൻറ്റും ചേർന്നിട്ട് ഹോട്ടലുകൾ ഒരു പരിശോധന നടത്തുകയുണ്ടായി. 19 ഹോട്ടലുകൾ പരിശോധിച്ചു. 9 ഹോട്ടലുകളിൽ നിന്ന് കിട്ടിയ ഭക്ഷണ സാധനങ്ങൾ പരിശോധിച്ചു. ഓരോ ഹോട്ടലുകളിൽ നിന്ന് വ്യത്യസ്തമായ രൂപഭാവത്തിലാണ് ഓരോ തകരാറുകൾ. അപ്പോൾ കണ്ടുപിടിച്ചതിൽ ഒരുപാട്, ഒരു ഹോട്ടലിൽ നിന്ന് പിടിച്ച ചിക്കൻ കറി അതിന് അല്പം പഴകിയതാണ്. അല്പം പഴകിയ ചിക്കൻ കറി ഇവിടെ നമ്മുടെ സഹോദരിമാർ ഉണ്ടല്ലോ പങ്കെടുക്കും. അതിന് എല്ലാ ദിവസവും ജോലി ചെയ്യുന്ന ഈ കറിയും ചോറും ഉണ്ടാക്കുന്നവരെല്ലാം പോലും എത്ര ദിവസത്തെ പഴക്കമുണ്ട് എന്ന് നിങ്ങൾക്കത് ഊഹിച്ചെന്ന് പറയാൻ പറ്റുമോ? ഇത്രയും സഹോദരിമാരുണ്ടായിട്ട് തെറ്റിയാൽ പരീക്ഷ ഒന്നുമല്ല, PSC പരീക്ഷ ഒന്നുമല്ല, ഏതായിരുന്നല്ല, ഇത്ര ദിവസം പഴക്കം ഉണ്ടാവാം. സഹോദരി പൈനുകാരി എൻ്റെ സഹോദരിയെ പറയും, അത് പറയും നിങ്ങൾ. ഒരു ചിക്കൻ കറിയൊക്കെ നമ്മുടെ നാട്ടിലും പണ്ട് പൈനൂരിലും പറയുമ്പോൾ ചട്ടിയിൽ വെക്കുന്നതാണ്. ചട്ടിയിൽ വെച്ചാൽ ആരോഗ്യപരമായി നല്ലതാണ്. ഇപ്പോൾ സ്റ്റീൽ പാത്രം ആയതുകൊണ്ട് അതിൻ്റേതായ പ്രത്യാഘാതങ്ങളുണ്ട്. ചെറിയ മത്സ്യക്കറി മാങ്ങയിലിട്ട് വെച്ചാൽ ഒരു ദിവസം പറയുക, എന്താ അതിൻ്റെ ടേസ്റ്റ് എന്നറിയാം ഇല്ലേ? ഇപ്പം നിങ്ങളെല്ലാം എന്താ വാങ്ങിക്കുന്നത്? ഷോർപ്പും ആ പാക്കറ്റ്, മഞ്ഞ പാക്കറ്റ് മഞ്ഞൾ നിന്നാണ് ധരിച്ചിരിക്കുന്നത്. ആരാ പറഞ്ഞ ഞങ്ങളുടെ മഞ്ഞളാണെന്ന്? മഞ്ഞ നിറത്തിലുള്ള മഞ്ഞളാണ്. ഈ കണ്ടുപിടിച്ചതിൽ തന്നെ കാപ്പിപ്പൊടിയിൽ ഒരാട്ടിൻ പിട്ട. പക്ഷെ അത് മിക്സ് ചെയ്തവർക്ക് ഒരു വലിയ പ്രായോഗികമായൊരു തന്ത്രപരം ചെയ്തതാണ്. അത് കാപ്പിക്കുരുവും ആട്ടിൻപെട്ടിയുമായി കണ്ടു കഴിഞ്ഞാൽ ഒരു ഒറ്റ നോട്ടത്തിൽ ഒരു കണ്ടുപിടി നോക്കിയാൽ മനസ്സിലായില്ല. അത്ര ശാസ്ത്രീയമായി ചെറുതാണ്. വലിയ ആടിൻ്റെ പെട്ടയല്ല. കാരണം കാപ്പിക്കുരുമായി ബന്ധപ്പെട്ട് മനസ്സിലാക്കാൻ കഴിയാത്തില്ല. അത്രയേറെ ശ്രദ്ധാലുക്കളാണ് ഈ മിക്സ് ചെയ്യുന്നവരെന്ന് ഞാൻ പറഞ്ഞത്. ഇവിടെ ചിക്കൻ കറി പിടിച്ചില്ലേ, അതിന് 3 മാസം മാത്രമേ പ്രായമുള്ളൂ. ആ 3 മാസം പ്രായമായ ചിക്കൻ കറി വിതരണം ചെയ്ത ഹോട്ടലിൽ ഞാനും പറയും, ഇത് നിങ്ങളുടെ സുഹൃത്തുക്കൾ ആരെങ്കിലും വന്നു ചെയ്താൽ അവിടുന്ന് എന്തും കഴിക്കുന്നതിന് അവിടുന്ന് കഴിക്കണം കേട്ടോ എന്ന് ഞാനും പറയും. ഞാൻ കഴിക്കുന്നതല്ലെങ്കിലും അപ്പോൾ കഴിച്ചു പോയി പറയും, ഓ കണ്ണൂർ പോയ ഒരു ഹോട്ടലുണ്ട് കേട്ടോ എന്ന് പറയും. അപ്പോൾ കേരളത്തെ പോലെ വിദ്യാഭ്യാസ പ്രഭുത്വം ഉൾപ്പെടെയുള്ള ഒരുപാട് പ്രഭുത്വം ഉൾക്കൊള്ളുന്ന ഒരു സംസ്ഥാനത്തിനകത്ത് പോലും ആരോഗ്യ പരിപാലനത്തിനും ഭക്ഷണ ക്രമീകരണത്തിനും കാണിക്കുന്ന അത്യന്തം ഗുരുതരമായ അശ്രദ്ധ, അതുണ്ടാക്കുന്ന പ്രത്യാഘാതങ്ങൾ പറഞ്ഞത് മാത്രമേ ഉള്ളൂ. കോവിഡ് മഹാമാരി കാലത്തൊക്കെ നമ്മുടെ ഒരു ആരോഗ്യ പരിരക്ഷയും ആ പരിശീലനങ്ങളും എത്ര ഗുണകരമായി പരിവർത്തിച്ചിട്ടുണ്ട്. അതിൽ നിങ്ങളെല്ലാം പങ്കാളികളല്ലേ. അത് പ്രതിരോധിക്കാൻ ലോകം കീഴടക്കുന്ന അമേരിക്കയിലാണ് ഏറ്റവും കൂടുതൽ ആൾ മരണപ്പെട്ടത്. കാശില്ലാത്തതുകൊണ്ടല്ല, മരുന്നില്ലാത്തതുകൊണ്ടല്ല, ആശുപത്രി ഇല്ലാത്തതുകൊണ്ടല്ല ഇവിടെ. പക്ഷേ പ്രകൃതിയുടെ അത്യന്തം മാരകമായ അതിക്രമങ്ങളെ നേരിടാൻ മാനവരാശിക്കൊന്നും സാധ്യമല്ല. അതിൻ്റെ ഭാഗമാണ് ഇവിടെയും നമ്മൾ കുറച്ച് ആളുകൾ മരണപ്പെട്ടു പോയി. പക്ഷേ ഏറ്റവും കൂടുതൽ ആൾ മരണപ്പെട്ടത് അമേരിക്കയിലാണ് എന്ന് പറഞ്ഞാൽ ഇതെല്ലാം നമ്മുടെ നിയന്ത്രണങ്ങൾക്കും ചിന്തകൾക്കും അപ്പുറത്താണ് എന്ന് പറയാനാണ്. അപ്പം അതുകൊണ്ട് നമ്മുടെ ശരീരശാസ്ത്രപ്രകാരം നിങ്ങളെപ്പോലെ ശാസ്ത്രബോധമില്ലവരല്ല, ഒരു ലേമേൻ എന്ന നിലക്ക് കണ്ണിൻ്റെ പ്രാധാന്യം പറഞ്ഞിരിക്കേണ്ട കാര്യമില്ലല്ലോ. കണ്ണില്ലെങ്കിൽ പിന്നെ എന്താ സ്ഥിതി? ഇരുട്ടാണോ പകലാണോ വെളിച്ചമാണോ സ്ത്രീയാണോ പുരുഷനാണോ അമ്മയാണോ അച്ഛനാണോ സഹോദരി സഹോദരങ്ങൾ എന്നൊന്നും അറിയാൻ പറ്റാത്ത നിലയിൽ എന്നാലും ഒരു പ്രകൃതിയുടെ ചുറ്റുപാടും കണ്ണ് കാണാത്തവരെല്ലാം കണ്ണ് കാണുന്ന നമ്മളെക്കാളേറെ ലോകം കാണുന്നവരും വ്യക്തികൾ കാണുന്നവരും മറ്റുള്ളവരുടെ ഹൃദയം കാണുന്നവരും എല്ലാം അതിൻ്റെ ഭാഗമാണ് അന്ധവിദ്യാർത്ഥികളും ആ രംഗത്ത് പ്രവർത്തിക്കുന്നവരും ചെയ്യുന്ന ഓരോ ഉത്കൃഷ്ടമായ മാനുഷിക ധർമ്മങ്ങൾ. അത് വേറെ പ്രകൃതിയുടെ ഒരു അത്ഭുതകരമായ കാര്യമാണ്. കണ്ണുള്ളവരെക്കാളേറെ ലോകത്തെ കാണാൻ കഴിയുന്ന കണ്ണുള്ളവർ. ഇതാണ് ഓരോ മനുഷ്യൻ്റെയും ഒരു സത്യം ചെയ്യാൻ. തികച്ചും അംഗവൈകല്യം 15 വയസ്സായ ചെറുപ്പക്കാരൻ വന്ന് എനിക്ക് എൻ്റെ ഒരു ഫോട്ടോ നന്നായിട്ടുണ്ടെന്ന് പറഞ്ഞു. അപ്പോൾ അമ്മ ഇവിടെ ശാരീരികമായ ശേഷിയില്ല, ഇത് നിൽക്കാൻ കഴിയില്ല, കൈയില്ല, കാലില്ല, സംസാരിക്കാൻ കഴിയില്ല, കേൾവി ശക്തിയില്ല. പിന്നെ ഞാൻ പറഞ്ഞു, ഇതെന്തെന്നാ ഇത് അത്ഭുതം? അത് അവൻ വായ കൊണ്ട് ബ്രഷും പെൻസിൽ വെച്ച് വരച്ചതാണ്. നമ്മൾ 4 കൈയും കാലും ഉള്ളവർ വരച്ച അത്രയും മനോഹരമാവില്ല. അത് തന്നു, സ്വീകരിച്ചു, അവനെ കെട്ടിപ്പിടിച്ചു. അത് തരുമ്പോൾ ഇങ്ങനെ പിടിച്ച സാറല്ലേ മന്ത്രി മാമനല്ലേ എന്ന് പറഞ്ഞ് ഇങ്ങനെ കെട്ടിപ്പിടിച്ച് തന്നെ കാഴ്ചയില്ലാത്ത എന്തൊരു അത്ഭുതകരമാണ്. പിന്നെ അടുത്ത ദിവസം വന്നിട്ട് പറഞ്ഞു, ഒരു ചെറിയ ഹുണ്ടിപ്പെട്ടിയായിട്ടാണ് വന്നത്, ഇത് മുഖ്യമന്ത്രി ദുരിതാശ്വാസ നിധിയിലേക്ക് നൽകുക. എന്തിനാ നീ അതല്ല, എൻ്റെ വീട്ടിൽ ഉപഹാരങ്ങൾ സൂക്ഷിക്കാൻ ഷെൽഫില്ലാത്തതുകൊണ്ട് ഷെൽഫ് സമാഹരിക്കാൻ വേണ്ടിയിട്ടുള്ള ഷെൽഫ് ഉണ്ടാക്കാൻ വേണ്ടിയിട്ടുള്ള സമാഹരണമാണ്. പക്ഷേ വയനാടിൻ്റെ വാർത്തകൾ കേട്ടപ്പോൾ ആ ദുരിതാശ്വാസ നിധിയിലേക്ക് ഈ നൽകണമെന്ന് പറഞ്ഞ് അത് മുഖ്യമന്ത്രി ഏൽപ്പിക്കാൻ നിങ്ങളെ കാണാനുണ്ടാണ്. പക്ഷെ എൻ്റെ ദൈവമേ, ഇതെന്തൊരു മകനാണ്. ഞാൻ അതുപോലെ കൊണ്ടുപോയി മുഖ്യമന്ത്രിക്ക് കൊടുത്ത് പറഞ്ഞു, ഇങ്ങനെയുള്ള ഒരു മകൻ്റെ സൃഷ്ടിയാണ് ഒരു ഫോട്ടോ അതിനെ പറഞ്ഞു. ഞാൻ പറഞ്ഞു വന്നത് ഇതൊക്കെ പ്രകൃതിയുടെ അലംഘനീയമായ കർമ്മത്തിൽ ഭാഗമാണ്. ഇതൊന്നും ലംഘിക്കാൻ നിങ്ങൾക്ക് സാധ്യമല്ല, എനിക്ക് സാധ്യമല്ല, ആർക്കും സാധ്യമല്ല. പക്ഷേ നമ്മുടെ കർമ്മരംഗത്തുള്ള അനുഷ്ഠാനങ്ങൾ കൊണ്ട് ചില കാര്യം ചെയ്യുന്നു എന്നുള്ളതാണ്. അതുകൊണ്ട് ചികിത്സാ രംഗത്ത്, നേത്രരോഗ പരിപാലന രംഗത്ത് പ്രവർത്തിക്കുന്ന നിങ്ങൾ ചെയ്യുന്നത് ഉത്കൃഷ്ടമായൊരു മാനുഷിക ധർമ്മമാണ് എന്ന് ചിന്തിക്കാൻ കഴിയണം നിങ്ങൾക്ക് എന്ന് ഞാൻ നിർദ്ദേശിക്കാൻ ആഗ്രഹിക്കുകയാണ്. അതുകൊണ്ട് തന്നെ നിങ്ങളുടെ ഈ കർമ്മം വളരെ വിശിഷ്ടപ്പെട്ടതാണ്. ഇവിടെ ചർച്ച ചെയ്യുകയോ ചെയ്യുന്ന കാര്യങ്ങൾ നിങ്ങളുടേതായ വർഗപരമായ ഉത്തരവാദിത്വത്തിൻ്റെ, അവകാശങ്ങളുടെ, താല്പര്യങ്ങൾക്ക് കാര്യങ്ങൾ സംസാരിക്കണം. ഇത്രയേറെ സേവനം നടത്താൻ നിങ്ങൾക്കുള്ള ബുദ്ധിമുട്ടുകളുണ്ടായിരിക്കും. അതുകൊണ്ട് ആരോഗ്യ മേഖലയിൽ നിങ്ങൾ നൽകുന്ന അമൂല്യമായ സംഭാവനകൾ അതർഹിക്കുന്ന നിലയിൽ പരിഗണിക്കുകയോ വേണ്ടതിൽ പ്രോത്സാഹിപ്പിക്കുകയോ സഹായിക്കുകയോ ചെയ്യാത്ത എന്തെങ്കിലും ചെറുതും വലുതുമായ വിഷയങ്ങളുണ്ടെങ്കിൽ അതൊക്കെ രേഖാമൂലം അറിയിക്കുകയും ചെയ്തു കഴിഞ്ഞാൽ അത് ആ നിലയിൽ ചെയ്യാം. അതുകൊണ്ട് ഞാൻ പറഞ്ഞു വന്നത് നിങ്ങളുടെ സേവനത്തിൻ്റെ ഒരു അമൂല്യത നിങ്ങളും ഞാനും കണക്കാനിരിക്കുന്നത് വലുതാണ് എന്ന് മാത്രമാണ് ഞാൻ ചൂണ്ടിക്കാണിക്കുന്നത്. അതുകൊണ്ട് നിങ്ങളുടെ ഇന്നത്തെ ഈ പരിപാടിയിൽ പങ്കെടുക്കുന്നവർ, പ്രഭാഷിക്കുന്നവർ നമ്മുടെ മഹാരാഷ്ട്രയിൽ നിന്ന് വന്നിട്ടുള്ള വളരെ ബഹുമാന്യനായ ഒരു ഭിഷുക്കരൻ കൂടിയുണ്ട്. അവരൊക്കെ വാക്കുകൾ കേൾക്കണം. അതുകൊണ്ട് ഞാനീ പറഞ്ഞത് നിങ്ങളുടെ ജോലിയുമായി ബന്ധപ്പെട്ട കാര്യമില്ല. ഞാനൊരു ലേമൻ, ഒരു സാധാരണ ഒരു സമൂഹത്തിലെ ഒരു വ്യക്തി എന്ന നിലക്ക് പറഞ്ഞതാണ്. അതുകൊണ്ട് കണ്ണ് പോയാലേ കണ്ണിൻ്റെ കാഴ്ച അറിയൂ എന്ന കേരളത്തിൽ നമ്മൾ പറയുന്ന പഴഞ്ചൊല്ല് അർത്ഥപൂർണമാണ്. അതുകൊണ്ട് ആ കണ്ണ് വായിക്കാൻ എഴുതാനും മാത്രമല്ല, സമൂഹത്തെ കാണുന്നവരാണ്. കണ്ണ് കണ്ടാലേ മനസ്സിലാവുള്ളൂ. അതുകൊണ്ടാണ് അത്ഭുതകരമായി വയനാടൊക്കെ ദുരന്തമുണ്ടായപ്പോൾ അവിടെ പോയി ഇത്ര ടൺ നഷ്ടമുണ്ടായെന്ന് പറഞ്ഞിട്ട് കാര്യമില്ലല്ലോ, നേരിട്ട് കാണേണ്ടേ. ആ കണ്ടപ്പോഴാണ് വാസ്തവത്തിൽ ഹൃദയഭേദകമായ കാഴ്ചകൾ അതെല്ലാം ഉണ്ട്. അതോടൊപ്പം തന്നെ നയനസുന്ദരമായ കാഴ്ചകളും കാണാൻ കഴിയുമല്ലോ. സൗന്ദര്യം സുഗന്ധവും നിറഞ്ഞെടുക്കുന്ന പരിപാടികൾ അതുകൊണ്ട് പ്രകൃതി ഇതെല്ലാം കൂടി ചേർന്നാണ് നമ്മുടെ പ്രാപഞ്ചിക ജീവിതം. എന്തുകൊണ്ട് ആ ജീവിതധർമ്മത്തിൽ ഉത്കൃഷ്ടമായൊരു സേവനത്തിൻ്റെ ആമുഖമാണ് നേത്രരോഗ പരിപാലനം എന്ന് എളിവനായി ഞാൻ വിശ്വസിക്കുക. അതിന് പകരം ഒന്നില്ല. അതാണ്. അതുകൊണ്ട് ഇത്രയും സേവന സംബന്ധമായ സമർപ്പണ ജീവിതത്തിൻ്റെ അതിൻ്റെ സർവസ്വമായി പ്രവർത്തിക്കുന്ന സ്രോതസ്സുകളായ നിങ്ങളുടെ മുമ്പിൽ അല്പസമയം, നിങ്ങളുടെ വിലപ്പെട്ട സമയം നഷ്ടപ്പെടുത്തേണ്ടി വന്നതിലുള്ള ക്ഷമാപണത്തോടുകൂടി നിങ്ങളുടെ നിർദ്ദേശിച്ചതുകൊണ്ട് നിങ്ങളേവരുടെയും അനുവാദത്തോടെ, അനുഗ്രഹത്തോടെ, പ്രാർത്ഥനയോടെ ഈ സംഗമേരിയുടെ ഉത്കൃഷ്ടമായ ഈ സംഗമേരിയുടെ ഔപചാരികമായ ഉദ്ഘാടകർമ്മം സ്നേഹാദരപുരസ്സരം, ഭക്താദരപൂർവ്വം, വിനയപുരസ്സരം ഭദ്രദീപം കൂട്ടി നിർവഹിച്ചതായി അറിയിച്ചുകൊണ്ട് എല്ലാവർക്കും ആയുരാരോഗ്യം, നന്മകൾ എല്ലാം നിറഞ്ഞ കുടുംബജീവിതം ഉണ്ടാകട്ടെ എന്നുകൂടി പ്രാർത്ഥിച്ചുകൊണ്ട് എൻ്റെ വാക്കുകൾ സംഭരിക്കുന്നു. നമസ്കാരം.
I request Mr. Gopinathan sir to hand over the memento to the Honorable Minister. Request the release of book. invite Mr. Gopinathan sir for the felicitation.
Honorable Minister, members of this medical fraternity, ladies and gentlemen. I'm really fortunate enough to be a part of your inaugural ceremony of all CMEs, be it at Talacheri or Calicut. I am here to offer my felicitations on behalf of Comtrust Charitable Trust. Taking an advice from our Honorable Minister, I am a regular coffee drinker. I think I should be careful, think twice before drinking coffee again. Well, this CME, I believe, is a working tool in the hands of our doctors. They can use it to enhance their knowledge and to advance the technology. And I'm sure that it will directly benefit the public in general. While advancing the technology, I believe that the human intervention is likely to get reduced. But here my apprehension is that will that affect the bedside manners of our doctors? If it does, then it's going to be a disaster for the general public and the patients in general. I wish all the success for this CME, and I'm sure our next CME, Dr. Srini, will be very happy to host it at our Kadarur hospital. One more word about this CME, using this working tool. A good doctor can become a better one. Thank you very much.
I invite Dr. Nadeem Abouti, President IMA, Talsheri, for felicitation.
ഏറ്റവും ബഹുമാനീയനായ ഈ യോഗത്തിൻ്റെ അധ്യക്ഷൻ ഡോക്ടർ ശ്രീനി, നമ്മുടെ മുഖ്യാതിഥി മിനിസ്റ്റർ കടന്നപ്പള്ളി രാമേന്ദ്രൻ സാർ, മറ്റ് വേദിയിലും സദസ്സിലും സന്നിധരായിട്ടുള്ള ബഹുമാന്യ വ്യക്തിത്വങ്ങളെ, IMA തലശ്ശേരിയുടെ പ്രസിഡൻ്റ് എന്നുള്ള നിലയ്ക്ക് കോംട്രസ്റ്റ് ആശുപത്രി, മറ്റ് നേത്ര രോഗവിദഗ്ധരുടെ സംഘടനകൾ ചേർന്ന് നടത്തുന്ന ഈ പരിപാടിക്ക് അസോസിയേറ്റ് ചെയ്യാൻ പറ്റിയതിലുള്ള സന്തോഷം ആദ്യമേ അറിയിക്കട്ടെ. അതിലുള്ള നന്ദി ഇതിൻ്റെ ഓർഗനൈസിംഗ് കമ്മിറ്റിക്ക് പ്രത്യേകം അറിയിക്കുന്നു. ഈ പരിപാടിയിൽ ആശംസ അറിയിക്കുക എന്നതിൽ കവിന് പ്രത്യേകിച്ച് ഈ പരിപാടിയോട് നീതി പുലർത്താൻ വേണ്ടി കൂടുതൽ കാര്യങ്ങൾ സംസാരിക്കരുത് എന്ന് ഉറപ്പിച്ചതാണ്. എന്തായാലും കഴിഞ്ഞ ഏതാനും വർഷങ്ങളായി IMA തലശ്ശേരിയുമായി ചേർന്ന് ഈ തുടർ പരിപാടി നല്ല രീതിയിൽ നടത്തുന്ന, പ്രത്യേകിച്ച് ഇതിന് ചുക്കാൻ പിടിക്കുന്ന ശ്രീനി സാറെ പ്രത്യേകം അഭിനന്ദിക്കുകയാണ്. ഇന്നിവിടെ വന്നിരുന്നപ്പോൾ ഒരു കാര്യം മനസ്സിലാക്കുകയുണ്ടായി. നമ്മൾ സിനിമയിൽ പറഞ്ഞതുപോലെ പുസ്തകത്താളുകൾ കണ്ട് ഇന്ത്യയല്ല ഇന്ത്യ എന്ന് പറഞ്ഞത്, മറ്റുള്ള സ്പെഷ്യലിസ്റ്റുകൾ ഇതുപോലുള്ള പരിപാടികൾക്ക് പങ്കെടുക്കുമ്പോഴാണ് നമ്മൾ മെഡിക്കൽ കോളേജുകളിൽ പഠിച്ച ഒഫ്താൽമോളജി അല്ല ഒഫ്താൽമോളജി എന്ന് മനസ്സിലാക്കുന്നത്. എന്തായാലും ഒഫ്താൽമോളജിയും പ്ലാസ്റ്റിക് സർജറിയും ഒക്കെ വളരെ വൈദഗ്ധ്യത്തോടുകൂടി കൈകാര്യം ചെയ്യുന്ന വിദഗ്ധർ സമ്മേളിക്കുന്ന ഈ പരിപാടി പൂർണ്ണ ഫലപ്രാപ്തിയിലെത്തട്ടെ. ഇതുകൊണ്ട് എല്ലാവർക്കും ഗുണം ചെയ്യട്ടെ. ഇനി ഇതുപോലുള്ള പരിപാടികളിൽ മറ്റുള്ള ബ്രാഞ്ചുകളിലുള്ള ഡോക്ടർമാർ കൂടി പങ്കെടുക്കണം. അതിലൂടെ ഇതുപോലുള്ള പുതിയ പുതിയ കാര്യങ്ങൾ നമ്മൾ ഒഫ്താൽമോളജി ഗ്രാജുവേഷൻ ഡേയ്സിൽ പഠിച്ചോന്നല്ല, എല്ലാ സ്പെഷ്യലിസ്റ്റുകളും അതിനെ അപ്ഗ്രേഡ് ചെയ്യേണ്ട ആവശ്യകത മനസ്സിലാക്കുന്നതാണ് ഇത്തരം പരിപാടികൾ. ഒരിക്കൽ കൂടി IMA തലശ്ശേരിയുടെ എല്ലാ ആശംസകളും ഈ പരിപാടിക്ക് നേർന്നുകൊണ്ട് നിർത്തുന്നു. ജയ് ഹിന്ദ്, ജയ് IMA.
I invite Dr. Sujitra for a vote of thanks.
Good morning, everybody. As we conclude the inaugural function, it's my privilege to deliver the vote of thanks. Our sincere thanks to Shriman Ramachandran Kadanapalli sir for sparing his busy schedule and telling us how important organs we are dealing with. My sincere thanks to Mr. M.G. Gopinathan sir for all his support. Also, I would like to thank Dr. Nadeem Abuti for sparing his Sunday and gracing this occasion. Our special thanks to Mr. Dr. Srini Adaklon sir, whose efforts are seen with the huge attendance with so many CMEs happening. He has worked day in and out to make this CME a grand success. Once more, sir, thank you for making this CME a grand success. Also, our sincere thanks to all of you. My special sincere thanks to all the stalwarts of ophthalmology who have come, especially Dr. Lahane and his team, who have come all the way from different places to enlighten us with your huge knowledge and experience. Definitely, whoever has attended today will go back with a vast knowledge. Once more, sir, welcome and thank you. And lastly, but not the least, I would thank the organizing committee of ComTrust and all you delegates, without whom this CMA wouldn't have been a success. Thank you all.
This is we are winding up this inauguration, and we are starting with our ocular aesthetics discussion now.
Please come. Dr. Raman, could you please join back?
Yeah, okay, I'm there. Let me know.
Yes.
So welcome back to our session, Class T session. I would like Sundeep sir to please join the panel section, and also Dr. Anjali.
We'll be going through a few scenarios. Since Dr. Sundeep has made our job easier, most of the things are already covered. We'll be just putting up a few cases that would come up routinely in your OPDs and how to deal and tackle them. Can we have the slides, please?
Excuse me, can we please have the slides? Next slide. So as Dr. Anju mentioned, we'll be just going through a few clinical scenarios. Already it has been extensively covered by Dr. Sundeep sir. And so here it's a 63-year-old female who is much worried about her forehead lines. So I would like to ask, what are the basic things that you assess when such a patient come to the OPD, and how would you manage?
See, this particular lady, actually if you see, she is actually raising up her eyebrows a lot. So whenever we are assessing her, we have to actually see, I think she has already had some red marks and all I can see over there, but forget that. So the important thing is we have to actually press we have to ask her to close her eyes and press the forehead with great force, and then see the position whether she has got a blepharochalasis or not, because there is a high chance that she could be having a blepharochalasis over here. In case it is there, then probably you will have to do a upper lid blepharoplasty before you go and do your toxins. In the forehead nowadays, the current concept is toxins are the best things to get rid of the lines. Okay. But this is the only thing that you have to be careful when you are actually doing this.
Okay. So I would also like to know the concentration that is being used in the botulinum toxin. Is it the same which is for the functional as well as for the aesthetic purpose? The unit of the
Yeah, so
botulinum toxin?
always when you're actually diluting the botulinum toxin, you dilute it to 4 units per 0.1 cc. 4 units per 0.1 cc. That is the dilution that we make. So if you're actually having a, normally what we do is we'll have to have 64 cc. So you, in 100 units Botox, you add 2.5 ml of, you have to add 2.5 ml of normal saline, and then you get your Botox at 4 units per 0.1 cc. So normally in this particular case, when you're actually tackling the foreheads, we have a M pattern or a slightly extended M pattern. So you have around 5 points, and the 5 points you give 4 units each, and you would be actually having 20 units over there. The advantage of restricting it to 20 units is that you will be having slight mobility. It is not going to be a fully frozen look. It would be having slight expression, still would be, still slightly it would be there. That's the idea.
Can I add, please?
Yes, sir. Yes, please.
Actually, these are two schools of thought, I would say. The aesthetics people, as Dr. Sundeep has mentioned, they like to dilute it in 2.5 ml, 100 units, so that they make 4 international units per 0.1 ml. But we all in ophthalmic or oculoplastic scenario, we dilute it in 4 ml, that is 100 units in 4 ml, so that makes 2.5 international units per 0.1 ml. So that's the sort of a gold standard that we oculoplastic surgeons do. The benefit of it is easy calculation, because sometimes there are some points where you don't want to inject 4 international units. You may need to restrict yourself to 2.5 international units per site. Dr. Sundeep will agree with me. So in those type of scenarios, it's very easier to calculate and to inject, because those markings which you have, so it's like 2.5 international unit per 0.1 ml. So that's the standard also which we use in therapeutic, like 2.5 to max 3.5 international unit per site we give it. So in forehead or even in sometimes it's like even lesser dose when we do some mesotherapy type of thing, in which we not only take care of the creases, but we also want a sheen or a toned up skin of the forehead. So in which we further dilute the Botox, and we give minuscule quantity like 1 to 1.5 international unit per site, but multiple sites are covered. Isn't it, Dr. Sundeep?
Yeah, that's that's very true. So exactly, it's sort of, I mean, it's each person's convenience of how you are actually giving. So if you are actually going to give, say for example, anti-spock point, you are actually putting only 2 units over there. So I mean, it's not very difficult. And like what sir said about mesotherapy, I perfectly agree with that, because forehead, the sheen, no, even for the forehead and for the neck, etc., it's actually a remarkable thing. Especially nowadays, you add along with that, you can actually add some hyaluronic acid as well. The skin wipe kind of a hyaluronic acid you add, so you get immediate results you'll be able to get. Like you have a party or you have a function in the next 1 or 2 days, you will have a glow immediately. Otherwise, what happens is if you are going to use hyaluronic acid, the glow comes only after 2 weeks. So when you are adding microbotox or mesobotox along with your hyaluronic acid, you get a glow much faster. So that is one way of doing it. Like
That's
said.
very true. One basic thing which for all those all audience which are not very used to giving Botox and fillers, the basic thing which they need to differentiate before they start deciding where to give Botox and where to give fillers is, like you should differentiate dynamic lines versus static lines. These all lines, these are either dynamic. Dynamic means when you make some expression, whether it's a frown, whether it's like exclamation mark or smiling, the lines which appear, lines or wrinkles, which appear while you are expressing any expression are called dynamic lines, which are taken care of by Botox. Whereas the lines which remain there on the face without making any expressions are called static lines, and those lines are to be filled with fillers. So that I'm just making this statement so that in coming up cases probably the audience can also interact well rather than we both doing the job.
So that was actually our next slide. How do you manage the dynamic line, I mean the static lines? Can we have the
Oh, sorry. I spelled the name.
That's all. Slides. So, this is a question I would like to ask Dr. Anjali. Is there any role when patients come to you with concerns like wrinkles and all? How do you initiate a skincare routine? Or what is the importance of that prior to administering any of these injectables?
Definitely in this case, this lady just requires a Botox. But in some cases, there comes with some patients who can't afford the Botox, or there will be some, they will be asking for some non-invasive procedures. So in that cases, we have different options, but it works well when it comes with the fine wrinkles. Actually, we do have quite a number of different peels, that is chemical peels like glyco peels, retinol peels. When it is the case of a fine wrinkling, maybe with 5 or 6 sessions, there will be a little bit improvement. And some patients, especially in the case of fine wrinkles, they are quite useful. And other than that, we do have some lasers as well, like Q-switch anti-dark, and these lasers help in laser toning. So they'll be helping in removing this fine wrinkling by stimulating the collagen within the skin. And also, along with that, we can even add, as I already mentioned, the vampire facial, that will PRP with microneedling. All this will cause minor injuries within the skin, in turn stimulating the collagen, and thus helping to remove the wrinkles. So if the patient is asking for some little bit of non-invasive or minimally invasive procedures, and when there is a problem with the cause factor, maybe we can try with this, and this will be helpful as well.
Okay. Can I just add a point? See, the thing is, whenever somebody is actually coming to you for a particular aesthetic treatment, see, the most important thing is, what is it that you actually see? You're seeing the skin. You ask the patient, what should I address? Are you concerned about your nasolabial fold? Are you concerned about your crow's feet? Or are you concerned about the first priority? Or are you concerned about the quality of your skin? Invariably, the people would tell that the quality of skin is the most important thing. So definitely the skin quality should be addressed. Many a times we address the skin quality as a first priority. The reason is that once you see the difference, the patient is happy to go ahead and do the rest of the procedures. The person who's coming with the patient also will be ready to get the procedure done. Her this one has improved so much, so I also want to get this particular thing done. So the quality of the skin is a lot to do with hydration. The only sugar that is actually doing good to you is hyaluronic acid. Right, so what happens is that it is actually opening up the pores through which the channels through which water is actually coming from the deeper tissue to the epidermis to give you actually the glow. So that's the important thing.
So that's a point to be taken, that you need to re-emphasize on skin health.
Skin health, yes.
Nowadays you have biostimulants also. You have a couple of products that are actually biostimulants that will actually improve the quality of the collagen also with just hyaluronic acid, because it's not a filler, it's basically biostimulants.
So over to the next slide. So this is a 48-year-old lady with hollowness below her eyes. So obviously she has a teardrop deformity as well as she has early fat pads. So would you like
Can
to
I request the cameraman to focus on the slide, please? Because I can't see the slide. I see the audio. Yeah, thank you.
So in this particular case, would you like to fill or to excise?
See, she's got two problems over here. Obviously she's got a teardrop, and if you actually notice carefully, she's got hyperpigmentation also. So probably I would actually show her this, because most of these patients would be coming and telling that she's got a teardrop, I want to correct that thing. So, but the important thing is you have to highlight and you have to tell the patient that you have this additional problem. You have a hyperpigmentation, because you are going to correct your teardrop, still that lines would be probably visible because of the hyperpigmentation. So ideally you correct the hyperpigmentation first, probably either with skin boosters or with depigmentation creams, or probably you can actually use SVF also, stromal vascular factors also injections. So the quality of the skin would improve, and then you give probably a month's time, or you can do it simultaneously also. Once you tell them, then you do fillers for correcting the teardrop. the highlight that I want to tell you is that if you're just going to treat the tear trough, that the product is actually going to disappear from that area, and it is actually going to slip down, and it would come and stay somewhere near the nasolabial fold. So when you're doing the fillers for the tear trough, you have to have fillers for the cheek areas also. So that is a thing, that take home message that I wanted.
I agree with Dr. Sundeep, whereas I would also like to highlight her upper eyelids. In this, which I can see from the slide, is that she's having overhooding of the upper eyelids, like the folds are overhanging over the crease, so that, as he mentioned in his lecture very nicely, the upper tarsal show is not properly seen. So she is a candidate of upper lid blepharoplasty as well. So that will make her eyes look a bit more fresh, because now her eyes are looking a bit tired. So those tired looks can be taken care of if she is agreeing to any surgical intervention by doing an upper lid bleph as well, adding to it.
From an ophthalmologist's point of view, what are the complications that we need to explain to our patients, Dr. Anand, regarding fillers and the surgical procedures as well?
There are two different aspects. One, first we take up the fillers, because tear trough, as Dr. Sundeep has mentioned, there is a vessel going around the medial canthal area, just you can say about a couple of millimeters from the medial canthus. So that's a no zone where we do not fill with the injections. So if you by chance inject the filler, that is a branch of central retinal artery, that filler can theoretically go into the central retinal artery, can cause an immediate blindness. So one, rather than using sharp needles, we should use cannulas that will avoid puncturing into the vessels and giving a direct injection to the vessels. Secondly, avoid the no zone areas or the areas which are highly vascular, so that those injections into the vessels are avoided. And for fillers, I would like to mention that we should always err towards underdoing things rather than overdoing things, because as we all know probably, fillers, they imbibe water and they gain few percentage. That depends upon what filler are you using. So the volume is added in a couple of weeks time. To always explain to the patient or counsel them that you can do a touch-up after about 2 to 3 weeks. Regarding surgeries, all the surgeries are around the eyes. Some infections, apart from infections and hematoma, that is very important to be taken care of. In upper lids, there is a minimum which we should leave behind, which is around 18 to 20 millimeters of skin between the eyebrow, the lower edge of the eyebrow, and the lid margin. That is the minimum which is to be left, so as there is no post-operative lagophthalmos or incomplete closure of the lids. And of course, we have to maintain the lid crease, and the fat lobules have to be shrunken. That is altogether a different topic. I'm just talking about the precautions, important precautions. In the lower lid blepharoplasties, we should, very importantly, we should reduce the chances of overcorrection, because if we go in for even a little bit of overcorrection, the lid margin gets everted, that is causing the lower lid ectropion, which is very, very annoying to the patient as well as to the surgeon. Secondly, during the dissection of the fat pads, the central fat pads and the middle fat pads, you encounter inferior oblique muscles. So that muscles need to be very, we should be very cautious about that muscle, and we should dissect the fat pads from the muscles. And nowadays we not only excise, not only nowadays but for so many years now, it's not only the excision of the lower lid fat pads, rather we excise a bit if there are a lot more, and we reposition the pad into the tear trough area below the periosteum. I remember the slide shown by Dr. Sudhi where he gave fillers to the lady, but she, to my mind, she also had a bit of lower lid fat pads. And if she was agreeing, if she was my patient and was agreeing for surgical intervention, I would have loved to do a lower lid fat resection along with repositioning and to touch up with fillers later on. That would have given a really very healthy and long-lasting effect to the lady. So these 2-3 points, I believe, should be taken care of. Overcorrection is absolute no-no.
And just one more point to what Dr. Mittal had actually told. The most important thing when you're doing lower lid lifts, like he said, is undercorrect. And the second most important thing is you should be 100% sure that all the vessels are properly cauterized.
The risk of retrobulbar hemorrhage in post-op. So I think in interest of time, we will be going straight away to a major concern.
This is a patient who had come to us with hemifacial atrophy. So she is basically a case of Barry-Romberg syndrome. She was complaining of ocular irritation. So on examination, she had a medial lower lid entropion. So I would like to ask Raman sir, what would be the surgical correction of your choice? And to Sundeep sir, how would you improve the cosmesis?
Lower lid entropion, we have two important surgeries which can be done for lower lid entropions. Apart from just having the look of lower lid entropion, we should also check whether there is a lower lid laxity or not. In case there is a laxity of the lower lid, then that also needs to be addressed along with just correcting the entropion. In case it is, I'll create two scenarios. If there is no laxity, then you can do a simple Jones procedure where you need to reattach the lower lid retractors and advance it further, correcting the lower lid entropion. But in case you have laxity along with, it is preferable to add on lateral tarsal strip that will give correction to the laxity and will tighten the lower lids, correcting the entropion as well as reducing the sagging look which the patient is having. Of course, the whole face needs to be corrected, which I think Dr. Sundeep would be a better person to answer about the correction of the filling of that half of the face.
Yeah, so when we are actually looking at the Pterygium disease, we have to actually check whether that facial nerve is affected or not. Sometimes the facial nerve also would be affected. In that case, that treatment is also done. Otherwise, the best way of actually filling up these things, in case the dental alignment is okay. If the dental alignment is not okay, then you might have to do some bony work. But if the dental alignment is okay, which most of the time it is so, then you are actually filling up that area to get a proper contour. So the first thing what we do is we make a moulage with what do you call a particular material, something like a plaster of Paris moulage you make of the face, and then we actually fill that face with what do you call wax. The wax, and then we actually we do it on with hand to see that we get a proper symmetry for both the sides. So once that is done, once the patient is also happy with it, and we take this particular wax, and then we will have an idea of how that, which area what has to be filled. So now the best way of doing it is, there are two ways of doing it. You can actually put fat injections, or you can actually put derma fat grafts. So derma fat grafts are a much better thing than putting a fat injection. There are ways of actually increasing the take, where you actually do a sandwich procedure where you put 2 layers of derma fat, and in between you can put a temporalis fascia, crucial temporal fascia, vascularized tissue over there. So more volume can be added to the derma fat. This one. And what we do is, normally we go through a facelift incision, and then we, just like a facelift, we lift the skin pad off, and then we put the derma fat in such a way that the trick is to make it stay there for at least a week. If it doesn't stay there for a week in that particular position, all these things will slowly come down, and then it will settle at the bottom, and it is going to be extremely difficult to treat, and it will look very ugly. So the important thing is, you have to fix it in that position, and the challenge is to actually take bites and fixing it to deeper tissues. What we normally do is, we take sutures from the skin, goes through the dermis, and then comes back into the stitch, into the skin, and then tie it off with a sponge over there, so that the marks are not there. And we retain it all around, we have to do, so that the whole derma fat is nicely stretched. Many a times we even put thrombin glue inside, so that skin folds, also skin is also nicely stuck over there. Wherever it is possible to take stitch to the deeper tissue, that is taken. And the other thing is that we put a Riles tube also for these patients, so that they are kept with liquid diet for a week. So that is a challenge that has to be taken, but with that we get excellent results. Usually we might have to do 1 or 2 more small sessions of fat injection after that. Sometimes around the eyes, we'll actually, instead of fat injection there, we prefer to actually put fillers for that particular region.
Thank you, sir. So in the interest of time, can we skip to the last slide?
Meanwhile, as ophthalmologists, many of us are referred cases of seventh nerve palsy or facial palsy. So is there a time period where they can be taken up for facial reanimation surgeries? Is it effective in that case?
So there are two ways of actually dealing with the facial nerve palsies for whatever the reason. If you're able to correct it primarily, if say if it's a tumor surgeries, we try to correct it primarily. On table we do cable grafting and correct it primarily. If it is actually coming delayed, then if it is within a year, then what we can do is we can actually go and try to do a free functioning muscle transfer. So we take muscles from the thigh and then we can actually keep it on the face. We actually, in the meanwhile, what we do is we take a nerve from the opposite side. We take one or two buccal branches, and then from there you actually take a facial nerve graft to the opposite side and then connect this free functioning muscle with that particular nerve and the facial vessels also, and then connect it to around that modulus and both the sides of the lip we do. For the eyes, normally we go in for a temporalis transfer. There are again two ways of doing it. You can flip it from top and then you can do it, or you can divide the bottom from the cornoid process and then shift over there and do. The advantage of the second procedure is that volume is not there. Otherwise, lateral to the eye, you would have a large bulky volume if you're doing flipping over. That just transferring has got, it's already aponeurosis over there, so that bulk is much less. So this is the way. Then currently there's another technique of doing where we are only putting cable grafts. We put 3 cable grafts. We put one below for the lip area, then we put one across through the nose to the opposite side, and then we put one through the eyes, above the eyebrows to the opposite side. And we just connect these nerves to the facial nerves on the normal side, and we just leave it over there. What we find is that over time, even for late cases, maybe 5 years, 7 years down the line also, surprisingly, the muscles get neuropatized with this technique instead of doing a functioning muscle. Especially what happened is, during the COVID time, many people we had actually done cable grafting thinking that we are going to do functioning muscle. They came back after 2 years and showing that full result is also there. So now there are a lot of papers coming out. This all happened in the last 10 years. A lot of papers where instead of putting a functioning muscle, you are only putting cable grafts.
Okay, thank you for that point. Yeah, so with this, we'll be winding up today's session. I hope you all have learned a thing or two about periocular aesthetics. It's a really vast topic with a lot of things that are coming up almost every day. And I really thank the panelists, and thank you Dr. Raman also for joining us online. Thank you Dr. Srini for the opportunity.
I thank Dr. Srini, my friend and my brother. He's invited me with such love and affection that I thought I would not skip and miss this session. Thank you Dr. Hindu for coordinating this, and Dr. Sundeep, you were a wonderful speaker. I learned a lot during this lecture as well. Thank you all the audience for being here.
Thank you, Dr. Raman. I also learned a lot from you. Thank you.
I request Dr. Padmaja Madam to hand over the memento to our esteemed speaker and panelists. Dr. Sundeep Vijayaraghavan. Dr. Anjali. Dr. Hindu.
Sorry, we are running a bit late, so we'll move on to the next session, and it's on common but challenging scenarios. Like, see, you always face these little problems. Like you have a small chalazion, requires this thing, you inject xylocaine or whatever, and then you see it is not there. See, these are some things that I have faced, so that is why I wanted see what to do. Rustring when to deal with it and all, and Dr. Arjun heads the cornea department at Contrast Charitable Trust Eye Hospital, Kozhikode, and he is such a committed corneal surgeon, and the way he is managing all, see, nobody wants to take care of the corneal ulcers and all, and the way the compassion with which he manages all those cases is, I mean, you have to really know him to really understand what is doing. And my teacher, see, I always, wherever I tell, I'm from RP Center, but I am what I am because of JK sir and Shankara, and he's such a wonderful teacher and innovator, and you ask him anything. Yesterday we were talking, Jason and all were there, you ask him anything on Sanatana Dharma, whatever, he'll have it. So nobody better than sir for this, and he'll be delivering the keynote address. And MS Ravindra sir, see, I mean, JK sir might say, I mean, yesterday sir was telling, Dr. Ravindra is much better than me. So, I mean, thank you, Ravindra sir, for joining, and sir will be joining online. And so I request Arjun to take over, and Lata ma'am, sorry. So this is, I mean, she is the one who is teaching all those youngsters from Kannur, and she comes and attends all the CMAs and actively interacts. Thank you, ma'am, for being here, and Dr. Seema, a dynamic corneal surgeon from Kannur. So, Arjun, please take over.
We'll start our cornea session today with the keynote address from Dr.
Thank you, Srini, and
see, there is one more on the way. Number is KL13AW9287. KL13AW9287. You can give the key to Shinoy here.
And Contrast Eye Hospital and Kannur Ophthalmic Society. I've been many times here. It's one of the best places in the world. I traveled around the world. Few countries I missed: Australia and Mexico, Brazil, and Ireland. Remaining all, most of them covered. This is one of the best. I mean, I love Kannur and Calicut. These two are amazing places on the earth. Then coming back, coming to my topic today, Pterygium, very simple surgery. It's a simple, supposed to be. Sir, which one? Yeah, there are, but the problem is you read the textbook or you go through the literature or go to the talks. There are many ways how to remove the pterygium, but they don't work. You have to pick up the right one, and now there are many techniques given, turn the head, remove the head, bury the head, but the best thing is the old technique in like a wine in a new bottle, that glue or without glue, congenital autograft. That's the only technique. Remaining all should be removed from the textbooks, should not be practiced. All this bare sclera technique and turning the head, removal, all, they should be removed. They should no more be given in the books, because some enthusiastic guy will read and try all those things and he will mess up the patient. And coming back, pre-operatively anything can be done. That is the question. We just write pterygium, but it's not that simple. We have to see how it's fleshy, atrophic, or it is very end, what is the age of the patient, and what is the pathology, bilateral, or it is both eyes, or lag ophthalmos, the blink, even the bells, how the bells. A lot of people will not have bells always up. They will have medial bells. The eye will be moving medially. All this you have to see, otherwise the recurrences all will be high. And you are treating very flushy one, and in young patients better to give preoperative cyclosporine for some time, especially for patients less than 40 years. And 20 to 30 years, there will be some amount of recurrence at the site. It's impossible. All will have some amount of corneal vascularization and some growth up to 1 millimeter. But less than 20 years, more than 50% will have recurrence. It's a very, very tough in young children for pterygium, because we don't know the pathology. We are just trying to pull off. The pathology will play its own role. So this is the one. So ocular surface inflammation, if there is anything, we have to correct it, we have to look for it, and you have to take care of that. It's very, very important. And the dry eye, that's never forget, the dry eye incidence is becoming more and more, and the Sjogren's is not that unusual as we are thinking. In my training period, it's quite common. We are seeing Sjogren's. They cannot swallow much. They will be taking water along with whatever they eat it. So bilateral and both eyes, you will be more, you have to take more attention for this. So surgery is pretty simple. We do on topical, except when we are doing under, local, we give a local, especially when the head is coming near the pupil. Never shave the head with a blade or a crescent. Just peel it off, because the central 4 millimeters is very, very important for the vision in the cornea. Remaining thing, you don't worry about that. Central 4. I saw many patients like this, they take a blade and they cut it, and the patient will lose the vision, whatever vision, and you can never. Just peel it off, central first, the portion. Never try to take a blade and cut that and do a lamellar dissection in the pupil area. Never touch it. Central 5 millimeters, no dissection, only peeling. So especially case like this, cataract, they come, it's quite common, it's not. So you see the pterygium is quite thick, atrophy, conjunctiva is keratinized. So this here we remove a little bit more and release the additions. You see the inferiorly, it's going up to the almost inferior rectus, that subtenon tissue which is coming, it's just going there. So separate it from under the medial rectus. Then how far you have to cut? A lot of people ask me how far. Up to the medial fornix. We have to remove the tissue up to the medial fornix. You have to pull it up to the medial fornix. You have subconjunctival tissue. You have to remove it. Remaining thing, as I told you, you peel it off, and whatever the surface, the best thing is the diamond burr, and clean it up with the diamond burr. Don't do a dissection. You don't try to remove opacity with a lamellar dissection. You will be spoiling the cornea and spoiling the refractive status of the eye. Then recurrent pterygium, and you did a surgery, then mitomycin when you want to apply, see, look at where is the pathology. The pathology is the subconjunctival tissue. So we have to apply there, not on the bare sclera. Okay, if you apply on the bare sclera, it will go for necrosis. Even if not, even after 10 years, 15 years, it will go for necrosis. So don't apply on the bare sclera. Apply subconjunctivally in the fornix. Mitomycin. Cover this bare sclera with methyl cellulose. And bilateral pterygium, not very uncommon, especially tropical country and equatorial line people in India. It's not uncommon. We do the same surgery. You cut the conjunctiva. We try to spare here more conjunctiva. See it, once you pull it, these attachments you have to release the conjunctiva, separate the subtenon tissue. Inferiorly very important. If you don't remove inferiorly, it's a subconjunctival tissue, the recurrence will come like from there. So that's very important. The inferior portion we have to separate and take it off. And as I told you that you pull it, put some traction and cut till the fornix. Don't worry about the medial rectus. Medial rectus is attached to the sclera. First you separate it, you can nicely remove it. Recurrent pterygium, yes, you will have a problem with the medial rectus. So because all will get fibrous. So remove a lot of tissue and just polish it with a diamond burr. Same thing on the both sides. It comes very nicely. Here there are polishing, you get a lot of tips available. There's a M and F. M is medium grit, that means the diamond bits. F means fine grit. You buy a fine grit one for pterygium. Medium grit you don't need much. It takes a little bit more time, fine grit, but ask for a F in the tip. So when you take the conjunctiva, we need two, okay? That don't take the conjunctiva big piece and try to cut it on the eye. That's messy. It's a conjunctiva cutting. So they design it on the eye, when in the eye itself to design two bits. So take first one bit of it, for one side pterygium. And you don't need to dissect here, just separate all the conjunctiva, except in very young people you cannot separate. So take a small bit, one bit, and you have to iron it out. Once you cut it, it will be curled like this. These curls, we have to open it up, make it, iron it out, spread it nicely, then put the glue, and don't inject all those things they give. Just take a 26 cannula, load it, and put few drops of glue, and the same thing on the right eye, right side also, other side also. So which side we need more, which side, that depends upon the pieces you take it, and spread it out and press and spread it out. Don't leave a lot of glue. If you leave a lot of glue, you will have post-operatively more edema. It takes a long time to absorb. You will have dull and everything problem. So iron it out. It's like what you are sticking, like just like that. They don't put so much vehicle to stick. They put a layer and press it. Same way here also. You press it out and do it. So this, you get a bilateral pterygium like this, ask the patient to look to the, especially temporal side, there will be some restriction what we found. Ask the patient to look to the nasal side, and if you see a folds, DM folds, you can see the DM folds up and down. Those then means you are having a tissue deficiency there. Unless you put extra tissue there, they will get diplopia post-operatively. So you should be very careful about this finding. You have to look for that on the temporal pterygiums. So post-operatively, usually my plan is first 1 week, 10 days I give dexamethasone, then I shift them to the loteprednol, and we do give timolol for 1 month to 2 months to reduce vascularization, tenous granuloma. Lubricant 3 to 4 months, cyclosporin 2 months. Usually it works very well in most of the cases, except when you are operating less than 30 years or 20 years, 5, 7 years, we have to change the plan in those young kids. Then if recurrence comes, you see a recurrence, what to do? The best thing that works is the 5-FU. 5-FU as it is available, no need dilution, nothing, take the ample, it costs around 100 rupees, less than 100. 0.1 ml, inject it directly into the pterygium recurrence head. You directly inject there, it will take care most of it. It won't regress, but it won't increase, and it will become white and flatten it out, 1 dose of. Avastin people tried, but it's a very temporary one, it doesn't work. The other one is triamcinolone. If you are a very fleshy one, you can use triamcinolone, but you have to remember 1 to 2 milligrams. You calculate whatever, the 1 to 2 milligram, not more than that. If you give it, they will get glaucoma. Then how to manage recurrent pterygium? That's the problem. Commonly we see case like this, recurrent pterygium. So my fellows, they come and say, sir, it's true pterygium or it is pseudo-pterygium. Shall I probably pass and write it? Whatever may be. So after surgery, pterygium has come. You have to remove it. It doesn't matter it's a true pterygium or a pseudo-pterygium, whether you are able to pass a probe under or you don't pass a probe. They say, I'm able to pass a probe. This is not pseudo-pterygium. After pterygium excision, patient got again. So it's a recurrent pterygium. So these are the cases. We have a lot of folds and all. These are quite common. This is not unusual. These are all the cases. So this is one of the case. This guy became medically unfit for a job and went for pterygium excision. After that, he permanently became unfit for every job. So they removed from the job. He got diplopia, no vision in that eye. So the temporal pterygium, bilateral pterygium, nasal side nicely fed. Temporal side, it's fully occupied, and he is not able to drive, not able to do anything. So this is the case. There is no fornix, temporal fornix. Directly lid is touching the limbus and completely. So this case, what we thought is there is no one. So we don't want to spare as much tissue, surface tissue available as possible. So instead of cutting at the limbus, we started cutting wherever is possible, closest to save a lot of tissue. So we cut the tissue near wherever is a available maximum number of tissue and separated. We didn't bother about the corneal clarity here. So just separate the additions. We have to do very slowly. These cases topically we cannot do it. Mostly we give peribulbar or subtenon anesthesia. This we cannot do under, it takes a long time. It takes around an hour. So release it. Now you got a huge defect. Already they removed conjunctiva superiorly for medial side and lateral side they removed. There is no much conjunctiva. Here when we are dissecting with because that ridge we have to remove, we are not going into the cornea. We are just on the surface only we are removing, leaving that opacities. We will deal with them with the bar. We can just, it looks pretty bad surface. Okay, don't worry about that. Bar will take care of that.
You need around 5 to 8 minutes, but slowly do it. If you are getting bored, you ask your junior to do it. He will be happy to do that, and because you are given a hand, slowly nothing will happen. It will get 5 to 7 minutes. You need, it will become smooth, at least pupillary area, if not in the periphery. Then to harvest conjunctiva. Usually these people, the other eye want to take it, they don't accept, because one eye is gone. The other eye also you are want to mess it up, they don't like it, they don't. So somewhere we have to manage from here and put it. Then whatever deficits that they're having, we use AMG for that. There is a lot of deficiencies there, so we take AMG and cover with that area. Some few cases we did even, there is a lot of deficiency, label mucous membrane temporarily. We take from lower lip mucous membrane, make it very thin, and those gaps we cover that when there is a lot of deficiency. And here, because already second time we are removing conjunctiva, so that area will get fibrosed. So we cover that also with the AMG, the donor area. So that gives ocular surface becomes quite very fast if you cover that. And this is a post-operative few days, and this is a pre-op and the post-op with full movement, nicely formed fornix. And he had a very good vision, because pupil central 3 millimeters, 4 millimeters we cleared. Whatever opacity is there is the only in the non-functioning area of the cornea. So complications. So the Dellen, as I told you, you put a lot of glue and leave it thinking it will stick very well. You will get a Dellen, because the edema is there, you get a Dellen. We have to stop steroids and put on a lot of lubricant, patch the eye, it will take care of that. The tenon granuloma, anybody can get it. In young people will get it. So when the tenon granuloma, don't keep on increasing, it doesn't work. You have to exercise only. You have to exercise, there is no excuse. You can keep on telling patient, second surgery. Even in OP, you can put a topical drops, take a scissors and snip it off in slit lamp. Otherwise, you take to theater and snip it off. Little bleeding will come for 5-10 minutes. Put a brimonidine eye drops, alpha-gan, 1, 2 or 3 times, so that reduces the vascularity and clotting very fast. It will clot. You have to exercise tenon granuloma. There is no point in using more and more steroid. Little bit recurrence, okay, you can leave it. Nothing to worry about small recurrences. You don't need to reoperate those cases. Just put on cyclosporine, they will settle down. And this is interesting 2 or 3 cases I will show you. This one patient came after pterygium surgery. It looks very nice. So patient lost the vision. So lens is clear. So patient, he says, I lost the vision. It's almost 7 years, 5 years back operated. When you look at that area where pterygium excision was done, there is some tissue extra. So we thought, okay, let us do anterior and what's interesting. So you see that the thickness is 860 microns, corneal thickness where the pterygium was operated. So there is a lot of hypertrophy in that area. And the other area, the opposite sector, 500. So you have 300 microns extra tissue sitting there where the pterygium was operated. And topography, you see 10.5 diameter of astigmatism. So, and the entire became flat. What we have to do is simple. That area, you don't need to do anything. Take a diamond burr and polish it off. That it will take care of the case, and apply metamycin for 1 minute. And this is another case after pterygium excision. So patient with cataract and defective vision. So we did again anterior. There is a thinning. Instead of thickening there, here we got a thinning. Doctor is enthusiastic. He want to remove the opacity. Did lamellar dissection, remove the cornea. So luckily the astigmatism is less than 5. That can be controlled with toric. You don't need to do anything. Toric IOL, you put it, the patient will be fine. And this is another case posted, 4 diopter of astigmatism. Then I saw the patient, topography. See, this is not as regular astigmatism. These simple terms we call it irregular. It's a coma. You see here 40.4, opposite 46. So one axis, opposite sides, one is 40, one is 46. This toric lens doesn't work. So we did again diamond burr polishing this case. Astigmatism dropped down to 1 diopter after 1 month. Then we did a plain spherical IOL. Patient came with 6'9". So this is a pterygium. It is a very simple surgery. We will make it because pterygium looks very simple. We want to make a simple surgery. Actually, it is, but you should not make the things very simpler and land up in trouble. Thank you very much.
Thank you, sir, for the keynote address. Though it's a simple surgery, it's sometimes complex in some people's hands. Most surgeries, even complex, is very simple in your hands. So the hands makes a difference. So from this, we'll go to a little session on panel discussion on few of the common topics in cornea.
Sir,
case of large biheaded pterygium, there is hardly any normal conjunctiva sometimes to harvest for both sides. So if you cover one side with amniotic membrane post-operatively, do you recommend using cyclosporin drops?
Both sides, yes, what you are telling is large pterygium, you remove it. But first of all, pterygium, there is no need to remove conjunctiva. We have to remove only subconjunctival tissue. If it is primarily you are doing recurrent pterygium, that's a different issue. Already they removed, you cannot add. So the primary pterygium, don't remove any conjunctiva. Cut it very close to the attachment. So save whatever may be, you save all the, only remove subconjunctival tissue. Then, yeah, that you keep it. So there you are very little only you need. So, but always is better to put a conjunctiva near the limbus, not on the limbus, 1 millimeter from the limbus, you cover the conjunctiva. If there is a defect between that and the bed, that you can convert with AMG. Pure AMG will not work because it cannot supply any tissue. We need a tissue and cells growing. AMG has no epithelial tissue. So we need something to supply epithelial tissue. So put some graft and gap as we did in that recurrent pterygium, that you cover with AMG.
AMG, is it recurrence is higher in AMG? Which when compared to the autograft. So AMG is not alone is not enough.
The world is the reimbursement, Mediclaim in US or reimbursement, CM reimbursement scheme in India. If you put a congenital autograft, they pay you 10,000. If you put a AMG, they pay you 15,000. So every doctor, so because naturally who want to do a less surgery? Same thing in Mediclaim in US. If you put a AMG, they pay $1,500 extra. If you don't put a AMG, they pay $1,500 less. AMG is fine, $200, $300 there. So you make $1,200 extra by putting AMG. If you put a CAG, you will be losing. So they are so AMG became a common surgery across the world. You see statistics, but surgically results are inferior.
Any other audience questions on pterygium while Dr. Arjun is getting ready?
Sir, you said like it's better to take two pieces if both sides nasal and temporal this thing is there. See, when you cut vertically, would you be, what about the stem cell part of it? So it doesn't matter. Okay.
We'll go to a few of the common topics. I've kept mostly topics which will come to a general OPD practice. Just an overview of what to do. Since we have expert panel here, how to manage in a general scenario. So the first of the topic is allergic conjunctivitis, which is a very common thing to see. I would like to know from the panel. So there are many types of allergic conjunctivitis, which from mild to very severe. So what are the findings you would look for to understand which will be more severe, which requires a long-term management? I'll also like to welcome Dr. M.S. Ravindra sir, who has joined online for this session also. Madam, you would like to?
In mild cases, we routinely see some amount of conjunctival hyperemia in the palpebral and bulbar conjunctiva, along with the symptoms of itching. In chronic and severe cases, we can see the cobblestone papillae, the limbal changes, HT spots in the limbus, limbal thickening, and from history also the chronicity of the symptoms. And in chronic cases, again, some amount of limbal stem cell deficiency also may be there, leading to some vascularization of the limbus.
Sir, would you like?
Yeah, First, when our patient is kids, they are very troublesome. You know, these cases, they don't allow you to examine and do, put a drop of paracaine in kids. There is nothing going to happen. Then they allow you detailed examination, both eyes. Put a drop of paracaine. Then see this limbal variety or a type of palpebral or mix. If you say mix, you are in trouble. That is a severe form. It is going to take a long time. We have to counsel patients, and both of us will be seeing for 5 to 10 years. Then, so they will be also be happy. If it is one, it's a tarsal, it's reasonably okay. We can manage and we can just give, make them come one. If it is a limbal, again it is a in between. Limbal variety also runs for a long time because it's exposed area in the conjunctiva. So the limbal allergic conjunctivitis also goes for 4 to 5 years, 6 years, once in a 6 months checkup. So like that I classify depending upon that. First itself I will tell the patient this is a severe condition or is a mild condition. So whatever I understood, I will tell them. So 80% of the time it works, 20% of the time I go wrong. That's a different issue. So the first day itself we will tell them, this is the one, this is the course you need to come, or you willing to come, or you go to nearby doctor, manage, you need a long course. So that's how, then depending upon the drug also we select like that. Mixed case, ultimately we have to go into with tacrolimus, at least 3 to 4 years, once a day, alternate day. So these are all we explain first is sitting itself. If it is only tarsal, okay, it doesn't matter. Cyclosporin drops 3-4 years, it works, and they will become normal. Limbal again, you need tacrolimus for at least 2 years. Mixed variety goes up to 4-5 years also. So all this we explain in the first set of it.
So, same question I want to do. A maximum period to which you probably might have given tacrolimus or cyclosporin.
5 to 6 years.
And so, do you make it intermittent? That means if you start, you give it for the whole time, or?
Yeah, first if severe case twice a day, otherwise once a day. Then once a day at least 6 months to 1 year. So when the child they say very comfortable, or they have to tell parents. We don't need to tell he is all right. They have to tell he is okay now, reasonably good. So when they volunteer for that, we go for alternate day, once in a week, once in a 3 days, like that. So we teach them. There's nothing like our professor teaches. We teach them, parents also, how to use it. So they manage. They manage once in a week, once in 15 days. Sir, MS sir, your thoughts? Audio is not coming. 1 minute. Audio we are not able to. Hello? Sir, audio, sir, mic, check the mic, sir. We are not able to hear you.
So there are some kids below 6 years coming with the severe form. So do you recommend cyclosporin under 6 years of age?
But officially, labeling wise is cyclosporin from the age of 2 years approved for human use. For tacrolimus it comes, they are giving 8 to 12 years. Some countries 8 years, some countries 12 years approved usage. Only issue with the tacrolimus, the cyclosporin is allowed from 2 years onwards. So no issue for even oral, so we can give it. So that depends upon if you are very much worried. Twice a day cyclosporin doesn't work. You have to give at least 4 times a day.
What about the higher dose olopatadine? Nowadays, many people are pushing for that.
See, this is olopatadine or alcaftadine. These are all for only seasonal allergic conjunctivitis. They don't work for weakness. This is chronic, permanent one. They work for only just for when the pollen comes, they will have some irritation for 15-20 days. Fine. You give them more than 1-2 months, they get a hyperactive reactive status in that. Unless you put steroids, you cannot make them comfortable.
So 3 weeks, 1 month to 2 months down the line.
That's all. 1 month. If it doesn't work for them, then you have to shift to one of the immunomodulators or steroids.
And you stop off the antihistamines, only given on a periodic basis. So I wanted to ask this one, that there are around 12% mostly, if you see, mostly this burns off by 16 to 18 years. But there are few set of people who still go beyond. So I've seen few of the cases where I have to send them for immunotherapy just to see what it is, and mostly it comes as this dust mites. They are the perennial ones. I want to know whether panel's experience with immunotherapy, whether it has helped them along with their topical management, a systemic, sublingual, or a subcutaneous immunotherapy have started together.
Multiple allergens come up many of the time, so then you require desensitization to all of them. So what I have experienced is they don't follow up. They go for one or two things. After that, they get frustrated and they don't go for the remaining.
True, madam. That is what same experience for me. One of the patient has, I think she's allergic to life. There are 15 to 10 things which she is allergic, including cotton fiber. And once she rubs her eye, cotton goes into her lids, and then you get a pseudomembrane where the cotton is there. So now she is on immunotherapy. I wanted to know whether, sir, you've tried, in any of the panelists have tried any omalizumab or any other monoclonal antibody for such like severe cases.
No.
Price is coming down. There are some Indian companies, so they are promoting like anything now subcutaneous. The problem, not the problem, that's became a standard method of treatment in US and some European countries. Subcutaneous once in 6 weeks we have to give for 3 to 4 years. Each dose is previously around 1.5 lakhs. Now it is coming for us maybe around 10,000, something like that. Similar drug, biosimilar. So that is the treatment. Severe cases, I think definitely we have to use it. I never used, to be frank. We are looking into that.
So Ravindra sir's thoughts on conjunctivitis.
It's not very popular in Coimbatore now. 3 or 4 doctors started, so we are sending them SLT. They are telling 40%. They got a good statistics. 40% of the patients are 30% SLT, not 100%. They do respond, so they become much better, but it's not zero. They don't become normal. It's not like a fever becoming normal. So they become better over a period of time. So SLT, that they are, Bombay is very popular, Bangalore is very popular. Kochi also it's becoming popular, but Coimbatore just started, so we have to wait.
So I'll move on to the next topic. Another very common topic condition you come across is conjunctivitis. There are different ones, subtly different. I'll start with, I would like to know the panel, when do they suspect it is really viral? Asha madam.
First of all, more of papillae and a few follicles, that and then congestion, severe congestion. And viral conjunctivitis, there is, if it is adenovirus or picornavirus, there will be a few punctate hemorrhages in the upper tarsal conjunctiva. Mainly you have to look for that. That is how mainly we differentiate. Other one, discharge will be there. Bacterial, usually there will be a discharge.
Mostly serous discharge and mucoid debris will use. So do you see any change in trends nowadays that some of the conjunctivitis, I see few cases coming with early KPs?
Nowadays, we, at least within 1 week, most of the patients will develop punctate keratitis. So that is, and sometimes it takes longer time. Some patients,
3 weeks.
3 weeks, that is a standard period. Some patients I have seen even up to 6 months to clear that. Even up to 6 months or 8 months it takes.
So I want to know what your strategy is for patient comfort. That is the biggest thing, because probably viral, it heals by itself.
I usually give minimal steroids, that is tobramycin usually and fluoromethalone, that's a combination I give. And then CMC, lubricants, that's the initial treatment I give. I don't use more antiviral drugs usually.
I want panel's opinion.
I usually wait for 3 to 4 days before adding a soft steroid.
Okay.
I think there is an increase in SPKs and immune infiltrates if you start steroids too early.
Any antivirals you will prefer?
Routinely I don't prescribe, but there are many general practitioners prescribing acyclovir In some studies, it is shown to reduce viral shedding and easier recovery. I have no personal experience with ganciclovir.
Sir, do you start, sir?
Back, there is a US also, they did a trial, adenovirus, adeno kit. You do adeno kit and they supplied, we did a trial for adeno kit positive, put on ganciclovir, adeno kit negative, you don't put them. Or the other one is betadine dexamethasone study, all we did it.
Yeah,
But in India,
what I
adeno
want to
kit positive, 1 in 10 only is coming. Out of 10 patients, 1 only coming adeno kit positive, remaining 9. So the studies became failure.
dilute betadine, I wanted to ask you, sir. This is one option.
MS Ravindra uses a lot. We are not using right now. He puts 1 ml of the betadine in lubricant and gives 5 times a day. No antibiotic, nothing. He just gives that and he says.
Used for my staff once because of this.
But
Again,
direct you cannot give.
Yeah, sir. 5% betadine which comes, we try to dilute with 1 cc syringe and started for 3 days. But actually, I felt the recovery time was less. That is the only thing. But symptoms you should.
You find no difference.
So, no, sir. At least the time to recover was much less. Even the other patients which were on antivirals, I felt these patients recovered much faster without much SCKs or SPK.
That's what we have to understand. Either we are giving at least 6 to 8 times antibiotic, some quinolone groups. Whether these are the cause for exaggerated symptoms, we need to think, because when we are giving betadine, we are not giving quinolones. Okay, we are giving only betadine there. So whether this giving moxi, gatti, 7 to 8 times a day, already inflamed conjunctivitis producing more problems, so we need to think. Just if you give also antibiotic, just give once or twice a day, twice or 3 times, not 6, 10. I saw a lot of prescriptions 10 times a day, every hourly. So entire thing will get necrosed.
So again, steroids, I want to know whether, what is your indication for steroids? Do you put it early or do you delay?
I usually give, because the patients are, if I give plain it's just a lubricant, the patients are not comfortable. Most of them are working and it's a long process and the school children and so once mild steroids are given, the patient becomes more comfortable.
Do you feel any of your steroid patients gets more SCK? Is there a...
No, usually when I see the SPK, then only I start the steroids. Plain viral conjunctivitis, usually I give, if it is an adult patient, I give ketorolac. Ketorolac. And children, we cannot give ketorolac, so plain antibiotics I give. So this, I'm starting steroids only when there is an SPK. Or if the patient is not comfortable with it, it's not resolving with the fluorocathalone, then this ketorolac, then I give the steroids.
I think sir has already mentioned subepithelial. You start tacrolimus or for the same period of...
It's okay, it's not bad. This case responds very well. But sometimes we'll have a very, even then it is a central area. So what you are saying, the patient will be very symptomatic. He needs a tacrolimus. Again, you train them once a day, twice a day. Then once it goes up to 6 months, 1 year also. One doctor is there somewhere. Here only one radiologist. We used her for 4 years because she initially our professor ophthalmology, she put her on prednisolone. She came with 45 millimeters of mercury IOP along with anti-glaucoma medication. Stopped it and put on tacrolimus. She used for 3 to 4 years. Now absolutely clear cardiac.
Any preference between the drugs? Cyclosporin or
Cyclosporin doesn't work. It's okay. For mild, it's okay. This much, it doesn't work.
Initial phases, these patients become symptomatic when the scars develop some subtle edema. They complain of light sensitivity and all that. But after 1 or 2 years, they stop complaining about those symptoms, but the scars remain, compromising the visual acuity. Any insights about PTK in such cases after 1 or 2 years?
So when the patient is not complaining, you should not treat, number 1. When the patient is comfortable, why you want to treat it? When the patient is not complaining, why you want to treat it? Because just you see a scar, you want to remove it, it doesn't make any sense. Patient should complain that I am not having a vision. Even patients are complaining with the subnummular keratitis, central dense one. So when we took a topography or this anterior and all those things, it is not the question of opacity that's forming. Where the opacity comes, there is a necrosis of the tissue, disappearance. So there is entire topography is flat there. You have a 35 millimeter, 35 diopters, 28 diopters in the central area. So you cannot steepen it. So they are, unless you put on contact lens, they are not going to be.
I will come back, MS Ravindra sir.
Sir, can you log out from the computer because the echo will be there? You're muted, sir. Can you unmute?
How about now?
Yeah. Yeah. No, the echo will be there if you're joining on two devices. Just log out from the computer.
Yeah. I'll do that right now.
Yeah.
For the want of time, sorry.
Okay, I'm sorry.
Another thing to look for, most commonly, a lot of people will come with SPK, and if it is not going down, always think in terms of microsporidia. These are very common in our population, especially after the rains with contaminated water. I want to know how commonly you come across. This is one of our own patients here in Calicut. After scraping, you can see that small smear downstairs is showing the multiple microsporidia. That was a stromal case, but this is more of an epithelial case. So what do you look for to identify that as microsporidia? Other than mostly coarse SPKs, I want to know the panel's experience with how commonly they come across microsporidia in their practice.
It is not too rare. Some patients working in paddy fields after exposure to muddy water in the fields, they come with a presentation which is similar to viral keratoconjunctivitis.
Okay.
Initially, we treat them as viral keratoconjunctivitis, but then history of remissions and recurrences, then you should start getting suspicion of microsporidia. You can try fluoroquinolone drops. Also, fluconazole drops is said to have some effect. I have not tried oral albendazole that is recommended. Sir, any opinion on that?
Intermediate organism, microsporidia. It's so these any intermediate organism like epithelium, microsporidiasis, all those things. There are few azithromycin, antifungal, fluconazole. These things they are supposed to work on these patients. So as you are telling, rainy season comes, you have a few cases, not very much discharge, mild discharge, a little bit, and this one, and that is a stuck on cornea appearance, where the peripheral cornea is good, only you can see this as though you painted them within a pen. So those are the typical findings we think of microsporidia. Whenever we suspect, as you rightly mentioned, we start them on fluconazole. But that too not 6 times a day, again 3-4 times. For 6 times again the conjunctiva will become a hyperepi and a problem, 3 to 4 times. And overall it looks like for all conjunctivitis, azithromycin is a good choice after topical drops in general. That's not my personal feeling. Now we are shifting to azithromycin for all cases, any conjunctivitis without diagnosis. No topical drops. Instead of quinolones, tobramycin, and all these things, azithromycin looks like a good choice, twice a day.
To scrape off those lesions?
It's a little bit risky. Microsporidia epithelial disease very rarely becomes stromal, very, very rarely. So it's a spontaneously they get, because they like only, microsporidia likes only epithelium, it doesn't like stroma. Bowman's it cannot penetrate, so it will keep on eating the epithelium only.
Another common thing to come across is in OP is recurrent corneal erosion. And everyone gets one patient who's recurrently coming back also. I want to know the panel's experience, MSR's experience, what you look, Ravindra sir's experience of what you look for in your initial evaluation, whether you look for any other features and decide what kind of management will be required based on the history and the findings. So you're audible, sir.
A big headache for a practitioner. Many times it heals up when there is small episode of some other pathology in the lids or viral bacteria, whatever it is, residual neurotropic changes can also give rise to erosions. It can be toxic, it can be reasons for that. Location of erosion is very important to diagnose. Of course, we do the corneal sensations with the endoscope rotten to see whether etiology, and basically it's like investigation of all the factors that cause dry eye, that cause myelinitis, that cause infections, that cause viral disease. Especially if the patient is already treated with antibiotics or steroids or lubricants, the picture will change. The original picture will change. Many times we stop all the medicine. What happens to be in a day or every day, we can follow it up and say exactly where it is. Fluorescent staining is very important. Symptoms are very important. Like and then stain the make it a habit to stain the epithelium every day. Fluorescent pattern. And that gives the progression of the disease. So, the proper blinking, lubricating drops, and withdrawal of toxic, like they keep on putting moxiclox, which is highly epithelial toxic. These are the things. For real bad cases, same area, you are seeing the epithelial erosions, and they for multiple weeks, multiple months, they keep coming back, tearing or lose epithelium on that side, on that area. So then the treatment becomes quite aggressive.
Sir, JK sir, see one real common thing that we find is fingernail injury from kids and all. See, that is something that we are seeing very commonly. Sir, in your opinion, diamond burr is the go-to. I mean, you use diamond burr quite frequently, and so if you're using diamond burr, so my queries are like, if you're using diamond burr and removing that area, epithelium from that area and whatever subepithelial area, are you going to concentrate on just that area, or are you going to remove the epithelium from the entire cornea when you're doing this?
The thing is, you apply topical drops just in the operation room. Take a dry sponge, though not wet, but dry sponge or dry, but not the wet one. So cell sponge, dry one or wet one, then put on the epithelium and wipe it off. So whatever loose will come out. So most of the times this is 3 to 4 times more than what you expected and drawn on the slit length. This is a very wide area which will come out. Only thing is breaks down there in the center, but a wide area will come out. So whichever area is come out, that area we have to do. You can do PTK, you can do diamond burr. Most popular now is around the world is PTK. But we found that PTK sometimes it's a little bit more painful because they one, and another thing is sometimes PTK we are not able to reach up to 9 millimeters limbus because it restricts 8 to 6. Now new machines are giving up to 9 millimeters. Otherwise they restrict you to 8 millimeters, 7.5, 8 millimeters. Beyond that you cannot go. And PTK 10 microns or 7 microns PTK works very well. And diamond burr is very simple. Every day we can use it.
Do you do across the visual axis, sir?
Yeah.
So this is one situation you can safely do across the visual axis. And
yeah, and see, I keep on listening to podcasts. There was one where there was an interview with a very senior corneal person from Canada. So he was doing PTKs. See, as people who don't have access to the LASIK machine or laser machine, probably it might be a good idea to give a try with diamond burr, because I've seen some eyes with those multiple punctures with this thing, and when you see those spots. Here, once this is done, it is okay. See, JK sir has been showing this quite widely, and once there was a patient who kept on coming, and I sent it to Sujit. Sujit said, Sujit Nayanar. He said, sir, I have stopped doing lasers for this. One, it is expensive, and Diamondberg is giving as good results as the laser. So probably, this CME I've basically planned for people like me and us. So probably this is, and I've recently bought a Diamondberg, and it costs about 5,000, 6,000 rupees, and that's all. That's all. And the only thing is that you have to decide on what size of the Diamondberg, sir. Would you, if you're just buying just one, JK sir, which 2 mm, and that 2 mm can be used for pterygium also. And I've started doing it, and it's wonderful. Arjun, because we are
short of time.
Running short of time, we will stop this session. Just one more query. Would you be using this for the rust rings?
Right now we are not using. The 1 mm, there is a small 1 mm. That is not diamond actually, that is tungsten bar. They call diamond bar, the tip is tungsten. 1 mm they don't make in diamond, tungsten tip. That one, Arvind Pondicherry, they are using extensile duct Venkatesh. We are not using, we are just ordered it, and it looks like it's a good choice.
But I've asked around, they say it's not as effective as diamond for other uses. And with your permission, we'll wind up this
I thank
session.
my panelist. And
the mementos. Ranjini ma'am.
Dr. Ranjini ma'am, to hand over the memento.
Dr. Srini, I just wanted to add one word.
Yes,
I've tried needle punches with 26 or 30 gauge needles in that area. Next I've tried, which works really good, try it out, is Yaga. So focus it on anterior epithelium, or it's not exactly focused, but it may give certain birds in the anterior stroma or in the air in front of it. Somehow it doesn't get focused in the anterior epithelium, but then you cover it up with Yaga laser. Again, it's free, it's available in your clinic, and you can try it out. It gives wonderful results.
Thank you, sir. Thank you.
Thank you, sir.
JK sir.
Dr. JK Reddy, sir. Dr. Lata.
Lata ma'am.
Dr. Seema.
Dr. Seema. And finally, Dr. Arjun. Ravindra sir, please stay online for the next session.
I'm on mobile, right?
Yeah, that's okay, sir. You join for the discussion, sir. Presentation is fine. Okay, so. For the next session, we have one of the greatest ophthalmologists in India, Dr. T.P. Lahane, and sir has done so much for ophthalmology across India. If government of India wants some changes in policies, they go directly to Lahane sir, and he, in all administrative capabilities, we would require him to be supporting ophthalmologists across India, and these are his credentials and accolades, and we all know about sir, and he's such a wonderful surgeon, and sir will be doing the keynote address today. And I've already introduced MS Ravindra sir. Me and Srikanth had actually gone to see him operate. Such a wonderful, such steady hands, and topical SICS, and another great person who does that is with us, Dr. Shashikumar, and his session is going to be really great. I'm actually looking forward to Shashiatan's session, and Dr. Jason, I would say still he is the best phacosurgeon, among the best phacosurgeons in India. Super hands, and such a wonderful person, and Jason will be and one of the nicest persons. Such a ma'am is here, and she's a person whom you should really know, and sir and ma'am does that BOA conference, and it's such a, see, you imagine for a conference nearly 3/4 the attendance of AOCs. So that is that huge, and I saw that OPL there. See, we had stopped OPL in Drishti for a long time. I saw that the kind of attendance, that is why I started OPL in Drishti last time. And Dr. Srikanth, my brother, and he is definitely one of the topmost cataract surgeons in Kerala. And Dr. Arvind, our own Arvind, he has now got a multiple chain of hospitals, and he's is a wonderful surgeon. And Binu, the dynamic Binu, arguably he is running one of the top eye hospitals in Kerala now, Sunrise Eye Hospital, and JK sir, my guru, he is also there in the session, and I'll also be there, and I request Jason to take over, and we'll do one thing. We'll start with sir's keynote address, and then Jason will start the discussions. Sir.
Thank you, Srini. I just came because Srini is my friend and he called me here. So now to speak on the cataract in 10 minutes is very difficult, but definitely now I will go ahead and what is possible. Yeah. Okay. So now these are all the soft cataract videos, so I will not show this. I will go to the, okay. Now this is the hypermature cataract video I am showing you, and see here, I am doing the rexis, see here, and see the after the light thoda yahan ka band kar sakte ho, so the reflection will not come, and see now I am going inside and there is a Argentinian flap. So what happens now, now don't pull like this, so now first cut and extend. Now once you do that, you will do phaco or not, so I want to tell you something. Now look at this flap, the flap here, can you see this flap is moving, you see this anterior capsular flap is moving. So this, the movement of the anterior capsular flap, it is there, that suggests the extension of the tear is not in the posterior capsule. If these movements are stopped, it is a Rohit Om Prakash. If the movements are stopped, that time there is an extension, and this extension is behind. So you should not operate in that case. You should wait, bring the nucleus in the anterior chamber, and by SICS technique, you should bring nucleus out. So whenever you are doing this, always remember that you will see this. Now this is the white cataract. इसको चालू कर सकते हो? नहीं है? Okay. Yes, it is. Okay. Now, ठीक है ना? So this is the another cataract, the brown cataract. See here. So whenever we are doing the brown cataract, you can see the capsule is going on one side, and another thing is to the slightly larger axis, because the can see the in brown. See here. Now what I am doing is, can you see this? It is a posterior capsule. See the leathery fibers I am separating, and you will see the I am going in. See the both these instruments, and in that I am separating it. Can you see this? It is a separation again. Again the it is not required that there should be 4 pieces. Again the posterior fibers I am separating, and once that posterior fibers are separated, see here again the fibers are separated. Can you see this? And once the fibers are separated, you have removed one piece, then there is a debulking, and then you can do the such type of cataract easily. Now the another case is the direct chop. This is the always choose a cataract where there is a slightly whitish element. If there is no whitish element, then in such situation you should not go for the direct chop, because the posterior fibers are not separated, and so unless and until you have got an experience, you should not go for the direct chop here. See here, some of the fibers were white, and so we are able to see here, able to separate it. Only thing is that whenever you are separating, in that you must separate it up to the center, and piece should be removed. Now one piece has came out, then only for the last piece you should take care of that. Otherwise nothing to worry in this. So this is the another cataract. Now you know this is a same type of cataract, so I will go see here to the other cataract. Now see, this is the isko running नीचे नीचे होगा. हाँ नो उसका ऊपर वाला ओके नहीं पहला गो बैक. हाँ इसको चालू करो. नीचे नहीं है. ठीक है. हाँ now it is working. So now see, this is the see this type of cataract, black in one. So such type of cataract, don't go for the chopping. Here it is very difficult to chop. So I am chopping because I have operated more than 75,000 phaco surgeries. So here you will see I am going up to the center. Again I am going on the other side. And it is always better to go for the stop and chop. Instead of chopping, in this situation, stop and chop is always better. But if you have got a see here, if you have got experience, then you can definitely do it. Then the machine, it is not the centurion required. Any machine you can do it. Only thing is that you should have experience how to chop it. See here the chopping, you can see the vacuum there, what I am using, the longitudinal and torsional phaco, both I am using. And then you can see I have removed the one piece. Once you have removed the one piece, then there should not be any problem, and that you can complete the your Okay. See now this is the another cataract. It is not much harder variety, but what I am doing is you have seen the rexis, and once you have seen the rexis, then I am doing the trench. Here you will see the trench is done, and this trench whenever I am doing, here you will see again I am rotating it, completing the trench, and once I have completed, you will see properly I am separating. So I have separated it, and always remember, if I made the trench and if it is not getting separated, you will waste your some time in making the pieces, separating it, and then you can remove such type of cataract. Otherwise the, see here, because the two instruments are not working together, and so it was not coming, and the piece has came now. So here then the, इसको चालू करो. हाँ. Okay. Now see this, इसको थोड़ा बड़ा करो, इसको थोड़ा बड़ा करो. उधर से प्रेजेंटेशन मोड में कर दो उसको. हाँ, एक मिनट. हाँ, okay. Now see, this is the me only operating. I want you to see how it happens. See now, I am doing the trench. See here. And you will see there is a PCTR. So when it happened, so there is a PCTR, lens was not so hard, but see my tip, the tip has gone down. Can you see this? The tip has cut the PC. So always remember, so it is not a fast surgery. So it is a surgery where you can prevent your, see here. Now what I am doing is, when it happens, I am doing the vitrectomy, and then see, never too deep trench, and that will not help you. So now see, this is the, can you see the capsule? So zonules are very weak. Can you see this? I am trying to do the, can you see this? The very weak zonules. And when these weak zonules are there, go on the side where slightly stronger zonules are there. And in that side, then once you are done, then the side where the zonules we were unable to penetrate inside or remove the capsule, see here, automatically it is coming, but it is coming by his opinion, not by my mind, because those area is the fibrous area. Only unless and until you can go for femto, it is not possible to do by your hand, because that is fibrous area. Only thing is that it should not go to the this one periphery, that you should see. Now see, the whenever you are operating, you must see the tip, phaco. See what happens, the nurse, she is there, she is taking care of the tip, and when you are operating, the tip is broken. So it means you must calibrate phaco yourself and see, there you can work. Now see, आवाज बंद कर. See now here, this is the subluxated lens. Can you see, this is the subluxated, and then there are so many speculations when to put CTR, when to put segment, so many speculations, but that time whatever comes in our mind and whatever we have seen, we do accordingly. So now I have implanted the CTR, and once implanted the CTR, now I am doing the phacoemulsification. So iododissection is done, and then I am doing the, see here, phaco, but you will see the nucleus, there is no any support. So when there is no any support, you should not continue phaco, because this may go behind. So what I am doing, I am using the hooks. Are they capsular hook? No. These are iris hook. Every time it is not possible that you may have capsular or may not, but yes, iris hooks can also work, and here you will see I am doing it, and it is a support of the iris hook. and this iris hook is supporting, and by that, see here, I am doing the, can you see, this is the, by just you can say the removal, and what is helping me is the iris hook, and that definitely see here. So because of the iris hook, I can complete it here. Here I will see the, I have completed, and you will see the, I am also, this is my aspiration cannula, we have made it in 96, so that can be used instead of irrigation aspiration. And then the, so whenever you are doing such type of thing, first you stabilize the bag, and after stabilization of the bag, then you can go for the, this is the one, this one, this is the hypermature cataract. And see now the, what I am doing is a femto type of the rhexis, means I am using the poor man's femto, that is a scissor. I am cutting with the scissor, see here, because it is a fibrosed, it is not possible to do the rhexis. Now I have completed the rhexis, and now can I do phaco here? No. Then always remember one of the person who always speaks, that is Amar Agrawal. Put Amar Agrawal behind. It means I will scaffold. There is a, you can say the, this is a foldable lens because bag is there, and this bag is supported by the lens, and once that is supported by the lens, then you are now do that. But only thing, whenever you are doing, you will have to put visco minimum 3-4 times. Otherwise second day, because here you are doing slightly in the pupillary plane, also some in the anterior chamber also. So second day the patient may have very dense visco, so we'll have to take care of that. That when once you put a visco, and in that again gradually you make the separation of the nucleus, and as it is hypermature, though it is small, it is hard one. It is always hard cataract. So I am just, you will see the brownish appearance of the lens. I am just removing it, and can you see this now again? So again put a visco, and after that take it. Otherwise the cornea will be in the problem. So on the second day. So cautions, always, though the rhexis is difficult, you will have to do it properly, and after that scaffold helps in such type of Marganian or the hypermature cataract. And the last case I will show, and then I will finish my presentation, as we are very late. I brought so many cases. Okay. So this is, I think the, we have seen, then the, but dealing with complicated cases, now I will not show this. Go ahead. We have seen that. This is, I am contesting for the vice president election. Your support is required. I want to tell you about the other thing, that in Mumbai, there is to be maximum cases on the consumer cases on the ophthalmic doctors. KK Mehta used to be 60% in the court and 40% in the clinic. It means every time those who are rich doctors, they are always in this, because they want, the advocates want the money. It is not a patient only. And when I took over in 2004, that as a BOA president, then I just investigated what is happening. One of the doctor in Thane told one of the patient that lens inside your eye is opposite. It means upside down. And because of that you have a glaucoma. And that patient went in court of law. I asked that patient, who told you? He told the name of the doctor. And then in BOA, I called that doctor on the dais, and I gave a big bouquet to him. And I told him, I have never seen a person doing such a great research in the life. What is the research? Just putting the lens opposite, it means ulta. That gives a glaucoma. -2, -3, -4, okay. Refraction may change, astigmatism may change. But glaucoma, I have never seen. The lens is in the back. how can there be a glaucoma? And then publicly I have, you know that what I have done. And I told him that tomorrow if that patient is not taking the case back, I will see that not a single patient will come to you. And he removed the case. From 2004 till date, there is not a single consumer case against Mumbai ophthalmologists, not a single. Why? Because we criticize our colleague. Why? I don't know. You see IAS, you see IPS, you see any other advocates, even you politicians, they never criticize each other. Only they criticize outside, inside they are alone. They are together. Only the doctors, I don't know what gene has entered in the doctor, and that we criticize our colleague like anything. See, in this era, we should be together. If he is your enemy, don't do anything. Be neutral. Don't help, but don't criticize. And if you do that, the doctors will be successful. Otherwise, maximum cases. Now see, if the bridge is collapsed, is that a negligence? No. But if lens is in the vitreous, that is called negligence. Why? Because there, nobody is there to tell कि ये negligence है. Cement नहीं डाला था. There was no cement. Nobody is there because they all are together. But for us, अरे तुम्हारे आँख की तो लगा दी. Why? Don't do that. Be together. Love each other. If not love, don't hate. Thank you. Thank you very much.
I request Jason to we will be starting the lunch now. Whoever is hungry can actually take the plate back inside. Yeah. JK sir. Sir, what is your take on flax status of femtosecond laser assisted cataract surgery? What is your take on it now?
See, when Pheku came, that time we were criticizing that SIC is better, and then we were criticizing Pheku. But see, anything which is a new thing coming, as a can say research, okay, that is not a complete surgery. What we are doing today is we are providing money to the machine makers. It means I will trace 30,000. He is paid by us, and I think that is there. But yes, it is a development. It is a research. Something will come out, and one day we will just, you can say, remove the cataract just by making a small pieces, like we aspirate it, and the lens will also come like a liquid lens, and we will replace the physiological lens into physiological structures. So this may happen. So I think this is a change, we should accept it.
Thank you, sir. Ms. Ravindra sir, can you unmute and see, I mean, it's unfortunate that the presentation is not happening, but what I actually wanted from you, sir, is see, we are all doing topical surgeries now, but the way that you're doing it on SICS and the smoothness, there are a lot of PGs here and juniors here. I want an advice for these people as to what all care they should take when they are actually moving on to topical phaco.
Yeah, my apologies that I could not join in person, and then my presentation, though it's played in front of my system here, I can't share it. But if it is possible during lunchtime, you can put it on. I have mailed the whole presentation to you on your email address. If it is possible, if the time permits, just let it run. There's a small video also. So basically, you can understand where does the pain come from. I've worked a lot for a couple of to understand where the pain comes from. One is the lids and the lashes. So even if you touch the lashes or lids with your cannula, just to tuck the lashes inside, the patient will wink. Anytime the patient is winking, that means he has got sensation. It may not be pain, but sensation. Your duty is to start the surgery and finish it without patient knowing that we have done the surgery, or we have started, or we are through it. That is the ultimate aim, which I can show you it's possible. And it starts from the time you're cleaning, you're draping, you're doing biometry earlier on the previous 2 days before, and the patient comes to the operation theater. You should be very gentle to touch, including the painting part of it, washing part of it should be there. Normally, we put the proparacaine eye drops, which is done 1 drop before the dilatation, 1 drop before the wash and cleaning starts. And the lids are, you have to be very gentle on the lids. And draping also, technique should be such that there is no sensations to the patient. Go with the patient's movements rather than being against it. And and as far as the eye is concerned, what are the things that hurt the patient is touching the lid, and even take a video from outside as you're doing surgery, because you are focusing on the cataract and conjunctiva. See what all happens, and when all during surgery the patient has winked or complained of pain. You keep a note of it for every surgery and watch it with the video what exactly you did to cause the pain. So there is absolutely no need for any injection block which can cause problem. Number one is you're seeing so many patients, unexplained pallor of the optic disc is not very rare at all. You expected 6/6 patient ended up in 6/9. Is it because of optic needle? So when you want to switch over, the first one is you go for the medial canthus block instead of standard peribulbar block that you give, parabulbar earlier. Before that, we give the two-bulbar block, which all had problems, problems. Globe perforations are not very rare, especially if you forget the anatomy of the orbit. So go through the anatomy of the orbit. The medial wall of the orbit is straight. It goes straight inside. The lateral wall goes at 45 degrees. So that anatomy on a skull, you should know, put your needle inside, then you'll understand how to put a needle. So reduce the amount of fluid that is injected into the orbital cavity or into the parabulbar, peribulbar space. Switch to the medial canthus needle. There are many videos on how to give a medial canthus. Needle goes straight down for about 1.5 centimeters. A sharp 23 gauge needle, which is 1 inch long, you can take. And that should go medial to the caruncle, not lateral. Medial to the caruncle, just go straight, it goes straight. It cannot hurt vessels, it cannot hurt optic nerve, it cannot hurt the globe. You can comfortably eliminate the perforation. That's the first thing you should do. Once you're comfortable with that, then you go ahead with the subtenon block. So make a small, tiny incision in the lower nasal conjunctiva, about 8 millimeters below the limbus. Go up to the sclera. Don't try to pass the cannula through the tenons. It's impossible. Go up to the sclera. You should see the bare sclera. Just about 2 millimeter incision is enough. And take a cannula and go inside for about 1/2 inch or something like that. Inject about 2 ml of your lignocaine. That's the next step that you should do in developing it. Later, besides to do the topical anesthesia, I would say there are 2 or 3 things which are painful in the eye. One is conjunctiva and cornea. Cornea gets easily anesthetized with the your proparacaine drop, and the drop has to be instilled just before you start the surgery. Okay, this is most important, and the way to instill drop, the moment you put a drop, it will flow down. So the contact time is very important for proparacaine to act. What I do is I take a small pellet of cotton, soak it with that, and keep it on the area of incision and area where I'm going to hold the eye at only one position, which is about 90 degrees away from my incision. And I have my videos on YouTube. You can have a look at it. And that where you hold the limbus with your fine forceps of 0.2 millimeter deep, and where you make an incision, just keep that cotton for some time. If you adjust your microscope and all that. So that will give a very deep numbness of that area. If you put a drop, it numbs, but the duration is very short. After a couple of minutes, patient will start complaining. After this, in spite of you have done it, During surgery, for example, at the end of surgery, you're going to co-opt the conjunctiva. The conjunctival anesthesia would have worn off. The moment you touch it, he will be. So note that. So at that time, I put another drop of lignocaine that's on the table. We take 1 ampule of lignocaine for every patient, load it on a 2 ml syringe, and that can be dropped on it. Within a second, it will anesthetize, then you can touch the conjunctiva. So whenever you're touching the surface, you should add on additional the drops. The next thing that's painful is many people think that iris is painful. Iris, even if you touch the iris, cut the iris, do a peripheral iridectomy, or during phacosurgery, sometimes the phaco needle goes and chops the iris, the patient is not winking. Iris in its position is painless. Keep it in mind. This is a discovery that I made, because when the iris prolapses, patient will have intense pain when you're doing it on a topical. Why is that? Why iris, when you touch it inside the eye with a sharp instrument, it's painless. When it prolapses through a tunnel, it's very painful. You drag it, it'll sport. That's because iris root is attached to the ciliary body. Any pressure, pull or push on ciliary body is painful. So this is, you'll have to remember it very well. Am I clear, Dr. Srini?
Yes, sir. Yes, sir.
So you asked me, time is gone.
Yeah.
So,
thank you, sir. I request Jason to show the scenarios. Please be online, sir.
Good afternoon. We will move on to the
Ravindran
video.
sir has told very good. Only one thing I want to add. So whenever you are putting the Xalocaine, put it only before 2 minutes. And second thing is, contact is very important. So when you are putting it, put it in the fornix and ask the patient to close the eye. If patient closes the eye, then all the surface, that is the conjunctival surface, cornea and everything get anesthetized. And secondly, as it is late, it means 2 minutes before, cornea will not be hazy at the end of the surgery. So closing the eye is very important if you do it.
Thank you, sir.
Good afternoon. We will move on to the video interactive session. The first video, we will skip these videos we have already discussed. This is the one. Some patients may be allergic to topical dilating drops. Maybe your medical records shows they are allergic to dilating drops, and sometimes the patients will tell you that they are allergic to dilating medication. So, Madam, Dr. Rakini, Madam, what will be your strategy for managing these patients who are allergic to dilating drops?
Thank you, sir. So basically, when they are allergic, we use Tropicacel Plus, and they are allergic to phenylephrine most of the times, or atropine. So we use plain Tropicacel for these patients. We have also tried to use the intracameral phenocaine now, which is available, with very good results.
It won't be allergic to phenocaine?
No, no. And so mostly they are allergic to phenylephrine, and sometimes to homide also we saw in one patient recently. So you have to be careful, and those have to be written in the notes, because sometimes the patient comes for follow-up and gets dilated again by mistake, and the patient is really unhappy with that, sir.
You don't prefer adrenaline?
No, it is a phenylephrine which is causing this thing. And intracameral adrenaline we used to use earlier, and that can be used too.
Okay, okay.
Jason, I understand your question. I mean, the same constituents are there in phenocaine. Why is it not? Basically, we are using a minimum amount of this thing, and it's directly going into the eye. The allergy is basically for the skin and all. So it doesn't, and then you are actually washing it off also. Unlike topical drops, it's staying there. With phaco, so much of fluid going there. So phenocaine is absolutely safe to use.
When you're having allergy patient, the best thing is enter with a side port and fill the chamber with phenocaine through the side port. Don't make the main wound. And once the pupil is dilated, you can just wash it off and make the main wound. So it doesn't come into the conjunctiva. And you can ask your assistant to wash the conjunctival sac frequently.
What we have seen is also that with tropical, plain tropical also, there is enough dilatation or semi-dilated pupil for an experienced surgeon to do phacoemulsification, and because whatever you have to work in is in the central portion of the nucleus, which is hard. So in most cataract it works. If it is very, very hard, then you have to. So phenocaine has been a recent addition now, and it has really helped.
Suppose a patient is having floppy iris, will you recommend intracameral injection over hooks or rings, or you use everything?
So it depends on the grade of cataract again. If it's a soft cataract, little bit of intracameral phenocaine does help. And of course, machine parameters and use of cohesive viscoelastics, etc., etc. And again, based on the grade of cataract. If it's a hard cataract and very elderly patient on long, many years of prostate drugs, I think it's better to use iris hooks.
Sir, phenocaine also has an anesthetic component, and patients with floppy iris, if we try to use rings and hooks, I have seen in one case in our live surgery, one surgeon using it, and it damaged the pupil so much that the patient had a lot of problems. The patient was in a profession where it was very important for the patient, the cosmesis, where the pupil was seen, and the pupil was damaged for life, and the patient had a lot of problems. So we do not in floppy iris prefer many of these devices. You have to be very, very careful when you use them, and even if you use them, you can use them as capsular hooks or something. Try not to do the iris attachments much.
We'll move on to the next video. See this biometry value. You can see a short axial length, both sides, 16 millimeter axial length. Yes, it's a case of nanophthalmos. So in this case, suppose patient develops, JK Reddy sir is there? JK sir is there? No. Suppose in this case, patient develop sudden increase in intraocular pressure. Or as in a routine case, suppose during surgery, if patient develops a sudden increase in intraocular pressure, there is progressive shallowing of the anterior chamber. Lehane sir, what will be your line of action?
See, first of all, if it is increasing an anterior chamber getting shallower, that happens in the non-ophthalmic eye. In such situation, first of all, you should not do anything. Wait for a few minutes. You can, nowadays we are not using mannitol much, but yes, you can use mannitol also. Secondly, the best is if you are well with the vitreous, then you should go 3 point
prophylactic.
Prophylactic, yes, the vitreous tap if you do it, and that will definitely help. And but here, see, don't go fast, do prophylactic tap, and then gradually the pressure goes down, and then you can operate the case. Ask panelists also.
What kind of formulas you follow for nanophthalmos?
Yeah, I usually follow Barrett formula these days.
Okay.
Otherwise,
do you get Barrett result in short axial length? You get?
Yes.
Okay. You don't rely on SRKT?
So what we are using so many premium IOLs nowadays. In fact, one of the IOL companies came and told me that, please ma'am, let us put the Barrett formula in your IOL Master 700, because SRKT is not being used, and whenever you send to them for calculation for patients, they are using the Barrett calculator. And what I have seen is that with the Barrett calculator, for all across all type of patients. The formula works really well with very good results, because not only with premium lenses but with monofocal, any type of lens today, every patient who comes to you wants 6x6 vision and n/6 vision. I mean, whether the patient is aware of what we are doing, not doing, what lens we are putting, the patient listens to all their friends, and this is what they want. So the Barrett's calculator really helps.
Next question. Next doubt is, will you attempt pars plana anterior vitrectomy in this patient?
I have not tried. I will not attempt also. I usually give a mannitol and wait.
Okay. Our next video is.
Sir, can I just make a point?
Yeah.
So we used to use a lot of mannitol, but one must be very, very careful. And in the past, before Lahane sir was in JJ, when I was studying, we have seen a patient of mannitol death, because for mannitol you need to have a cardiovascular clearance, because it suddenly increases the CV load and the intravascular volume. So we would be really scared. And what I think nowadays is that all of us must learn the scleral puncture, because what happens in these cases is the misdirection of aqueous. And so if you feel that you are not capable of doing it, like he said very honestly, even I have never done a pars plana vitrectomy, but we need a colleague with us, a vitreous, retina vitreous colleague.
This is the next scenario. Here it's a case of PSCG with malignant glaucoma. IOP is not getting controlled. Similarly, you will have phacomorphic glaucomas, where your IOP is not getting controlled with mannitol and all diamox, everything. In that scenario, will you attempt a vitrectomy? Definitely. Okay.
Sir, in most of these patients, what I have seen sir doing is that we used to get these patients from the village who used to come late to us, and especially during the COVID times, because they never got operated. So you give peribulbar block, you make the eye hypotenuse, and by gently, after all that also, if the pressure is slightly higher, use a 1.1 side port to gently decompress the eye, and even in front of the eye you can see the cornea clearing up before attempting to even enter the anterior chamber. And once the cornea gets decompressed and soft with the egress of aqueous, even the cornea gets clearer for you to start or do surgery. In these type of patients, SICS should not be attempted because you have a bigger opening, so phaco would work in these patients.
I think the take-home message is, if you are suspecting suprachoroidal hemorrhage, you close the wound. Don't attempt anything. And if it is misdirection syndrome or malignant glaucoma where aqueous is trapped, you can attempt vitrectomy. Am I right?
Yes, absolutely.
I raise a point here, sir. I'm Ravindra here. Hello?
Yes, sir.
Can you hear me?
Yes, yes, you're audible.
I can continue?
Sir is asking whether we can hear it.
Yeah, we can hear.
What's important is there are two kinds of pressure. One is intra-glow pressure and the other is orbital pressure. So both of them have to be under control. So if you give a mannitol, intra-orbital pressure will not be there, fluid will be in the orbit, and only the intraocular pressure comes down. So there is a very good way of reducing the pressure is applying gentle pressure to about 30 millimeters for about 20 minutes before the surgery. That will reduce both orbital and ocular pressure. That's number one. As far as the non-ophthalmos is concerned, you should totally avoid giving any blocks to the orbit, which increases the pressure and increases the pressure in the orbit as well as in the eye. However much of failure of light post-injection will not come. That's one of the causes. In non-ophthalmos is the choroidal effusion. It is not the bleeding there, but choroid becomes swollen, and somehow the choroid swells up. It can swell up to 10 times its normal size, and that's the one which increases the pressure. The second one which increases pressure is because of small anterior segment. The misdirection syndrome is very common in these patients. So if you are careful to avoid it, and actually as a prophylactic measure, at about few millimeters behind the pars plana, you can make a small clear window exposing the choroid. Just make a window exposing the choroid, and that is supposed to drain out the choroidal effusion. So this is as a prophylactic measure you can do just before doing cataract surgery. Number one is the topical anesthesia or surgery under general anesthesia are the options, not the orbital injection. And for calculations, you can use Barrett Universal 2 as well as half a Q. And I take an average of half a Q and Barrett's Universal 2 for calculating this. And the intraocular lenses of power up to 60 to 62 diopters, single lens is available. We don't have to worry about the putting two lenses inside the eye. In India, imported lenses are not available. Imported lenses of power up to 40 is available, but if it is above that, there are local Indian companies that manufacture these lenses and give. So these are few things I wanted to say.
Thank you, sir. Show me the next video. Next video. This is a case of intumescent cataract with anterior capsular fibrosis. So I would like to ask Dr. Binu, what are the methods to complete rhexis in these kind of situation? You have two issues. One is intumescent lens, other one is capsular fibrosis. And next part of the question is, suppose you get a runaway rhexis, what is your next technique to complete the surgery?
First thing is anticipate such cases, intumescent cataract. You anticipate a runaway rhexis first of all and prepare for it. And try to make a small rhexis. And if you have, use high viscous OVDs and start from the center, make a small opening. If it is running away, then stop. First sign is if it is trying to run away, then stop. That's the first sign. Then you can put more OVDs and flatten the flap. It should be flattened, and you can use a forceps, capsule forceps to grasp the root. That is known as little procedure. You can grasp the root and pull it, give the traction opposite side towards the center or 180-degree apart, and try to continue. If it is still not continue,
like when you push visco to flatten it, many times we get a Argentinian sign.
That's okay. That's if it is. You try to flatten it and continue. If it is not continuing and if it is going to Argentinian, then you have to cut from the side. What I do is we go from the venous, we cut from the side and complete as far as big as possible, and do a small, slow motion phaco and take it to, as Dr. Lahani said, take it to AC and do.
You can do phaco because you don't need a hydrodissection.
No, don't do hydro procedures and all.
You
and
don't need
always look at the flap, that flutter sign. That, as I said, that flutter sign is very important. If you see the flutter, that means it's not gone to posterior. And if it is not there, if it is gone to posterior, better convert it to SICS or deliver that to AC.
Another thing, it is fibrous. So you actually don't need a rhexis. The capsule is strong. So without rhexis also, to an extent, you can do phacoemulsification.
So what you have done in this case is the perfect management of this case. Because what you did was that where it was fibrous, you didn't pull it, you just left it. And so if this video is seen, no, this is the perfect management of this fibrosis in your video, that you left it where it was fibrous, you went from the other edge and completed it, and automatically it got completed. So if you had actually continued there, you would have been in trouble. So, and two things, use of the microforceps. Second thing is that where it was fibrous, you left it. Multiple use of visco again and again to see what you are doing. This was a perfect management of this case, which is very, very important, sir.
We'll move on to the next video. Here patient is having a PC, patient had a PC rent while phacoemulsification, and the nucleus is in the anterior vitreous phase. Dr. Aravind, how will you manage? Do you recommend performing a posterior assisted levitation in this situation?
The nucleus is not in the it's in the anterior vitreous phase. So obviously do a limited anti-vitrectomy first, and then ideally a pars plana vitrectomy should be attempted again based on the support of VR surgeon what we have, and we should never go to fish it out.
Okay.
If gently while doing the anti-vitrectomy, there are many times the nucleus comes up, reduce the parameters, and as probably you also have done it, we have to extend the wound and convert it. And again, based on the type of cataract, if it is one hard nucleus, it sometimes comes out easily. If it's a soft cataract and we have already done a lot of chopping and all, it's all disseminated into pieces, then it's difficult to bring one chunk.
You mean to say if there is vitreous disturbance, already vitreous is there above the lens, you better leave it to a posterior segment surgeon.
Exactly.
Okay.
Yeah. Of course, we should do a limited anterior vitrectomy. That helps.
Okay.
There will be some amount of vitreous in the anterior chamber also.
Okay.
So that helps in sometimes bringing up the nucleus. And if it is comfortably above the pupillary plane.
But here is a technique you can remove it through the, not through the pars plana,
yeah,
but through paracentesis.
Just cartwheel it out as you have rightly done.
Yeah.
Cartwheeling it out, and we should never use the phaco probe to run behind the nucleus. That's lessons we have learned the tough way, and causing a lot of, we are tempted to do it, but we all learned.
We'll move on to the next video. This is about ocular surface issue. This patient is having ocular surface disorder. You know that cataract surgery is going to spoil the ocular surface more, and this situation, what will be your, JK sir is there? So, Lehane sir, how will you?
First of all, as there is a corneal opacity and nothing is seen behind. So basically in this situation, if you are not well conversant with phaco, go for SICS, and that will save your 1 month of life. Secondly, if you want to be a very good surgeon, then use endo illuminator. So use it from behind, and your microscope light should not be there, and that can help you for the illumination also for this, and also dye assisted rexis.
Use endo illuminator.
Yes, and dye assisted rexis.
Want to say something?
Again, one more thing is post-operatively, make sure you use drops which are more cornea friendly, especially the quinolones. Better not to use. Use a chloramphenicol drops, that's more than enough. And avoid NSAIDs as far as possible.
Okay.
Some better formula, BSS, some fluids like glotazole plus, which are more cornea friendly, and of course viscoat, because the endothelium count also may be less, and probably a peribulbar block is better.
Okay, we will move on to the next video. This is post PKP cataract. Another similar scenario is a keratoconus patient developing cataract. In both situations, you can have patient will have astigmatism. So, Ragini madam, what is your how you tackle this these patients in
So
point of view cataract as well as the astigmatism?
So first, the keratoconus needs management, because otherwise if you're not managing the keratoconus will be progressive, and you will not get the correct parameters to put in the correct intraocular lens. So you have to assess the patient as to what is the keratoconus, what site of treatment will the patient need for keratoconus, how progressive it is, how thin is the cornea. So depending on that, you would need treatment for the keratoconus first, and then the management of the cataract, because if you try to do the cataract first, we are not going to be able to assess what IOL needs to be put.
keratoconus and cataract. The thing is what they are using patient before, and mainly it depends upon the topography, and they are using the spectacle correction. If the spectacle cylinder is matching with the topographic cylinder, spectacle cylinder axis is matching with the topographic cylinder, then it's okay. You can go for toric lens. They're reasonably okay. But almost 30 to 40% of the patient, they will have a flip. So that means the AR, AK will show a cylinder at 180 degrees or 170. Patient will be accepting his spectacle power will be at 90 or 100. The opposite. We don't know why the optics, they accept like that, they read 6669 also. Though, if that case, if put a toric lens, then you are messing up. The patient will become totally disappointed, and you have to. So you have to, the whole spectacle power, you have to check and see it. Based on the topography, we can come to a reasonable conclusion. This is a clean case. We can go with toric, or otherwise we have to go for better to avoid toric most of the times in keratoconus, except for FFK.
Sir, I would like to share a case because he is no longer alive. I can talk about him. A very big Father De Brito. So what in today's day is, because we are using premium lenses and all, so what is said now is that for every patient who has a cylindrical number, instead of just going ahead with the the toric lens, not only the keratometry, the dry eye evaluation, but the topography, like sir said, is very, very important, which was not done. A toric lens was put. Again, the patient had problems, so the toric lens was rotated. Then a piggyback lens was put, and then finally when the patient came and the topography was done, it was found that though he was very old, he had keratoconus. So assessment of even a patient who is not having a keratoconus, but topography in a patient with a cylinder or a little more cylinder before cataract surgery is very, very important, and should become a part of our system of doing a pre-operative work.
You're trying to tell topography is must for any case of premium IOL implantation. The other take-home messages, if astigmatism is regular in keratoconus, you can implant.
No, previously when we started toric lenses.
No, Jason, it's not that simple. So we are seeing 10 cases keratoconus every month, every week, not every month. New cases. Old cases we are seeing another, this part the past 10 years. So we have thousands of cases. Many cases, very regular astigmatism, but they take a flip. So if the astigmatism is 180 degrees, I can show you, I could have bought the video presented. The regular astigmatism, 10 diopters in the one, but it's a question of PMD is different. PMD they accept. But in keratoconus, the opposite axis they accept. We did a lot of ICLs. Patient is having AR reading, if you take -10 at -6 at 180. But patient is accepting -5 cylinder at 90, 6 vision. So we did ICL. The patients are very happy. Like that, there is a lot of cases. So you cannot take, looking at the topography, you have to see the spectacle correction, what they are using. PMD you can use it.
These keratoconus patients, what sir said is very true, that either we were underdiagnosing them in the past, or now they are more because of the lifestyle and the allergies. So most of these keratoconus patients have a lot of dryness also, because they are allergic and itching and all that. So testing for dry eye and treating them with artificial tears also makes a big difference to your readings. So keratoconus, like sir said, is not a very, very easy thing to treat. And it should never be taken lightly, sir. So all these aspects have to be considered. So I think the cornea surgeon would be the best person to treat the keratoconus.
We'll see the next video. You can see the biometry value here. The axial length is high, and the cornea is flat, and you can see it is done under RK mode. And the formula used is Barrett K. Of course, a case of post RK patient. So my query is, JK sir, what are the challenges you encounter in post LASIK or post PRK patient when they are undergoing cataract surgery?
Post PRK, post LASIK is not an issue now. We got Barrett works very well, 2K or whatever, maybe 2 or 3. There are different formats, but Barrett 2K reasonably works well. And the RK is the problem surgically, and everything is challenged depending upon the cuts. Here it's reasonably you are able to make it, but sometimes you will have more cuts, they will open up. There's nothing to worry, you can suture them. Regarding the power in RK, what is the power you calculate? IOL power you calculate. In RK, if sometimes you have to topography, you have to check in the center what is the power. That's all. Take the mouse and see in the center and calculate for that. Sometimes it will be little periphery, the topographer will otherwise reasonably good. There won't be much surprises. We'll try to always overcorrect. That means put on the minus side. And desired refraction, you put minus 0.75, minus 1 and do it. They are quite comfortable.
So all these are okay. So what happened in Shah Rukh Khan's case? Like he went out for a
no, nothing like that. This is not Shah Rukh Khan's problem. That's not the doctor's problem. The problem is with the Neetu Ambani. See, Neetu Ambani is a -5, +5. She is wearing contact lenses. She's not able to wear with all the makeup. She had a VVT done and she said, I am fantastic, Shah Rukh, why don't you go for the same surgery? He had +3, +4 hypermetropic LASIK done some time back. So hypermetropic LASIK done once or twice, it will come regression. Somebody did it, they pay the money and do it. So all irregular ablation and somewhere is there apical axis and topography, and it's a lot of comas are there, everything is there. So over that they put another VVT lens which gives very poor distance vision. Reasonably good. That's not excellent distance vision. So this guy is not able to see with the camera, he is not able to see anybody. Now, when he goes in front of, he is not able to see anybody beyond 5 feet. Everything is glare.
So
the problem is
I mean, you would be knowing better. See, was there an error in?
No, not error. The cornea itself is very bad. Okay, twice done hyperopic. Once you do hyperopic LASIK, the cornea becomes very bad. So with that operations, the best thing is put a simple spherical monofocal IOL and give a monovision. Put -0.5, -0.5, or you flatten it out by doing the corneal correction. But the thing is, more enthusiasm. The problem is Neetu Ambani, not the Karthik. She went and sold fantastic Shah Rukh. After I got it in both eyes, I can see everything. I don't need contact, I don't need anything. This is clear lens extraction, +5 she is. After that +5 or now and then she is wearing contact. All of the time she is moving around. You imagine +5 what they will see, nothing. You can't differentiate between a donkey and a monkey. It's a +5. So she was moving around, all of a sudden she put VVT, she is excited. So she told that, go and have, my doctor will do excellent job. She gave the lens, she gave the surgery, everything was given. So there is no choice for the doctor. There is no choice for...
Jason, I think we'll start the next session. I mean, can we end with the last question, like post-op dryness and MGD? Like, I mean, many times you see post-operatively the patients are developing. I mean, it's not that you missed it before. All those frothy, at least a little bit. So, JK sir.
It's a big problem only. That's a premium IOLs. For example, this case is showing, you see this vascularization, peripheral vascularization. There is a big opacity. Sometimes you don't see opacity. Even without, you have a cornea like this, it's a real challenge. Post-operatively, the antibiotics you put it, steroids you put it, everything again they mess up the entire cornea. So they are very, very difficult patients. Initially you over-counsel them, they will go to other doctor. If you operate them, then you have to spend most of the times with them in the OP instead of seeing other patients. This is both ways they are troublesome. Pre-operatively we can treat and reduce, make. See, this eye looks. Here it looks very nice, but here it looks very bad. So here it looks, it's ocular surface problem, congestion, blood, no limbal. You can't see any palisade, nothing is seen in this cornea. Where is limbus palisade? Nothing you see. There is no epithelium and everything. And he is having multifocal lens. Over to that.
No, this is another video. It's
Yeah,
not
different,
static.
different. I am telling this patient in generally. But here it looks very nice. Monitor. But there you see all, where is it? You can't see any limbus palisade, nothing. And all blood vessels are going into the cornea, and over that he is having multifocal. You are removing with the monofocal exchange.
This patient actually is having 6 and 6 both eyes.
Terrible anatomy.
He implanted this trifocal for presbyopia correction actually, and became very unhappy and getting exchanged. Monofocal.
See, what you're telling is correct. I have few patients from coming, they asking for exchange. Same presbyopic correction, they got it done. And they said, the extreme lanapy, I can't drive, I can't do anything. Completely my life has gone. You exchange. He said, you go to the other doctor only. I don't want. Some confusion happens.
Premium lenses, see, everybody is implanting the trifocal, and that is the problem. So whenever you are implanting the premium IOL, personality A you keep in mind. Google patient coming with the Google knowledge, one, asking more than 4 questions to you. Asking more than 4 questions to you. We are not for them, we are for us also. If one patient is going, nothing happens. But one patient will trouble you throughout 1 year. Always remember. And so don't treat that patient. See what happens, every day that patient will come and sit, and he will not only talk to us, he will chat to the other patient because he want to prove that doctor galat hai. So because of that, when he is asking for more than 4 questions, better way that tell him your lens is immature, it requires to ripen and be there for few months. What will happen? He will go to other person. He may or may not operate, but our headache is avoided.
This is my patient who sent me this WhatsApp message after trifocal implantation.
Anybody. It may be a panoptic, it may be any optic in the world. Don't say spectacle free vision. Any person. Never promise spectacle free. Never promise. Never. Nothing happens. So always promise that yes, you will require +1 or 1.5 for near vision. Whatever, bipolar, even also trifocal also. Because what happens, they come with the, you can say the medicine, they are in the trifocal, they say, ye nahi dikh raha hai. It means they want to say that medicine also, it means it is very difficult. So don't promise that. Do it, don't promise that.
No, sir, I feel is, I don't know whether any of you have experienced it, the cost of the monofocal is less. The cost of the multifocal is very high. So patient feels that because I have spent so much money, I should get that much worth. That is our Indian mentality. So that also plays on their head all the time, and they...
Not like that. Nobody, for example, I don't do much multifocal. There are so many patients multifocal done. They never complain. I paid more. I didn't got for the money. They never complain. So that somehow some 5 to 20 to 25% of the people's, the entire visual system, they cannot accept multifocal. They can, some 20 remaining people, okay. Sir. Another thing what I saw is Jason has rightly, he uses a lot. Maybe he will be able to, he facing all the types of music. So he will be able to answer better. That's what we found. The other group, some patients, extremely happy. Multifocal done, extreme. They say this is the best thing that happened in my life. They say that. So they are extreme. So they request all. They tell also. Will this remain my entire life, doctor? You think? So it's their system, not we cannot do anything. See, we did a lot of psychological study, and so questioning, answering the system, visual system. This one, spherical aberrations, total aberrations, higher order aberrations, all we did. So nothing is matching why this guy is unhappy, why that guy is happy. It's a neural system. Some people are not. We did all.
I think, yeah, actually early cataract patients, if you implant multifocal, they may become unhappy. But advanced cataract need not be multifocal. They are happy with any kind of lens. Cataract.
Srini, PS is Srini, if we have a posterior subcapsular cataract obstructing E16966 vision, you operate on them, they are happy as he is telling, any lens you put it. Just nuclear sclerosis, nuclear cataract, nuclear sclerosis, just sclerosis, -2, -4, or a nuclear cataract, 612 with a brown cataract, you operate on them and put a multifocal, 50% happy, 50% unhappy. We are not able to recognize why they are not even 50, 70% are unhappy in those categories. Something or the other. PS is, you can straight. Dense PS is there, you can straight away, you can go, whatever may be the pre-operative. You don't need to worry. They will be very happy. No, spectacles is not an issue at all here. No, the spectacles is not an issue. Say when I am doing my post-graduation, 1989, the Pharmacia was introduced the first multifocal eyewear, 811E, that's the number is called, PMMA rigid lens. At that time, no capsular exists. Can operate and put the lens. ECCE, sutures. So at that time, the patient satisfaction much better than with the fake one foldable now with the multifocal. Even at that, because the cataracts are very dense at the time we are operating. So now the cataracts are different. And the second thing added to that, how many years now? 35 years. The multifocal, total volume multifocal manufactured never cost 2.5% of the total business. So that means there's not the problem with the surgery, it's the problem with the lens. If the product is not good, you cannot sell it. They want to sell it because the company wants to make profit. See, the manufacturing cost between the monofocal and multifocal for the company cost only twice. A PMMA, hydrophobic lens, ordinary lens, multifocal lens, the manufacturing cost for the company only twice the money. But the profits are very high. But never it crosses 2.5%.
Comparing multifocal and trifocal, which is creating more issues?
Not multifocal, bifocal and trifocal.
Bifocal
We'll come
and
to
trifocal.
Bifocal is better lens than trifocal on the optical bench.
Yeah, true. Actually, you just count the number
because
of
they are
rings.
not able to sell bifocal, now they bought trifocal. At least we can sell this. So they want to say, if you can't sell one, what you will do? You bring another product. You have to bring another product, change the lights, change that like automobile, change the grill. The same way they are doing. Actually, as he's telling is, bifocal is better lens than trifocal on optical bench.
Like it is directly proportional, and unhappiness is directly proportional to the number of rings in the lens. So if there are no rings, they are more happy.
We'll end this session now and move on to the next session. I request Dr. Asha to come and give the mementos. Lahana sir. Dr. Ragini. Srikanth. Dr. Binu. 10 minutes left. He's a phenomenal. He is the one
Recording stopped. Recording in progress.
We'll be moving to the next session, and as I said, for those who are starting their practice, doing the post-graduation, and even for us who have been there in practice for a long time, this is going to be the best session of this CME, and I can promise you this is going to be the most entertaining one also. So this this session is being handled by none other than Dr. P. Shashikumar. Sir, if you, I mean, he's a great person right behind you, sir. He's a great person to know, and undoubtedly he is the single most successful ophthalmologist in Kerala. He does basically topical SICS, and as JK sir would say, Dr. M.S. Ravindra started topical SICS after Dr. Shashikumar and learning from him. I mean, just how good it is and how the results are and basic techniques. And after that, he has innovated quite a bit. Many of us have been inspired by Dr. Shashikumar, and we, as a panelist, I'll be there. And ma'am is going to be there, and the kind of experience that Dr. Ragini has, and the huge number of students who have been under her, and their experience in handling the problems of the great majority of people in Bombay Ophthalmic Association. Dr. Ragini can definitely give a lot of inputs on how to go about it. And Padmaja madam, see, I mean, I'll tell you, you should actually learn how to do the public speaking from Padmaja madam. We in the last to last Drishti conference, P.T. Usha was a chief guest, and the way she talked about P.T. Usha, the kind of language, English that she was using, I had my friend Kaushik, who's a very good orator, who's the president of Shankaraya Institutions, which is, by the way, starting their huge hospital in Varanasi today, and it's being inaugurated by Modi ji. And we have Lata ma'am, who also has a lot of students and a lot of experience. And I request Dr. Shashikumar to start the presentation. And he'll be speaking also about improving our happiness quotient.
Thank you, Srini, for all those nice words. Actually, I was thinking what to talk, what next in ophthalmology. So, what next in ophthalmology, you people have to decide. I don't know, to be frank. So, what I want to tell you younger ones, like we have to dream. Dreaming is the most important thing. That is very, very important. So what I thought was I will tell my journey, how I reached this stage. I'm supposed to be, it has to be a motivating speech. I don't know. Most of the people have already gone. So whether it's motivating or demotivating, I don't know. Anyway, so it all started uh, dreaming to be a doctor. It all started when I was in 7th or 8th standard. So that time my mother had kidney failure. So we used to go to hospitals, CMC, Vellore, Coimbatore, lot of places. And there I used to see all these young girls and boys in white dress, apron, just flirting and talking to each other, kicking and the tamashi and. So I thought I want to be a doctor, not to serve the humankind and mankind and all, to be frank. Just that fascinated me. I thought I should be a doctor. So then I wrote SLC. It was in the SLC exam. I'm an average person, I'm telling you. In the SLC exam, I got 234 out of 600. That means that time there was a group system. That's why I passed. I actually failed in maths. So then that year only my mother died. So I thought maybe because of that trauma I couldn't make good. That's the normal human nature. No? Your fault somehow you want to put on others. So I was then. After that, I every day I used to pray in front of my mother's photo. I want to be a doctor. I want to be a doctor, Amma, like that. Then one night in my dream, she came and told the mantra, work hard, that's all. That's all what you have to do, get marks. There is no entrance that time. So you work hard, you will get. So I started working hard. Really worked hard. Then I got 540 out of 900. 1 mark less, I can't say I got first class. So whenever somebody comes and asks me what's the mark, I will say I got first class, that's all. Then I will vanish from that place. So again, bleak. So that time you need minimum 98%, 97% in pre-degree. And then next option is then BSc. Again, BSc also you have a chance. So I joined BSc Chemistry. Still I don't know why I joined BSc Chemistry, but I joined. Anyway, that's the only option. Then BSc, actually I stood second in my college. So the thing is, I was telling, but I want to tell juniors is you have to dream. Unless you start dreaming, it won't happen. And luckily for me, 100% I won't get with marks. MBBS, I knew. Luckily, the entrance exam came. When I was in second year, I got the first entrance exam came. Then that I didn't write. Final year, I just went and wrote, and I failed. Then after the BSc, I wrote. Then that time I had only 34 seats. We had only 600 seats totally. There is no private medical college, Kerala. Out of it, BSc quota is 10%, so 60 seats. Then being a forward this thing, I had only 34 seats. For that, all the BSc, some 10,000, 20,000 people were writing for that seat. That is the last time when you can write after BSc. So I wrote and I got it. I don't know. That's the biggest puzzle still I haven't solved in my life. How the hell I got in being average? Maybe my dad was a Muruga Bhakta. Maybe he was doing some puja or something, I think. I bet on that because there is no other chance. So BSc, MBBS, that was the finest college, Calicut Medical College. I couldn't believe. So there what I did was, I was just average. So average, it went on like that. All the exams I passed. But that time, strike came. The strike is for what? That no private capitation shouldn't be there. That's for that. And I was in the forefront. So due to the postponement of exam, I lost 1 more year. So BSc 3 years, 1 more year I lost, although I didn't fail. And the irony is both my children studied after giving capitation fee. So one time we feel something right, after some time we feel it's wrong. That's the funniest part. So after that I knew, I didn't know what to do then. No, the mark, everything was bad, average only, some 60% something. I knew entrance, I was not sure. That was the time when Arvind people came to Palakkad. And that time they did the camp. The campsite itself they operated. So I was putting the torch and the way these people were dealing, I was so impressed. On the same bus, I got in and went to Madurai. Madurai chief interviewed. Lucky for me, there is only 6 senior census seats. Out of it, some 10,000 people will write usually. But I went in between, so there was 1 or 2 dropouts, because always there will be dropouts because of the workload. So I got in like that into Aravind. So Aravind I studied, then I knew I won't get, there was only DO, I wanted MS. By then, to some extent, our financial picture was good. So my dad deposited some money in Syndicate Bank, that's the Pi bank they had. And because of the deposit, I got a seat in MS. But in MS, I was good because I had the background of Aravind. So I was doing well. And there was only 3 people, one Mr. Junior who had failed the previous year, then 2 of us. The other person's father is a big ophthalmologist in Andhra with a big hospital and all. Then they failed me. Again, I lost 6 months. So totally 4.5 years gone. Why I am telling to the juniors is I always hear like 1 year, this, after that I will do that. Life is never 1 + 1 2. It comes, you have to, so many people, they calculate so much. After MS, I will do this, that. Then after this thing, MS, I went to Shankara, and there I got him, my best friend, JK Reddy. So I was there in Shankara. By the time it was almost to get finished, they asked me to do FACO. But somehow I didn't like FACO, to be frank. I don't know why, but I didn't like FACO. Sometimes you tell, no, I don't like him. Why? Why you don't know? You don't like him. That's it. Something like that happened to me. So FACO, there was no other way out. So everybody advised me. I was planning to start my practice without FACO. Impossible, gone. Nothing can be done. But I am used to these negative remarks because in Aravind, suddenly one day when I was doing senior census, M. Srinivasan sir said, go and operate, he said. So I was so thrilled. It was like getting the girl on the first night of your wedding. So thrilled, excited. Then I started, it was ICC. You push the pedal, the probe is going in. Then suddenly it was dangling. First case, dangling. Then I told, please call Srinivasan sir. Then the next fellow, my senior told, I will manage, don't worry. And he managed, it went down. Then Srinivasan sir came and put the stitch there. So first case, doomed. Then when I went to the hostel, my friend Venkat told, but no, nothing, this Avashagunam, I bet, you better change the profession, you are not going to reach anywhere, I bet on that, he said. But somehow I stick to it. And my first night also doomed. By the time I removed all the pins, the slides and the hair clips, I was exhausted and slept off. Total tragedy, sir. Okay, anyway, so after that, there was no out. I had to do SIC. That time I had done SIC. So I discussed with JK Reddy and discussed with him how to go ahead. So that time, we discussed and we started putting lignocaine, 2% intracardiac. So no preservative, nothing, and we added adrenaline to it. Adrenaline, 5 insulin units in 10 ml. That I used to put intracameral. So that time, my only aim was how to surpass these FACO people. So that, this is an old video actually, still I do the same. FACO people that time they were doing under block. And I was doing without injection. So injection is the thing which most people fear, always remember. Before the vision comes, they are worried about the injection. So many people have done one eye, other eye they won't do, just because of the fear of pain, the pain of the injection. So, me, JK, we discussed, and this is almost same thing which still I am doing. So we started doing this, and I jumped to the temporal section. So that was another advantage. Even FACO, you do superior, you get so much estimates. So people used to say like, after 1 month, SICS is same as FACO. It's nothing like that. If you do properly, use the right machine, give the right respect, your results, because most of the cases, I do more than 250 cases in my practice. All paying cases, foldables only. And only thing is you have to give importance. The next day I do the other eye. Third day I ask them to take head bath. Fifth day I ask them to take go to jaw. So that's the this thing. Oh, I went out. Anyway, these steps and all, nothing much. It's all routine thing. I inject in the sides, peritomy after peritomy. I inject in the sides that silocaine. And this is the okay. So it's almost you should do it. JK says this is tougher than phaco, but I don't think so. SACS is easier, I think. Anyway, I don't know anything about phaco anyway. So this thing. Now I put IOL, air. I used to put air. So I put foldable lens. Many people ask me, do you put foldable lens? I said, I don't lie. I say, yes, I put foldable lens, but I put it unfolded. So many people used to ask me, what's the size of the section? I say, is it keyhole, pinhole? I said, yes, key. Who has defined the size of a key or pin? Nobody has defined. I say, yes, it's a keyhole, whatever you want. Sometimes they ask me, is it 2 mm, 3 mm? I said, what you want? The first session, how much you want? Sometimes some people say 2 mm, 3. Okay, peritomy, I will put 2 mm. 3 mm, they are also satisfied. I am also. Why? I am always confused. These people, these Google people, they Google so much. These people heard from somebody has come to me. At least you should have faith in me, no? After coming here, now they start asking questions. This, that. Too many questions they ask. There are two types of consultation fees. One is the, two types of fees actually. One is the consultation fee, the other is the insultation fee. So I make them pay extra. Unnecessarily they ask hard questions. Or otherwise, best thing to do is, I used to tell, is to confuse them. Confuse them in the sense something they will start, they are non-ophthalmic, not even doctors. I will say, you are talking about the CCC or the in the sulcus, which you are talking. Then they get confused. So best part is confuse them. That's the best part. They have come all the way thinking of me. Now they want to question me. Why? So anyway. So complications, as such, complications do happen. Complications do happen actually. So I've seen so many of my friends, good surgeons, some complication, after that they will never do. So same thing, that this is for the juniors, I'm telling you. It happens, what to do. So once in Shankara, I had 6 to 8% of PC rents. Then there was one lady who comes from Trichure. She asked a consultant. She's very good looking, pretty lady. I don't remember the name. Most probably JK will be remembering, I bet. And so I asked her, how many PC rents you get? She said, no, nothing. Then I became more sad, not because I am getting 6 to 8, she is not getting. Then I asked JK, why she's, because she doesn't operate, he told. So that's the thing, if you operate, you get it. There is no other go. So that's one thing. See, and the important thing is you have to dream, as I told you. We were like, when my mother died, like we five of us, my elder brother, we were just like cattle in the road, nobody to look. Father had an eye, he had an eye, he used to just, but he never used to impose anything or influence. That's the problem with our generation now. We try to, not all, I mean, still, and whatever our children has to do, this, that, they are not allowed to dream actually. My elder brother became chartered accountant. I am the second. Third became chemical engineer. He is now Hindustan Organic Chemicals executive at the top post. Fourth is engineer MBA, and he is doing tool solutions. And last is my sister. She didn't get into any profession. That time she was after kabaddi. She loved kabaddi. So she was going on playing kabaddi. So that's the thing. So if you have to dream, that's the only way out. So what next? That's up to you, I don't know. You have to dream. What next? So, never you say you do, after doing SICS, never say that you do FAB. That's very important. Always remember. And never say you do SICS also. Because you tell that these fellows will go and Google and see some horrible video, and then they will. So best thing is you put your own name, whatever you want. So I had a patient from his relatives and all. I operated in Palghat, Kalpati. Somebody, his relative is calling from Chennai and telling, sir, I am coming there. I want you to operate. I said, what? I can't operate. No, sir, I will send the video. Here they're charging 75,000 rupees. I heard a lot about you. Can you do eye drop surgery? No eye drop surgery. I got my own technique. No, sir, I will send the video. I don't have a WhatsApp what to do. Then they send it to my sister, staff. There I was, they are doing topical, that's all. So he has put the name as eye drop surgery. So that is the trick. You put your own name. Who is going to check you? Keyhole, pinhole, whatever. So, and the important thing is you should have right circle, friends. Especially friends you need, but real doctors you need, doctor friends. We have a big circle, like a lot of them. So when you're in trouble, when you send the patient, they consider it as their own case. That circle you have to build is very, very, very important. So these are the things which I want to say. So what I went through, whether it's motivating or not, I don't know. I thought you have to dream, that's all. Go on dreaming, then you will start reaching some place. Thank you. One more dream. Even at this age, I dream, to be frank. Still I dream. That's very important. In my bed, it's always crowded. There is only two of us, me and my wife. But I will be dreaming of somebody, and she will be dreaming of somebody. So always it's crowded. Okay, thank you. So I will go to the next topic. See, this is the problem. Everybody wants to be happy. True. So then they find some spiritual way, or they try something, anything, Buddhism, Zen, whatever. So this is a study done by National Geography on the happiest people in the world. After Costa Rica, Denmark, and one more country was there, I don't remember. They are the happiest people. So they have started analyzing why these people are happy. And this is the chart actually. You should have a loving partner, quality time with kids, very important. No TV, or more than 1 hour you should never watch, or any gadgets in that sense. What's the other thing? I'm not seeing it properly. Yeah, socializing, very, very important. Then exercise. Yeah, meditation must. Having 2 permissive drinks. I'm telling you clearly, wine or 2 pegs, don't cross it. That's very important. Eat only 80%. Like, don't make full. They never eat. Little. Usually smoking people are unhappy people. That's what they found. I'm not. Whether you are on consultant, that's what I've written, I think. Freedom. I'm not seeing anything actually from here. Whether you care, you can read. No, it's all clear. There's nothing being. That's it. Correct. Yes. Are you a likable person? That's very important. For that you have to joke and move around. Very important. There should be some hobby, reading something, 7 to 7.5 hours sleep. You should have empathy. And the lighting of the home is also important. I was surprised. This is a pakka study on lakhs of people. Whether you are in a lot of sunlight should be there, should be bright. That also makes you happy. So these are the things which I got. I thought I should share with you. These things are something which is really applicable rather than trying to find a guru and meditation and all those stuffs. Then you start closing your eye, your mind goes somewhere else. So this is very difficult, living in this moment. Everything I'm trying, nothing. But this is good actually. This is something which you can apply. Anyway, thank you.
Thank you, Shishita. And I request Padmaja Madam to give a memento to Dr. Shashikumar. Ramya, do you have anything to add? Because when I added you in the session, because you belong to that young.
What he spoke is very, I think it was 100% correct. I congratulate him. Can you see at me? Any disease? Can you see? No disease. I underwent kidney transplant in 1995. Now 30 years have passed. My mother donated me kidney, and now I am on only one kidney. But I work for 14 hours, and now also I work for 12 hours. My age is 68. Just now my mother, I lost my mother. But what he said is very true. So unless and until you have willpower, only one thing will, I think your life is more, everything is more, but willpower. If there is no willpower, then success is not there. Willpower, willpower and willpower. Thank you.
Ramya, anything from your experience?
Actually, I started, means after my fellowship, means after my PG, I took almost 5 years break. Completed my, means I joined the Contrast family for some time and started operating there with Srini sir. Then I completed my family. Then after 5 years, I went for my fellowship. I didn't regret now because it was, means I wanted to complete my family because we need a career as well as a family. So in that way we have to balance our work and life. It's very nice. And one more thing is, even now, means after this, we go for these socializing, all these clubs and all, and also for Zumba, dance and everything. This we need to meet some other people from other, not only doctors, other careers. So we have a rapport with them, and we'll come to know, we learn so many things from other people. So I think it's more important to socialize with other people, not only doctors.
I request Ragini ma'am to give a memento to Ramya. Thank you, and we'll move on to the next session on glaucoma. This session, the lead discussant is Shweta, and a really dynamic glaucoma surgeon now working in Jyotis Eye Care. She did her fellowship with Dr. Satyan from Coimbatore, and she's doing a wonderful work now. And Dr. Bindu Sajid, she's one of the senior most glaucoma surgeons in Kerala, and she does all sorts of glaucoma surgeries. She's excellent clinically, and she has developed the glaucoma department in Comtras Eye Hospital, Calicut to a great level. And Dr. Ronnie, he actually doesn't need any introduction, and my relationship with him is that we both wrote the DNB exam together, and the number of papers that he has and the skill he has unmatched. Equally good is Dr. Satyan. Satyan sir headed the glaucoma department of Arvind Eye Hospital, Coimbatore, and he is undoubtedly one of the top glaucoma surgeons in India. So Dr. Sujitra is the glaucoma consultant at Netra Jyoti, and they have different branches, and she's another great glaucoma consultant, and I request and Dr. Nabir. I mean, he is one of the young kids on the block, and extremely well trained and expert glaucoma surgeon. He's a glaucoma consultant in Abeta Hospital, Kannur, and I request Dr. Bindu to start her keynote address.
So good afternoon, everyone. I think I'll start the session. We are all used to making errors, but only thing is we have to learn from them. And in glaucoma, it's not uncommon to make errors. So we'll just go through some of the errors. Should I come there and do it? So sorry for that. So we doctors were known for our illegible handwriting, but yes, EMR and digital thing came to our rescue. But then still we are not away from errors. This patient was on two medication, but it was given as a combination drop. And then his pressures were uncontrolled, and on query he told he was sure that he is applying the medication. So it was a combination drop which was given, but then what was dispensed to him was a single drop. So if we did not ask him to bring the medication, what we would have done is we would have added another medication. So that is important in all glaucoma patients. Reinforce and ask them what they are applying. These are the common medicines which we end up in such mistakes, the Bidin T and Bidin LS, Mysop, Monosop. And yes, with the EMR, yes, we do end up in errors because these are very closely written, and we go and take the Gansigil or Gansivir instead of Ganfoot and then dispense it off. So that also nowadays we have to take care of. Now this is another patient. He was applying 3 medication, and on asking, he told he is putting it. And still the IOP high, again you think of adding another drug or switching to another drug. But then, proper history, he said he was drowsy with one of the medication and he used to skip that one often. And the other person, they are always scared of coming to us and put the drops just before coming to us. That is the time when you see the pressures controlled, but the disease is progressing. So, before jumping or adding to another drug, always check regarding the compliance factor. And we always target to the target pressure, and we never take care of the quality of life or the cost containment when we are prescribing to these patients. This is a study done by us at Comtrest, and we saw that depression, anxiety and quality of life in glaucoma patient is much low when compared to normal patient. And the compliance, most of them were forgetful, and the side effect of the drop was leading them to stop the medication. And there are also a large number of medication again that brings down the compliance. And to identify a non-compliant patient is the task that we have faced with. So these are the side effects that lead the patient to stop the medicine. It could be a hyperemia or the allergic dermatitis, or what we thought that prostaglandin is the drug which less complication is the one with the most. Now we commonly see all this, the periorbitopathy that is associated with the prostaglandin. And once it is not only the side effect of the drop alone, the preservative that is used to preserve the drop, that itself is a toxin to the eye. So the medicines with the preservative produce the OSD, which was more, and also patients on multiple drugs had this OSD. So when patient has an OSD, you use the preservative-free medications. And also, whenever possible, stick to combination therapy, because again it decreases the preservative load and also increases the compliance. So now, when we choose a drug for a glaucoma patient, not only take care of the drug property, like mechanism or efficiency, also take care of whether it is preserved or not preserved, and also the cost. And regarding the patient, you see if the patient can adhere to the medicine, is it available, and also does it affect the quality of the life of that particular patient. And for reminders, we do have newer gadgets, and also the mobile phone reminders can be used to increase the compliance of these patients. Now just we'll see some of the case scenarios. This is a patient who was on prostaglandin, but he developed a viral keratouveitis. So he was on Travatan. Now what we do is we stop that particular drug because it increases the viral. So we change that patient to another group of drug. And then the lesions after the lesions are healed, again the IOP also is getting controlled. So some of the other case scenarios which I thought I'll just show, when you see a glaucoma, you either think it is just an open or a close, but when you actually evaluate, it is much more than that. So this is a 40-year female referred as high IOP, and she was diagnosed as open angle glaucoma and was on 3 medications. So always your findings needn't be jarring and shouting to you. It could be also some subtle changes like this, a dilated vessel there. Again, on investigation, found to be a carotid cavernous fistula, which is an indirect type, and it is managed by intervention radiologists. Again, now we do commonly see most of bilateral acute angle closure glaucoma. Before doing a PI, always ask a history of treatment with some medicines. Most commonly, we find the topiramide. And also when you have a bilateral attack. And ASOCT helps you in picking up the ciliary effusion. And there are not only topiramide, there are many other drugs like the antipsychotics, respiratory, the sulfur drugs. They either push the lens diaphragm forward or ciliary effusion, or you can pupillary block to produce the glaucoma there, angle closure there. This is again a patient on multiple psychiatric drops. It even moved the lens forward, pushing the subluxation and causing a very severe intraocular pressure rise. And this patient even had a choroidal detachment. Here the pressures were very low. This is also again antipsychotic. So you have to talk to the doctor who is treating them and change the medication. That is the treatment. Stopping the drug is the treatment here rather than doing a PI. So even your Diamox, which you are giving to decrease the intraocular pressure, can cause this is the choroidal detachment in the periphery and the ciliary effusion there, bringing down the IOP to very low. Even that drug you have to use very carefully because you can get situations like this. So stopping the Diamox has reversed the condition. The CDs have resolved. Now not only closed angle, even drugs can cause open angle glaucoma. This patient, usually what you get a history is, they have a preceded upper respiratory infection and an oral intake of fluoxetine. What they present is a severe high IOP, and you see lot of pigments in the anterior chamber, behind the cornea, in the angle. And you have transillumination defects in the iris. It is the Bate or the Bardi syndrome. The Bate, these are literature, and you have the severe variety is the Bate and the less severe is the Bardi. So you have to take a proper history and treat before you jump into an open angle or pigmentary glaucoma. So these are the severe variety is the Bate and the less severe is the Bardi. Now the dilemmas which I face in my clinic, this patient presented with severe headache, the gonio closed, IOP high. Again, before doing a PI, do a B scan. Here, this was a multiple exudative detachment. This was a patient with VKH. A similar case, Unilateral, SLD on treatment, presented with pain, redness and a high IOP. You can see the shallow AC. Again B scan picked up the T sign and the ciliary effusion. This was a case of posterior scleritis presenting as angle closure glaucoma. And this was referred as orbital cellulitis with this is referred as acute angle closure glaucoma with severe AC shallowing and high IOP, hemosis, and on detailed evaluation, he had the ciliary effusion with CDs and high IOP, and on CT showed it was an orbital cellulitis with angle closure glaucoma. So this is a 34-year-old female who presented with IOP high. This is a high myope. In high myope, you always see a spherophakia. So you have to evaluate to see what are the causes are. Again, this is a female. This is a very interesting case. Presented with angle closure glaucoma. I did a PI. And then to surprise, see the fundus, you see a very dilated and tortuous vessel. So then I thought, yes, there's something else in this patient. Could it be a raised episcleral pressure, or could it be an anaphthαλmos? Worked accordingly. The axil length was normal, the B scan was normal. And then we went into a CT and MRI. To our surprise, it was a case of craniofacial fibrous dysplasia, which causes the venous stasis and narrowing of the orbital canal and the superior orbital fissure, producing the raised intraocular pressure. So these are some cases which I thought I'll show you. So a mistake is only a mistake if you don't learn it. Yes, we do end up in errors, but that are a learning lesson for us. Thank you.
Thank you, Bindu ma'am, for that wonderful discussion. So madam has mostly shown about the mimickers in glaucoma. So now my panel discussion, I'll be taking around the common scenarios which we get when we are sitting in a general OPD. We get lots of patients where we are all actually confused whether it is glaucoma or not, whether to treat the patient or not to treat the patient. Is it really glaucoma? So I'll be showing 10 case scenarios where, and we can also discuss with the panelist. Okay. So, coming to the first case scenario. So this is a patient who is a 48-year-old man who came for a routine eye checkup, and this is the most common scenarios which we generally see. So this patient had a best corrected vision of 6.6 and N6. His IOP in the right eye is 18 and left eye is 19. His ECT in the right eye was 530 and left eye 520. And on seeing the fundus, we can see that there is a 0.8 cupping in both eyes. It's almost symmetrical. And this is a fundus photo. So fundus photo of the patient, you can see that neuroretinal rim is very thinned out. It is a concentric cupping. And the left eye, this is the left eye. So this is the right and left eye together. I would want to know from the panelist how to go about this patient. First, I'll ask Dr. Sujitra. Ma'am, can you tell me if you get a case like this, how will you proceed? What is the best test?
Yeah, first I would like to do a perimetry for this patient. We will go with both 24-2 and even 10-2 so that we won't miss the central 12 degree. And I'll just keep a fundus photo and an OCT disc for future references. And one more thing is better to do a diurnal variation if a patient is from nearby places or he is comfortable. Talk to the patient and check the IOP in different times of your clinic. Ask him to come once in the morning and once in the evening. And after that, if everything is normal, I'll like to follow him up after 1 year or 1 to 2 years. And before going, you just make it clear to the patient that you don't have glaucoma currently. Otherwise, they'll be psyched out. Nowadays, glaucoma is, it is publicized so much, so he'll be like depressed. They'll be telling everyone that I think I have glaucoma, I think I have. That's the main thing. Before sending back the patient, we have just, the size is almost normal, 90%, this will be physiological cupping only. So that you have to make clear, and that's it.
So that is so true. We have to be sure that unless you're sure it is glaucoma, never start him on anti-glaucoma medication, because nobody is going to stop a drop which somebody else has started. Nobody stops a drop other than if you're very sure you're going to stop. So I would like to ask Dr. Ronnie sir to add your comments to this case. Ronnie sir?
Yeah. Can you hear me?
Yes, sir.
So it's a pleasure to be here, and yeah, this is an interesting case, and one thing that I would do before ordering an investigation is to just measure the disc size. So if it's a large disc, then very likely any large cup that you see is a physiological cup. And I would of course investigate, get a baseline visual field, get a baseline photo, and get a few intraocular pressures. Keep in mind that the boy is under 20 years of age, he's 18 or 19. And at that age, getting a normal pressure glaucoma type of picture is very, very unlikely. So this is most likely a physiological cup with nothing else sinister there. But make sure you get both baseline values and follow him. That's all that I will do, provided all the other investigations are normal. If he shows a defect on the visual field, I would definitely investigate for other tests.
So, is it an OCT that will go initially, or is it a visual field that, which test do you prefer in such cases?
If I'm going to look for any single test, it would be a visual field.
Okay.
Because what you're looking to see is functional damage. There's much greater anatomical variability in the optic disc than you get on the visual field. So if you don't see functional damage, most of the time it's just an anatomical variant and nothing more. The OCT is useful only from the long-term follow-up point of view. And keep in mind, this boy is young. So more important than the OCTs is disc photo. Because technology will change, but a disc photo will.
Okay, sir. Dr. Satyan, sir, do you have any change of opinion in that?
Yes, sir. Good afternoon and a wonderful meeting, and thanks for inviting me for this meeting. Basically, when you really look at the fundus, what you have done is a good job that you take a very good fundus photograph and then go back to your basics. Understand what is the disc size and what kind of a shape the disc has. Along with that, what kind of a cup you have, and depth of the cup and all the signs of glaucoma. And also see the corresponding neuroretinal rim area and also the NFL loss. So if you can really understand the very basics and try to have the both fundus pictures together, and then first analyze that first before you go for anything. Then of course you have the OCT. OCT doesn't mean that you just take one OCT and then you look at the green signs and the red signs. That's not going to be the good one. But if you can understand the basics of OCT, go back and see how is the BMO, MR value, and whether the OCT is properly taken or not is the first thing. So, especially when you have a patient like this where you feel there is a suspicious appearance, then your basics are going to be the primary thing that you should focus on. And of course, your intraocular pressure levels, how good is the measurement done, and how the measurement is done. Is it an NCT measurement? Is it an eye care? Is it an appellation? When was it done? Think about the diagonal fluctuations. Look at the family history. Everything, it is not that once you have a suspicious appearing disc, then of course you need to have a very elaborate things to be seen. If you have a very high IPF, of course things becomes much easier. So looks like a suspicious appearing thing, then you have to go methodically all the possible things. Go to the basics first.
Okay, thank you, sir. Slides, please. So this
because
patient,
we are not able to see what has been projected clearly from here.
Okay.
Because of the bright light, we can only see there is a fundus photograph that much only I can see. Yeah. The large disc with a little bit of thinning of the neuroretinal rim is absolutely normal. And as long as you have a good RNF and you know how to see the OCT in a large disc, then you should be able to pick it up.
so this was a visual field of the patient. Next slide, please. Next slide. So this is the right eye of the patient. You can see that we have only few scattered areas of depressed sensitivity. And left eye, it's also only in the inferior field you have an OCT when you see. So this in the right eye you can see that even though JCL pattern, there is a thinning in the GCL, but still it has the donut pattern. So MRW it seems to be little thin, but RNFL it's almost normal, and the GCL also doesn't have a proper glaucoma pattern. And in the deviation map there are few changes, but we cannot say that it is very definite of glaucoma. In the left eye if you see, it's almost similar picture, and the GCL and the RNFL deviation also do not say that it is, but we need to follow him up because right and left eye shows little bit of thinning inferiorly, but it's not definite of glaucoma. Just go on, see the diurnal variation and have a baseline and then follow him up. So next case scenario. This is a patient who is a 32-year-old lady. She is a foreigner who came for a glaucoma evaluation. She was from UK. Her vision is 6.6 and 6 and there is no family history of glaucoma. She presented with an IOP of 32 in the right eye and 28 in the left eye, and CCT being 560 and 556. So previously from there when they checked, she had similar IOPs of 30, 28. And this is her optic disc. Both eyes we have a cupping of about only 0.2. And her OCT was completely normal. The rim with the RNFL and the GCL in the right eye and the left eye, both were normal. And the visual fields also were normal. So the thing about this patient is that we do not have follow-up because she's going to go back and then we do not know when she's going to come back. And she keeps telling us about this IOP previously. So how exactly will you go about in this patient? What all history you elicit, and do you treat and not treat? Because the IOP is 32. Dr. Nabid? Okay. Dr. Bindu ma'am?
Known risk factors like systemic disease like hypertension, diabetes, or refraction. Again, all this cardiac, because again if IOP is very high, young vascular occlusion can be a complication if you neglect it. So look for other risk factors also, because cornea is thicker.
Okay.
So thin cornea again.
So can we watch this patient or should we put her on any anti-glaucoma medication?
At least if she is going abroad, she should be able to review there. Okay. If she can do a follow, close follow, yes. Otherwise it's better to start if it is actually above 30. The recommendation is you start.
Generally up to 28 millimeters we say we can wait and watch if there is thicker CCT and a normal field and OCT. Satyan sir, any comments on this?
Yeah, Sweta, first of all, yeah, a little bit more on the history will be very useful, like you see on any steroids, okay? So very common to have steroid responders. Even a patient creams, what she's applying, especially when they're abroad, they use a lot of creams, cosmetics. So that is one thing which, and then second thing is the family history is also equally important. So the first thing is go with the basics again and again. Age, IOP measurements, the risk profile that the patient has, and IOP at the time of your examination. So if you will look at the IOP, you feel is 32 and 30. That is so thing definitely both eyes are there. How old is the patient?
32-year-old.
32. So definitely the age-wise is quite young. Because it has to, life expectancy is quite long. And having an IOP of 30 plus is definitely a thing that you have to probably treat them, provided that you rule out all the secondary glaucomas first. So that will be my approach. If it is a primary like ocular hypertension, provided that the only thing is for me the OCT, the what do you call the posterior pole appears to be much thicker. It's quite surprising to see the thickness of the posterior pole. So that is one thing is concern. But otherwise, if it is 30 plus, even if it is ocular hypertension, ruling out secondary glaucoma, probably you should treat it.
Okay, sir.
And I'm going to have a follow-up over there.
Ronnie, sir, do you want to add any comments?
Yeah, no, I agree with Satyan in terms of once you rule out the secondary glaucoma, I would also consider treating more so also because if you look at the fluctuation, just on a diurnal itself, she's fluctuating more than 6 millimeters, which means she's probably crossing 30 sometime during the day, multiple times during the day. You're much safer keeping on treatment. I would consider an SLT if it's available. And considering that she's going to UK, once you label her as an ocular hypertensive, she will be under good follow-up there. It's only important that she gets into the system.
Okay, thank you.
But can I just add one thing, little bit on Ronnie's comments? Ronnie, would you like to really go with the SLT in this young age group?
Yeah, so it's a little
or you would like to kind of postpone for some time until it becomes 40 plus or whatever?
So it's a little controversial in a young person whether we need to do an SLT or not. So if she had established disease, I would hesitate to do it because that usually means by that time your mesh work is terribly compromised. Since she doesn't have established glaucoma, you're looking at an early increase in IOP. So I would actually consider an SLT in one eye to look for a response because SLTs typically do better when the patient has not been exposed to any glaucoma medication. So if I see a good response, anyway we're planning to treat. So if I see a good response, I can delay the treatment by a little bit. If I don't see a good response, anyway I'm going to keep a patient on medication. So that was the logic here. If she had an established field effect, I would hesitate to give an SLT at this point.
Shweta, one second. There is a car blocking the way. I'll just one second. KL13 AH 3893. If it belongs to anyone here, KL13 AH 3893. Thank you. Sorry.
So we'll move on to the next case. So this is one of a common scenario which we see. This is a 66-year-old male who had come for a cataract evaluation. He had best corrected vision of 636 N18 in both eyes, and he had IOP of 14 in the right eye, 16 in the left eye, and there was a cataract for which he had undergone a cataract surgery. But only after cataract surgery, his vision was 66 N6 and IOP 12 and 14. Then only we have seen that he is a disc suspect. So his fundus in the right eye had a cupping of only about a 0.4, but in the left eye you have 0.6 to 0.7 cupping with an inferior notch. So this is his OCT in the right eye, which is completely normal. And in the left eye you can see that inferiorly you have the rim thinning, which you can see in the top. And there is an RNFL thinning inferiorly and corresponding GCL thinning in OCT in the left eye. And visual fields was done in the right eye, it was normal. Left eye you can see corresponding area of superior scotoma is there, arcuate scotoma. And when such patient come to you, so now his IOP is only 14 and it is a unilateral glaucoma which you see. So do you start treatment at this point of time is what I wanted to know. Dr. Suchitra ma'am.
Here I would like to start the treatment based on this thing post-op, how long it is been. If it is more than 3 months or something, I would start with a single drug. And before that I would like to do a diurnal variation also, since it is IOP is 12, 14, I want to see at what time whether IOP is fluctuating more than 6.
Okay.
So maybe we can start unilaterally and then slowly we can start the other eye based on the response and how he is able to tolerate the drug.
Okay. Dr. Ronnie, sir, can you give your comments on this case?
Yeah, so this is a bit of a challenge because you don't know what the gonioscopy findings were like before surgery. So if this was basically under closure, then you may actually be able to delay starting treatment for a while because you may have corrected some of the pathology with that. We also know that cataract surgery on its own for short term can sometimes reduce intraocular pressures for a bit. So if we have gonioscopic findings before, or if you notice synechia in the angle, then you can probably delay surgery a little bit if you suspect it is closure. If on the other hand there's an established defect and you don't have access to gonioscopic findings and the angles are wide open, you could consider treating the worst side.
Satyan sir, your comments on this case?
Sweta, I couldn't see any of your slides.
Sir, it's an incidentally detected glaucoma after cataract surgery. So we do not know how his eyes were previously. And his one eye is completely normal. The other eye has an early to moderate glaucoma. So, and his IOP was 14.
1-4.
Pre-op IOP was 16. So we do not know whether this is an primary or secondary glaucoma.
Okay. So when you really look at the fundus photograph, and if you can really see the pattern of ulnar loss, if the ulnar loss is kind of close to the temporomacular bundle, then possibly we are looking at the anti-G pattern. So that will be a good clue for you. Or if there is a significant change, then possibly we are thinking about past history through the gonioscopy and see whether there is any angle recession or traumatic glaucoma you can look at. Or it could be even a steroid-based glaucoma, secondary glaucoma is always unilateral secondary glaucomas we have to rule out, and a possibility of MTG that you will have to see, provided that it is a definite glaucoma.
Bindu ma'am, any comments on the case?
Do you have the fundus photo?
I have the OCT. No,
Okay.
fundus of the OCT.
You don't have the gonio and the...
It was an open angle, sir. It was an open angle both eyes.
Okay, open angles and fundus picture is not there, right?
Fundus.
So if you really see these fields, I'm not sure whether I am correct or not. Look at the fields, that is the left eye. Is it the left eye is the one affected?
Left eye is the one affected. There is a
Is it
superior.
close to the
It is closer.
central 10 degrees?
Center 10 degrees are affected. Few areas are there in the central 10 degrees.
Okay. I'm just assuming, with my thing, I'm assuming that it is central, but if it is so, then we are probably looking at more of an anti-G pattern.
Okay, so my question is, do you start the medication immediately or do you want to follow him up for some time and see whether there is a progression and start?
These patients, see, once you have a very established glaucoma, then I think it is better you do the diurnal also in these patients. But this is definitely with the typical fundus binding and typical visual field damage, then you just try to understand how the patient is doing. Post-cataract surgery, sometimes that could itself be a beneficial thing for the patient, lowering the IOP. So it is not that you have to treat by immediately. Do the diurnal also and observe the patient for some time because the damage is not too severe. But this is very dicey situation where you really want to treat or you want to observe, but nothing is going to happen overnight. So we can always track the patient and see how the disease is progressing, especially NTG is not going to be overnight process. So we can rule out other causes for the NTG like sleep apnea, cardiac problems or carotid vascular studies. If you feel it looks more like a glaucoma, first thing is rule out the secondary glaucomas. Second, it looks more like an NTG pattern. So along with that, you go whatever you want to do.
Okay. This patient I am seeing for the past 3 years. It's almost stable. So I haven't started the treatment, so I just wanted to know whether to treat or not.
Yeah, if there is no progression, I don't think you need to treat. Once you are following the patient for almost 3 years, it's a good time that you are seeing the patient. Once there is no progression, it is fair enough that you don't have to really go and treat the person.
There is no definite evidence of progression, but I have done OCT, visual fields. I do not have that progression chart in the visual fields. But still, there is no progression in the visual fields too.
Okay, then you can really observe that.
Next scenario, whenever you get an angle closure disease, so how do you, if there is a thick iris, what next? When you get a PAC patient with a thick iris and you get an acute angle closure glaucoma patient which you are not able to do a PI, both scenarios, what you will do? Bindu madam?
And pilocarpine and PI, if I haven't taken any patient for surgical PI yet.
And do you do a green laser first and then do a YAG on top of that?
I haven't done it yet.
Okay. Ronnie sir?
Make it a little atrophic in the first attempt and then repeat it again.
Repeat it. Ronnie sir, when you have a thick iris.
Yeah, I agree with Dr. Most of the time you can get away with
two
it
sittings.
might take a couple of attempts, but you can. The only scenario where I use the combination is when there is a neovascular glaucoma with a narrow arrow that I need to get through, or a post siliconoid glaucoma. Those are the two situations where doing the combined process helps. Otherwise, the YAG you'll get through in one session or two sessions.
Okay. Satin sir, do you want to comment on?
Yeah. Usually, if you can keep the lens and do the PI, most of the time you can do the PI. But only thing is, different people use different coagulation machines. Sometimes it is a little difficult with your upper semi machine because the energy levels are a little higher. I think you might sometimes blast. But having a size type of size or the rider, the YAG is much more precise with the 4 dots. So you can usually use the lens and then you can do the PA most of the time, provided that the corneal edema is not much. But even if you have a corneal edema, once you put 1 drop of glycerin, usually the corneal edema will come down. Only thing is when you have a too thicker an iris, sometimes you really may not be able to do that. In that very rare instances, one might try out using a organ laser to start with. Once you have a little bit of a pupillary distortion also, the pupillary block will go off. But it doesn't mean that once you have thick iris, you do that kind of thing in every given person. Don't do that. But most of the time, like what other people say, is that you just get away with few shots of YAG itself. Only when in a very, very rare instances, one might look for doing a surgical PA. But that is going to be very rare instances. So far, I haven't even taken probably maybe one in my entire period of practice to take the patient for a surgical PA. Most of the time, you can do the YAG PA.
Sometimes we get reference for cataract surgery for an acute angle closure glaucoma. Any points on that? We do get referral for cataract surgeries.
But acute angle closure glaucoma, I don't think I'm going to do just like that, I'm going to do the YAG, IY. Always make sure that eye is becoming quieter and observe the patient when the patient is having still a higher IOP or IOP has become normal. Till that time, I don't think I'm just going to try and only remove the lens and then get away with but it is not the way we go with it. Always try to see how you can control the IOP and control the inflammation first.
Okay. The next scenario, another common scenario which we see is you have IOP in low teens, but the visual field progression there is a definite visual field progression. This is not a proper case, but I just want to discuss the topic on when you have a visual field progression with the low IOP, what all do you investigate in further? Dr. Nabeed?
Actually, there are few things we need to look into it. One is either patient is adhere to treatment because most of the time, like patient may not take they may be missing drops. They may be missing drops in between. So that is one of the most common factor actually. It's published literature also same thing. Almost most of the patients, like if you prescribe for many patients, only 30 to 40% people are correctly adherent to the treatment. That is one thing we need to look into. Another factor is like it is like actually glaucoma or not. Actually, that is one more thing we need to look into. Then any systemic factors like sleep apnea, then any vascular dysregulation, these are the things we need to look into.
Ronnie sir, your comments on this situation?
Yes, I agree that compliance is one thing that you need to look at very closely. The second issue that you need to look at is what was the baseline pressure. So if your baseline pressures were high and you're dropping IOPs to the low teens and you're still seeing progression, then you definitely need to investigate to find out what's happening. But if your baseline pressures were like 15 or 16 and the patient already was NTG and is progressing, then you just need to be a little bit more aggressive about your therapy. So if you are seeing unexplained progression in spite of good compliance and what you think is your target intraocular pressure being achieved, then you would need to definitely investigate. One of the things I think which we need to look at closely is whether the patient is actually hypotensive, whether the patient has systemic hypertension. Are they on high doses of antihypertensives? Getting a 24-hour blood pressure monitoring is often helpful because you'll find that some of them are nocturnal dippers and their diastolic blood pressures drop to 30 and 40. And at that time, you can actually get increased visual field damage in an eye which is susceptible. If they are on 9 doses of antihypertensives, take it off. Getting a carotid Doppler is a good idea because if they are having a significant blockage on the carotid Doppler, it can be indicative of more proximal damage closer to the optic nerve also. So these are the two things that I would look for, and that if both of these are negative, before that also do a color vision, because if you see a color vision change, you may be dealing with primary optic nerve pathology rather than a pressure-related pathology.
Also, just to add one more point, Sweta, in this is look at whether the patient they do any kind of sirasasanas or exercises may also be really helpful. Okay. Compliance, exercises, cardiac pathologies, sleep apnea, carotid blockage, all this will really help you to understand the patient better. It is not a single factor sometimes, it may be a multi-factorial also.
So we need to spend more time with the patient, take a proper history, do a proper evaluation. The first thing is compliance. The patient will say that they are using the drops, but ask him indirectly. You can ask how many bottles, when did you last buy the bottle. We know that it won't go more than 1 month. So that is the most common, and the rest of the systemic evaluation is also very important. We'll go for the next scenario. When you have a patient, you're on treatment for glaucoma and you detect a splinter hemorrhage, and the patient's IOP is under control, under your target level, what you have fixed previously. What do? Do you investigate further? Do you reduce the target IOP? Can you comment on this, Dr. Bindu ma'am?
I think this is similar to the previous discussion only. The same factors like other associated like nocturnal hypotension, sleep apnea, all this has to be looked by the disease is progressing, any other vascular abnormality. The same it just goes on the same.
Sujitra ma'am, you would like to add something?
Yeah, definitely now fiber layer hemorrhage indicates there is progression of the disease. So again, I check the correct IOP, and if it is really in low teens, I would like to add one more medicine. If he is not for regular follow-up, or if he is on one medicine, I would like to add one more. medicine, so that there may be some IOP fluctuation which we are not noticing.
Satyan sir? Getting a splinter hemorrhage in glaucoma.
Yeah, it is almost similar to what we have discussed earlier. Once you have the recurrent hemorrhages, we have to keep on searching for the cause. So one is, as we mentioned about the compliance, but most of the time it may not be that the compliance itself is the cause for the disc hemorrhage, but there is a continuous pathology going on. So we have to keep on observing, but sometimes it is not easy for us to pick up in one visit. Over a period of time, we may be able to pick up the cardiovascular disease or a coronary disease or sleep apnea things. It's not one visit that you can kind of identify everything. Only thing is, we know that the disease is not stable. So you try to see whether the medication is working or not first. Sometimes with the IOP levels, we might be thinking that patient is having say 16 or 17 IOP, we might think it is normal IOP levels. But once you really see that the drug is effective or not, even the baseline could have been 16 or 17, so the drug is definitely not effective. So in those cases, probably if we are looking at the vascular part of it to some extent, the carbonic anhydrase inhibitors might be of some use in that way. So we can look at that.
We'll go to the next scenario. Okay, this is an interesting case who is a 60-year-old lady who came with a complaint of defective vision. Best corrected visual acuity in the right eye was 612 and left eye 636, and she was started on AGM elsewhere, and her IOP in both eyes were 18 millimeters of mercury. These are fundus photo. And OCT in the right eye, you can see that there is a temporal RNFL thinning, and you can see that the GCL pattern, it's a total thinning of the GCL. It's not the snail track pattern which we see in glaucoma. And in the left eye, there is symmetrical thinning of the temporal RNFL as well as the GCL. And if you see at the RNFL deviation map and the GCL deviation map, you see there is a papillomacular bundle thinning and there is a GCL thinning. So how do you go about with this patient? Ronnie sir?
Well, I would first do a visual field, because you are seeing temporal defects on the OCT, and you would really like to see whether this patient has any sort of visual field defect. Do a 10-2, do a 24-2C to look for any central defects. And to me, this sort of a pattern is not typical of glaucoma. You are looking at something else. It may be nutritional, it may be alcohol or tobacco related, it may be something else altogether. I would definitely consider stopping the medication, at least in one eye, doing a reverse trial to see what sort of pressure difference I'm seeing, and I would investigate for a non-glaucoma discus.
Satyan sir?
Yeah. So the OCT, first thing is the vision. Is the vision improving with the glasses? Is the one thing which we have to really look at. So that gives us an indication whether there is glaucomatous or not glaucomatous. The vision is not improving with this kind of a cupping. Definitely this is possible, not a glaucomatous thing. And it's a very typical sign, that temporal sign, that is called as a temporal sign. And you see that typically the papillomacular bundle is getting affected. And also if you see the posterior pole, that is called as a red circle sign. So the temporal sign and the red circle sign of the papillomacular bundle is getting affected. So typical of either toxic optic neuropathy or a nutritional optic neuropathy. So we'll have to just go and see the history, color vision. These two things will help to identify. But this is, for me, it is almost like a neurological than the typical glaucomatous appearing. It's a very classical sign, actually.
Any other comments from the other panelists? Okay. So we do see patients who are wrongly diagnosed as glaucoma coming with an anti-glaucoma medication. We need to investigate further for this patient whether there is any neurological or toxic or nutritional
Sometimes just looking at color vision also gives
Color
you a-
vision is really important in this patient. There's a templar pallor. It can be anything, optic neuritis, multiple sclerosis.
I remember this patient having probably an ethambutal toxicity. I'm not sure.
Yeah,
The same patient which
this
you're
patient,
discussing.
yes, it was a patient whom we have seen there together, sir. So it was an
Yeah,
ethambutal
yeah.
toxicity. So the patient came back late. Like she had lost her vision 6:36. It was not improving. It was ethambutal toxicity. So another question is.
I remember this patient, and sorry to say that she is no more now.
So the next patient, next question is, how often do you do 10-2 or an M-dynamic program in early glaucoma? We know that we do it in the advanced glaucoma, but in early glaucomas, how often do you do? Dr. Nabeed?
Most of the time I do 10-2 in almost all the patients. Actually.
Early glaucomas also.
Early glaucomas also. Mostly we need to concentrate, like if it is RNFLD zone closer to the macular area, usually we will get the defect actually. Usually. But
Sujitra ma'am, do you also practice doing the central fields?
I also do in all the patients. Okay. And I think in early glaucoma, I do it once in 6 months.
Okay. So, Ronnie sir or Satin sir, do you have to comment on this? Because generally we see that we do only 30-degree fields, but the importance of the 10-degree fields, can you just explain it?
I think it's very important to do 10-degree fields since you are looking at the macula in greater detail. You are looking at points which are 2 degrees apart. For us, for logistic reasons, we can't do it for every patient with early glaucoma, but anybody with a deep defect or a defect which is closer to, or a deep notch which is more temporal than inferior or superior, definitely we would ask for a 10-national addition or do a 24-C, which has additional central points. So it's very, very important when you see somebody with a defect or a negligent defect or a notch where you don't see anything on the 24-2, do a 10-2 because you may actually land up picking up a defect on that.
Yes, with the same comments, but only thing is in a Humphreys pattern is little different, but with the new Humphrey pattern it is almost similar to the octopus pattern. But when you do with octopus, the central macular area is very well established in the octopus visual fields. So doing a central 10 degrees is, you have the macular program. So that is again pretty useful, but in reality most of us we really don't do in every given patient. But it may be useful in quite a good number of cases.
The next scenario, when you have a myopic patient, a patient with such a fundus, so you're always confused whether this is actually glaucoma, whether it's an early moderate glaucoma or a severe glaucoma. It looks like a severe glaucoma when you see the fundus photo. So when you have high myopia with glaucoma, there is difficulty in seeing the RNFL, whether to do, you have the myopic progression. The disease progression is also happens, and it can give the visual field defects too. So when you have such patients, how do you exactly go about with these patients? Sujitra ma'am?
So at first we have to see the age of the patient, family history and CCT, and carefully look, do a fields also, and correlate the disc with the fields. And this will be your baseline fields. With the, suppose if you have a infronasal thinning, you might have a temporal scotoma, and keep it as a baseline. And if the IOP is within normal, within low teens or something, you just follow him up regularly. That's the only thing I practice. And slowly, if the fields are progressing, then I say go back and look at the disc and see whether that defect is increasing, and keep a baseline fundus photo, disc photo also. So if it is progressing, then only start medicines. And if there is family history of glaucoma and other risk factors, especially if any siblings are having glaucoma, that goes more in favor of this patient having glaucoma, then I'll follow him up, him or her more frequent.
Satin sir? So is there any role for OCT in case of a high myopia?
Yes, Shweta. It is very interesting and very important also, because the OCT definitely gives you, if you have done a good OCT and if you have really picked up all the Brooks membrane opening points. I'm not sure how many of you have seen one of my videos, like how you really pick up the clinical disc margin versus the true disc margin. If you can really pick up the disc margin by doing the OCT by looking at all the BMO points, then many times you can really mark which is the true disc. Once you know the true disc, then it is easy for you to really pick up whether the patient has glaucoma or not. That is quite reasonably we can pick up. So OCT definitely helps you to identify where is the true disc margin, and accordingly you can see the curve. Once you, if all of you have some time, you can just go through the spectralis OCT, the PDF, how you really see the myopic disc, then it is quite useful for all of you. So just look at that. So once you have that, then many times we can pick up, but it is not that easy like what I'm saying. Many times you still may not be able to really assess, but it is again, as I said earlier, it is not like overnight you can really assess everything. Of course, your IOP, other risk factors, everything will help you out to identify whether the patient has glaucoma or is there a progression in these patients.
Ronnie sir, any comments on that?
No, I agree with Dr. Satyam. I mean, the advantage of an OCT in addition to whatever else you're seeing is that you have one more way of seeing, looking for change. So if you see a change on the visual field and on the OCT and the fundus picture is looking exactly the way it was before, you know there is probably some amount of progression. In addition, I would also consider doing serial disc and fundus photographs, because sometimes it's difficult to pick up subtle change on the retina and compare it to what happened in the previously. Myopic discs are always a challenge, especially in association with myopic retinal changes.
Even acquiring the OCT for the myopic patient is also difficult, but as sir said, the true disc margin and the clinical disc margin in myopic patients, we have seen that it's completely different. So it gives us more idea of what exactly the disc is. So we need serial fundus photographs, we need serial visual fields, and we do need serial OCT images too. And the next case scenario, and this is a patient of 65-year-old male with a vision of 6.9 N6 in right and 6.36 N12 in left, and IOP is 20, and his right.
Can you share your screen? I think I can't see the slides. I'm not sure if Satyam can see them.
No, I'm not seeing. I'm just imagining.
Okay.
Imagine that it is like that.
So I think you need to pin the screen.
Your video is actually off.
Yeah, in the screen.
The screen is showing the video off actually.
Yeah. The screen, the slides are not seen. We can see our own image, and we can see the panelists now.
There seems to be some issues.
Please send us some copy also.
The CME co-host is showing us not sharing the screen.
So this basically, I think I'll just tell you the case scenario.
Yeah, just go ahead.
So this is a case of advanced glaucoma, both eyes. One of the eye has only a slight temporal area of vision, and the other eye has a biarcuate scotoma, which is equally bad. There is only tubular vision. So he comes with a cataract checkup, and he has an IOP of 20 millimeters, and he's on 2 medications. So generally when you have an advanced glaucoma with a cataract, many of us are a little scared on operating such patients. What is the best thing to do for that patient? Whether go for a trabeculectomy first, or do a combined procedure, or do a cataract extraction? What would you suggest when you have a patient on 2 medication, IOP of 20 millimeters, and advanced fields both eye? Ronnie sir?
Yeah, so somebody with a visual field like you have described with an intraocular pressure of 20, you've obviously not reached your target intraocular pressure. Your target intraocular pressure is going to be significantly lower than this. So if you're going to achieve that, you have to either add a medication or think in terms of surgery. So I would actually consider doing surgery, possibly a combined glaucoma and cataract surgery at this point in time, because one thing is that if they're an open angle glaucoma and you decide to do only the cataract with this amount of disease, you may land up with a steroid response also, which may make it a little bit more difficult to manage later. You don't have much of a buffer in this patient to wait and see. So that's what I would do. But if your patient is very willing to come for follow-up and you're able to follow up closely, and he understands that you may need to do an urgent trabeculectomy after the cataract, that's the second option. But for me, the first option is probably the safer option.
Satyan sir, do you agree with Ronnie sir?
Yeah, yes, definitely yes. I think your question was mostly on whether the patient is going to have a snuff out.
Yes, sir.
That is going to be one of the things that you wish to ask. But in general, when these kind of patients come with IOP of 20, with the 2 medications and the cataract, once you are sure about your own surgical skills, I think you should go ahead. Or if you feel that you don't have the skills to operate on this, I think we must send the patient to whoever has the skills to go with the combined procedure as the first choice. Because once you do only cataract, definitely these patients will have a significant amount of steroid response. Even if they don't have a steroid response, they do progress. Though you might feel that doing a cataract alone will reduce IOP, but may not be the amount of IOP which we really expect. Probably once you feel this advanced, definitely we are looking at somewhere around 10, 12, something like that. But when you have a 20 with the 2 medications, cataract surgery might just reduce only around another 2 or 3 millimeters down. But that's not going to be enough. So you have to go with the combined procedure. I think we all have a reasonable amount of skills to go with the combined procedure. But you have to really explain the patient the possibilities of having the snuff out. But in general, most of the time we don't really see. Even if the patient has a problem initially, many of them will get back to their good vision by a month or even 2 months. I've seen one of my patients having only hand movements for 3 months. That was a nightmare for me. But then after 3 months, suddenly one day he came with a 6/6. So even checking the vision, you'll have to be a little careful whether the staff, sometimes they put a one-day pinhole and see. In advanced glaucoma, sometimes you put a pinhole. The patient might have only a temporal field. So they may not be able to read anything. So you'll have to check the vision also properly. So in one eye, I can see that possibly the patient has only a temporal field. So you'll have to be careful, explain the patient in detail, and then take them up for mostly the combined procedure.
So when generally we see with an advanced glaucoma, we tend to put them on additional medication and then keep the patient on follow-up. But we have to know that if we do not achieve the target IOP, the patient is going to lose his vision. So doing a surgery will do more benefit than waiting. So if you're not confident, please do refer the patient to seniors. So that is what I want to tell. So this is the most common scenario which we see because we generally...
It is not the seniors, it is who can do the surgery.
Okay, sir. So I think we have, so another thing what I wanted to show you is the GCL, how it is important when you are planning a surgery. Once you have that nasal GCL, these are all patients who have 0.9 cupping. Once you have that nasal GCL and little bit of a papillomacular bundle which is left, the patient tend to gain vision after cataract surgery. But once the last scenario where you see total loss of GCL, those patients generally they do not do well after cataract surgery in terms of vision. The improvement of vision. Once you see that nasal GCL and the papillomacular bundle, you can have little more confidence in doing surgery for those patients. Generally we see that OCT is not useful in advanced glaucoma. That is why I am specifically putting some pictures of the Heidelberg OCT. I do not have any financial interest, but I just want to show that there is use of OCT in advanced glaucoma too. And my last question will be about neovascular glaucoma. So, neovascular glaucoma is something which all are confused how to manage these patients. So, when you have a patient who is an active case of NVG, he has an IOP of around 40-45, and there is an inflammation, and the patient is coming with a cataract. Neovascular glaucoma, cataract, and a PDR, but you do not have a vision, you do not have what do you say, for laser you do not get the view. So what is the line of treatment that you would suggest for such kind of a patient with NVG, cataract and uncontrolled IOP? Bindu madam.
What we do is intravitreal anti-VEGF, and then immediately when the IOP is high, you admit and do a paracentesis also to bring down the IOP. During that time, wait for 3-4 days, and then go ahead with combined procedure, and then also immediate retina consultation if they want to do a laser.
By combined procedure, you mean cataract with trabeculectomy or valve?
If the angles are closed, definitely cataract with trabeculectomy.
Okay. Satyan sir?
Yeah, once you have seen an active LVI, I would definitely not go with the immediate surgery. I would rather give a anti-VEGF first, because anti-VEGF will work immediately. Within 24 hours, we can see that the vessels will disappear. And then just give them, kind of a week or so to see how the IOP is getting controlled. So many of them will have a definitely reduction in the IOP, but once you have a safe levels of IOP, then you can look at, see, one of the indications for primary tube is the NVG. So you see that IOP is getting controlled, inflammation is getting controlled, then you take the patient for a surgical option. But definitely these patients will do very well than what we all started doing as a PG and just consultant. That time there was no anti-VEGF, and it is mostly like a painful blind eye how we treat. But today with the anti-VEGF and a good amount of laser, the patient will do very well. Even sometimes we get even 6/12 6 vision also, provided that the disc is reasonably there. The cupping is not much. So they will do very well. Anti-VEGF, PRP, combined procedure, mostly like with the AGV, definitely the patient will do better.
So when is the ideal time to do a surgery? After the anti-VEGF, how long should we wait for surgical procedure if it's a closed angle?
So whether it is an open angle or closed angle, it's going to be the surgical size definitely be there. So see, in a closed angle, it doesn't mean that you will not be doing a tube, because only when you have a completely closed angle, IOP is going to be so high. In the open angle glaucoma stage of MVG, once you give the anti-VEGF and do a PRP, many times they will reasonably settle down with medication. But it doesn't mean that every patient will settle down. They also will require a tube, or sometimes even a trap will work in them. But once it is kind of uncontrolled, then you have to go with the tube. Because you can just go underneath the iris also, you can put the tube if you think that it is going to touch the cornea. So it's just how you do the surgery rather than whether you do this procedure or not.
Ronnie sir, your comments on the NVG and cataract?
Yeah, so there are two things. Like Dr. Satyan says, if the angles are open, sometimes aggressive anti-VEGF and laser will help. The second situation is where there is no view to the fundus, either because of corneal edema or because of the cataract or because of a vitreous hemorrhage in association with all this. So if you have a vitreous hemorrhage, then you will not be able to go with laser, which is ultimately the definitive treatment required. So then one of the options that you have is do off the anti-VEGF, at the same time try and do an active retinal cryo, and 3 to 5 days or 3 to 7 days after that, you do the glaucoma surgery. Because then you have some time for the cryo and for the anti-VEGF to kick in, and you may actually be able to take care of the neovascular process. Keep in mind that if you're planning to do a PRP soon after your glaucoma procedure, you're probably better off doing a tube than a trap. because you can get effusions post aggressive laser and that can impair your trabeculectomy. And if you're planning to do trabeculectomy, then make sure that the patient is there for follow-up, because these are eyes which require 5 FU, need releasable release, very aggressive follow-up. And if they're not available to you for follow-up, then the trap is very likely to fail.
Thank you, sir. So I think we are running out of time. We have taken more than 1 hour. So I am thanking the panelists for giving their valuable insights in the topics. We started from the glaucoma suspects to advanced glaucoma and neovascular glaucoma. So I hope you all have some take-home points which you can use in your day-to-day practice. And thank you, Srini sir, for the opportunity.
Satyan sir, you're there?
Yeah.
You're proud of your student, right?
Thank you, Sid. Thank you so
And
much.
thank you,
Yeah,
Ronnie.
of course.
Ronnie is my dearest friend, so you would agree for joining any of my programs. Thank you, Ronnie. Thank you, Shweta, for that wonderful discussion. Thank you, Bintu, Nabit, and I request Sir to hand over a memento to Dr. Bintu first.
Thank you, Srini, and the entire team. Thank you so much.
Dr. Lahane sir is here. Hi. he sat through. He sat through all your the full session, intently listening.
Thank you, Lahane sir. Thank you so much.
Thank you, sir.
Thank you.
I also do glaucoma. So many patients come in the 0.9 stage. So I was just seriously listening to you both. Thank you.
Thank you, sir.
Thank you. Dr. Sujitra. Dr. Nabit. And finally, Dr. Shweta. A big thanks to all of you. Biggest thanks to Sir for coming all the way from Mumbai. You made our day, Sir. Thank everyone. Thank my staff, the audiovisual team, the hotel, and definitely our sponsors. Thank you. Thanks a lot.
It was very good.